The pre-contrast imaging, other sequences like chemical shift imaging, that is OP and IP imaging, which is in-phase and out-phase imaging. In these images, we can demonstrate the intracytoplasmic fat. So MR, in addition to the extracellular agent sequences and hepatobiliary phase, which is 30 minutes after the contrast, LRNC. Definitely benign is LR1, probably benign is LR2, intermediate probability of malignancy is LR3, probable HCC is LR4, definite HCC is LR5, LRM is definitely malignant, but it's not necessarily a hepatocellular carcinoma, and tumor in vein is LRTIV. Now there are 4 steps in the application. That is, the first step is apply the CT-MR Lyrate's diagnostic algorithm. The second step is applying the ancillary features, which may be divided into benign and malignant ancillary features. Step 3 is apply tie-breaking rules if needed. Step 4 is the final check to know like whether we assigned a correct category. If we feel we did not assign correct category, we can go back and reevaluate. Now in the step 1, the untreated observation without pathological proof in patients at high risk for HCC. Lyrates uses the term observation than a lesion because a abnormality which is distinct from the background liver parenchyma as an observation. So these are the 8 categories which I already discussed. So the second step is applying ancillary features. There are few benign and malignant ancillary features. So for category adjustment, upgradation and downgradation, applying these ancillary features. For example, if there are 1 or more ancillary features favoring benignity, then you can downgrade the lesion from LR5 to LR4, and even though now some of the cells which pass through the lesion without distorting and iron, some of the features favoring malignancy, particularly HCCR, non-enhancing capsule, nodule in nodule, mosaic architecture, blood products in MRs, and fat in MRs, which is more than HC and liver. And step 3 is applying tie-breaking rules if needed. If you are unsure about the presence of the tumor in a vein, you should not categorize as LRTIV. Instead, you should categorize as no TIV. And if you are unsure about the benign or malignant categories, suppose you assign a lesion in LR2 category and you are not sure the lesion is benign, it's okay to upgrade by 1 point to LR3. Similarly, if you are assigning a lesion in an LR nodule, in addition to the above mentioned. So a regenerative nodule or a distinctive nodule which is less than 2 centimeters in size and which follows the following things. Examples are when the lesion is T1 hyperintense, T2 hypointense, siderotic nodules, hepatobiliary phase hyperintense nodules, or any of the combination of the above. And these are regenerative nodules which should be assigned LR2 category. Now this is the overall chart where we have already discussed the LR1 and LR2, the benign and probably benign categories. For the categorization of LR3, 4, 5, we use 5 major features which are arterial phase, non-rim hyperenhancement, the size, the enhancing capsule, the non-peripheral washout, and the threshold growth. So depending on those 5 major features, the 2 major features being the arterial phase non-rim hyperenhancement and size, and the additional major features being enhancing of image. In the subsequent phase and the portal venous phase, there is clearly an LR3 category. This is a triphasic MR image. In the first triphasic MR image, in the first image, you can see in the right lobe of venous Lyrate's algorithm table, this lesion is around 3 centimeters and you have 2 major additional features. So this is an LR5 lesion. Important observation to make is never measure the lesion size in an arterial phase because there can be some hyperemia around the lesion.
I am Dr. Sunil, consultant nuclear medicine. Today I will discuss about role of nuclear medicine in hepatobiliary and pancreatic malignancies. When coming to nuclear medicine, hello. Coming to nuclear medicine, in nuclear medicine we use unsealed radiopharmaceuticals for diagnosis, research purpose and treatment purpose. Radiopharmaceutical has two parts, like one is biological moiety and one is radioactive moiety. Biological moiety is for localization and radioactive moiety is for imaging and therapy. As example, F18 FDG. F18 is the radioactive moiety and FDG is the biological moiety. This is fluorodeoxyglucose. Coming to PET-CT, it is a hybrid imaging technique. It has both PET and CT. PET is used for functional information and CT is useful for anatomical information. These are the tracers we routinely use in the department. Mostly we use F18 FDG only, but other tracers also used, like gallium-68 DOTANAC is used for NET imaging. DOPA is used for NET and Parkinsonism. DOTA-Xendin is useful for insulinomas, and gallium FAP is a new drug. I will discuss about it later. Coming to FDG uptake in tumors, it mainly depends on glucose utilization by the tumor, and if glucose transporters are more in the tumor, then FDG uptake will also be more, and it also depends on hexokinase activity. If hexokinase is more, uptake is more, and if glucose 6-phosphate levels are low, uptake is high. Coming to clinical applications of FDG PET-CT in oncology, mainly it is useful for diagnosis, staging, response evaluation, screening and planning biopsies also. Coming to FDG PET-CT in hepatobiliary oncology. As we know, well-differentiated HCC show less FDG uptake compared to moderately and poorly differentiated HCCs. It is because it has high amount of glucose 6-phosphate levels, which metabolizes the FDG. That's why FDG uptake will be low. And in a poorly differentiated, FDG uptake will be high. And if FDG uptake is high in the HCC, that means it is biologically more aggressive and it may not respond well to the treatment also. Actually, there is not much role of FDG PET in diagnosing the HCC, but it has role in detecting loco-regional and distant metastasis. And it is useful for a biopsy planning in large tumors, because we can plan biopsy from the tumor which has high FDG uptake, part of the tumor which has high FDG uptake. And it has role in treatment response evaluation and in assessing recurrence also. And as we know, like benign lesions like FNH, hemangiomas, adenomas, they show less FDG uptake compared to background liver, so that we can rule out malignancy in those lesions. You can see here, this is the HCC pre and post treatment images. Lower one is pre-therapy images. You can see a arterial enhancing lesion in the right lobe of liver. It is not showing much FDG uptake, almost similar to background liver only. Patient had chemo and radiotherapy and came with high AFP levels. Here you can see a large tumor size is increased, almost involving right lobe, and it is now FDG avid also. Maybe tumor transformed after treatment. Coming to cholangiocarcinoma, mostly we use 3-phase CT, MRI or ERCP only. FDG has not much advantage over these investigations, but it is useful for loco-regional and distant metastasis. And this mainly diagnostic efficiency mainly depends on location and morphology of the tumor. If the tumor is located peripherally, it is more sensitive. If tumor is FDG PET-CT in pancreatic adenocarcinoma, it can be considered in high-risk patients to identify extrapancreatic disease, like in high risk, like large tumors, high CA19.9 levels, and borderline resectable tumors. Okay, and it is also useful for treatment response evaluation and restaging. In cystic lesions and IPM, and cystic lesions like mucinous cystadenoma, serous cystadenoma, we can identify malignant potential in them, and it can be false positive in pancreatitis cases because of inflammation. You can see here, this is a carcinoma head of the pancreas, pre and post surgery case. This is the pre-surgery images. You can see a small FDG with lesion in the head of the pancreas with a few regional lymph nodes. And patient had surgery and chemotherapy and came for follow-up. One focal FDG uptake in the pancreatic jejunastomycete. that is a local recurrence, and you can see the FDG with liver metastasis also. It is mainly used for restaging. And this is a serous cystadenoma pancreas. This is cytologically proven also. You can see large cystic lesion in the head of the pancreas region. There is no FDG uptake and are no enhancement also on CT. It is proven as benign only. Coming to FAPI PET CT. FAPI is a newer drug. It has potential to no fasting required. Normally for FDG at least 4 to 6 hours fasting is needed. Here no fasting is needed. Shorter waiting time, like after injection within 15 minutes we can do the scan, and no need of sugar control, good for diabetics. And it has high sensitivity in many tumors which show less FDG uptake, like HCC, RCC, mucinous lesions and mucinous malignancies and peritoneal metastasis. And PRIVE is also similar to FDG or DOTA only. It is in-house prepared in the department with the gallium generator. It is a comparison between FDG and FAPI in HCC. Here you can see FDG is able to, in HCC, FDG is able to identify only single lesion in the HCC, but FAPI is able to identify multiple lesions in both lobes of liver. This is the advantage with this. Coming to pitfalls, it is a newer drug, not widely used, and we don't know about physiological activity also. It can show uptake in the wound healing, tissue remodeling, degenerative process also. Sometimes it show high FDG uptake in the endometrium, which hinders use in gynecological malignancies, and few benign lesions like fibromas, schwannomas, and renal angiomyolipoma also show high uptake. It needs to be researched well. Coming to gallium labeled FSTR imaging, like it is useful for NETs. Okay, as we know, majority of NETs are in the gastroenteropancreatic region only, and they express high levels of SSTRs. Well differentiated and moderate differentiated HCCs, in well differentiated and moderate differentiated NETs, we can use DOTA PET CT scan. But in poorly differentiated NETs, we have to use FDG PET because FSTR expression is low and they are very aggressive and they have a high metabolic activity. That's why we can use FDG PET CT here. Mainly this DOTA PET CT useful for diagnosis, staging and restaging of NETs and other tumors which express SSTRs like pheochromocytomas, paragangliomas, adrenal tumors, thymic tumors and small cell carcinoma of lung. And it is also useful for identify occult primary. Sometimes patient will come with liver metastasis proven to be NET. We can, after PET scan, we can identify primary. And it is useful for planning PRRT also. This is a NET pancreas case, DOTA PET CT. Here you can see enhancing lesion in the distal body of pancreas. It is showing intense tracer uptake also. Gallium-68 DOTA extend in PET CT. This is useful for insulinoma imaging. It is almost 100% sensitive to insulinoma. This extendin is a GLP-1 analog. Like the insulinomas express high amount of GLP-1 receptors. That's why we can use in insulinomas. Here you can see intense uptake in the insulinoma in the tail of the pancreas. We can do DOTA PET CT also in insulinomas, but it has around 75% sensitivity. Coming to nuclear medicine therapies, we regularly use the term theranostics. Theranostic means therapeutic and diagnostic. Like we use almost similar type of compound for both therapy and diagnosis. For example, in NETs, we use gallium-68 DOTA for scanning purpose, and same DOTA tagged with lutetium for therapy purpose. That's why we call we are using the term theranostics. And how nuclear medicine therapy works? Like in nuclear medicine therapies, we use alpha and beta rays for therapy purpose, and gamma rays are used for imaging purpose. This alpha and beta rays, they induce DNA damage with breakdown of DNA. Mainly alpha can cause a double strand break, and beta can cause a single strand break. And alpha has high least range but high ionizing energy, and beta has comparatively moderate range and moderate energy. This gamma has long range and low energy. That's why we use it for scanning in PET CT and SPECT CT. Coming to TARE, transarterial radioembolization, it is commonly done by nuclear medicine and intervention radiology. It is mainly indicated in inoperable primary or metastatic liver lesions. Like we use the radioisotope yttrium-90 teraspheres or surspheres depending on availability. Yttrium-90 is a beta emitter. Like I already told, it causes a single strand break in the DNA. It has half-life of around 2.7 days. As we know, these liver tumors show high blood supply through hepatic artery only. That's why we can preferentially target hepatic artery. Procedure is initially angiography is done, then technetium MAI is injected into the hepatic artery catheter. Then we will do a technetium MAI scan and see right to left shunt. If the shunt should be less than 10% ideally, but if it is more than 10, we have to adjust the dose. And if more than 20, therapy is cancelled. And after that, after the shunt, calculating shunt, we will give the radioactive dose directly into the hepatic artery. And side effects are mainly radiation pneumonitis, hepatitis, and gastric ulcer. They are also due to right to left shunt only. Few phase 3 trials are showing TARE is not superior to sorafenib in overall survival, but it has better quality of life and fewer side effects compared to sorafenib. In some phase 2 trials and meta-analysis have compared TARE with TACE. TARE has better TTP, better OS compared to TACE, but side effects are almost similar only. This is the post-TARE image. You can see a patient had a large tumor in the right lobe of liver. The total dose is concentrated in the right lobe of liver only, with the rest of the liver completely normal. Coming to PRRT, peptide receptor radionuclide therapy, it is mainly indicated in inoperable and metastatic NETs and other SSTR expressing tumors like pheochromocytoma, paraganglioma, and neuroblastomas. We use the radiopharmaceutical lutetium dotatate, which is a beta emitter, or actinium dotatate. Mostly we use lutetium only because of availability issue and cost. Actinium is very costly. And the procedure is hello. Procedure is a daycare procedure only. You can see initially we will assess the renal function, then we will inject like amino acid cocktail for the patient to protect kidneys. Then we directly inject the lutetium into the patient. It has very less side effects, and it is a daycare procedure only. After the procedure, patient can go home. Hardly takes around 2 to 3 hours for the procedure. Main contraindications are severe renal dysfunction and pregnancy and breastfeeding. We mostly do around 3 to 5 cycles in intervals of 2 months. And side effects are acute, mostly headache, nausea, and sometimes functional syndromes can happen like hypoglycemia, carcinoid syndrome. Delayed side effects are very less likely. Possibility of renal toxicity and bone marrow depression is present. This is a PRRT case. This is a pancreatic NET case. Initially, extensive liver metastases were there. After the treatment, after 3 cycles chemotherapy, you can see liver mets are almost gone. Primary lesion also size reduced. This is also extensive metastatic case of pancreatic NET. You can see after 5 cycles chemotherapy, near complete resolution is achieved. And coming to NETTER-1 trial, they compared lutetium dotatate and low dose octreotide with high dose octreotide in advanced medical. Main key results are like in lutetium group, PFS was not reached, and it has better ORR and overall survival rates. And NETTER-2 trial is a newer one. It is still ongoing. It is also compared lutetium with PRRT with octreotide. Like it also shows PFS is better for PRRT group. And this is the latest NCCN guidelines. It is recommending in pancreatic and neuroendocrine tumors with advanced or distant metastasis, PRRT can be used as a first line. Okay. Thank you.
Thank you, sir, for that comprehensive and enlightening session. Your insights into evolving role of nuclear medicine in HPB oncology, from precise diagnosis to targeted therapy, highlight the depth and potential of this field in advancing patient care. Before we begin this important segment on hepatocellular carcinoma, it is my privilege to invite a distinguished academician and clinician to chair this session. Please join me in welcoming Dr. Mihir Lakshmi, Assistant Professor and Medical Oncologist at NIMS, Hyderabad. Ma'am brings a wealth of clinical and academic experience in oncology and has been a guiding voice in liver cancer management. We are honored to have her chair this segment and steer this discussion that follow. Welcome, ma'am. I request Dr. Harish Babu, Medical Head of Medicover Oncology Institute, to hand over bouquet to our chairperson. I kindly request ma'am to be seated as we proceed to the session. We now shift focus to one of the most dynamic and evolving areas in liver cancer management, interventional radiology. It is our pleasure to welcome Dr. Sai Teja, Consultant Interventional Radiologist at Medicover Hospitals. Sir will be speaking on interventional radiological treatment of hepatocellular carcinoma and IR role in immuno-oncology of HCC, the future perspective. Please join me in welcoming Dr. Sai Teja.
Good morning, everyone. This is Dr. Sai Teja. I'm a consultant intervention radiologist. So I'll be today talking about the loco-regional therapies of HCC and a short note on what is IR role in immuno-oncology. So the loco-regional treatments, usually it's just a curative treatment in a very early stage disease of HCC. Downstaging of the tumor is a major aim for IR so that they can meet for a liver transplantation criteria. Bridging therapy to avoid the tumor growth for the liver transplantation is also the aim. So what are the types of loco-regional treatment? So loco-regional treatments, the first one is the tumor ablation therapies, and the next is transcatheter directed intraarterial therapies like TACE and TARE. So the BCLC system, staging system, plays an important role in determining the best treatment for the HCC. So I'll just try to just take a short time here. The HCC usually, the BCLC have 5 stages. Very early stage or stage 0. Usually we recommend a normal resection for this patient. If it is an early stage with increased portal pressure or bilirubin, we'll go for an RF ablation. If it is an intermediate state, a multinodular HCC, we directly go for TACE. And in advanced stage, we recommend a systemic therapy. And in terminal stage, just a supportive care. So what is tumor ablation? So it is just a direct application of energy-based thermal or non-thermal energy or chemical therapies to treat the focal tumors. So tumor ablative therapy, it actually induces the cellular damage and causes tumor necrosis, and it can be performed percutaneously, laparoscopically, or open approach. So coming to the first ablation therapy, it's a chemical ablation. The chemical ablation, usually the most commonest agent which we use is ethanol, so which causes direct neoplastic cells into coagulation necrosis. So it is recognized as technically very safe and low cost, and with very limited resources, this could be an option. So this is an image of an HCC in the right lobe. As you can actually see, viable HCC, and this is after the ethanol ablation therapy, where there is no enhancing area. This is another case where enhancing HCC after the percutaneous ethanol treatment shows no enhancement. So the only risks in this procedure is local progression, and the most commonest which we encountered is the needle track seeding, which actually the tumor seeding can happen throughout the needle which we actually insert, and portal vein thrombosis is also a complication, so this is usually avoided. This is actually an electric current which we, in the radio frequency range of 450 to 500 kilohertz, is applied to the lesion by an electrode needle and heating it around 60 to 100 degrees, predominantly adjacent to the electrode tip. So this causes the coagulative necrosis and protein denaturation. Margin of 0.5 to 1 centimeter of non-tumorous liver is the main target for IRs. So this is the most effective treatment of HCC compared to the other lesions such as liver mets. So the better survival rates are good in RFA than compared to the ethanol injections. For small lesions, RFA has a survival rate similar to that of surgical resection, but with less morbidity and better quality of life. So this was a patient which we treated using RFA. This is an enhancing right lobe HCC, which is getting washed out in the subsequent phases. And this was the image in the post-ablation with no obvious enhancing viable tumor. This was the other case, which was a very small lesion around 1.5 centimeters HCC. And this was the area of ablation post-therapy with post-RFA changes surrounding the lesion. So coming to the microwave ablation, there's not much difference between RF and microwave, and usually the only advantage what we have is high intratumoral temperatures, larger tumor ablations and larger tumor volumes, and faster ablation times and less heat sink effect. So this is the electrode of RF, microwave and cryo. So the RF, the peripheral, the heat diffusion is not very great compared to the microwave. So microwave is bit better than the radio frequency ablation, and good cold diffusion also can be achieved by cryoablation. This was a patient which we treated. There's a lesion in the left lobe which is enhancing and getting washed out in the subsequent phases, a small HCC. And this is the post-microwave ablation where there is no viable or enhancing tumor part which was there. So this was an contrast MRI showing a small HCC here, and we have percutaneously went to the lesion center, and we have got a good ablation area of this tumor also. So these are the very commonest complications which we encounter during this RF and microwave ablation therapies. The most commonest which we achieved during our cases was patients with a good subcapsular lesion, subcapsular HCC causing a subcapsular hematoma, and hepatic abscesses were common in our cases, and a bit of hemorrhage because of the vascular and biliary damages. So what is cryoablation now? This is a very new technique which is available in Hyderabad also, which is characterized by application of extremely low temperatures to destroy the tumor tissue. So this functions with the delivery of argon. This is in cryogen, which the applicator is rapidly cooled by means of Joule-Thomson's effect. So then the helium is also passed into the system. So there will be successive this freezing and warming of the tumor, which actually causes the cell dehydration and protein denaturation, causing hypoxia and cell death. So this is called as Joule-Thomson's effect. And the most commonest cryogen which we use is argon and helium gas. Direct tissue destruction is achieved very significantly in this procedure with no vascular injury. Advantages of this cryoablation is you can actually see a good ice ball which is formed inside and surrounding the tumor. No severe pain as a patient. Lack of damage to the major blood vessels can be achieved and GB. And patient can be discharged pretty fast from the hospital also. So this was the small ice ball formation around the electrode of the cryo. And on CT, you can actually appreciate a good margin of the ice ball. Coming to the transarterial therapies, the first one which I am talking about, it's just a bland embolization. It just aims at occlusion of the tumoral arterial supply, including hypoxia followed by necrosis. The most commonest embolic agents in this procedure is we use gelatin sponge as temporary, autologous blood clot and degradable starch microspheres. In permanent embolizing agents, we can use PVA and steel coils. But this procedure actually has a very, the recanalization rate after this procedure is very high. So this is actually not being practiced nowadays. The other we prefer TACE. This is an interventional treatment where we actually go into the tumoral feeders by causing selective ischemia and anti-cancer drug effect. This can be, we actually use a mixture of lipidol and chemotherapeutic agents like doxorubicin. So who are the candidates for TACE? The ideal candidates of the TACE are with a good liver function, so ILPUX A or B without vascular invasion or extrahepatic spread, and may also can be offered to the patients with inoperable small tumors which are not amendable for local ablation. It can also be used as an adjuvant therapy as a means of downstaging of the disease for the liver transplantation. Now, what are the contraindications of TACE? The first contraindication is the decompensated cirrhosis, where patient is having jaundice, clinical encephalopathy, where we cannot offer them TACE. Extensive tumor with massive replacement of both the lobes, severely reduced portal flow, and technical contraindications to intraarterial therapy like arteriovenous fistulas and all cannot be, TACE cannot be done. Relative contraindications include tumor size more than 10 centimeter, which we can actually offer TARE if it is more than 10 centimeter. And other comorbidities can be a contraindication for TACE. So this was a case which we have done recently, showing a good right lobe enhancing lesion very close to the diaphragm. And this was the complete washout in the subsequent phases. And this was a good lipidol inside the tumor with the doxorubicin was achieved in post-TACE imaging. And this was a common hepatic artery run in the DSA showing a good tumor blush, the multiple tumors in this case, which was completely been embolized in the post-common hepatic artery run. And now coming to the DEP TACE, this is the new standard care of treatment in HCC. These are just drug-eluting beads are used in this with chemotherapeutic agents loaded with it. The doxorubicin is mixed with DC beads and then superintendent aspirated and injected into the tumoral feeders. The advantages of this are very slow release within the lesion, decreased systemic toxicity and increased patient's tolerance. So this was a case which we have offered DEP for this, DEP TACE. The huge right lobe HCC with a good arterial blush in the DSA of the right hepatic artery, and there was a good tumoral feeder occlusion and obstruction after the treatment was done. But patient came back to us after 6 weeks showing a small blob of enhancing area, and we have taken him for the angio and even tried to embolize those things. And this was a small blush which was seen on angio also. So we have gone inside and just confirmed that there is a small viable tumor, and we have not offered them TACE again, but we have finished off the tumor using microwave ablation. So what are the comparisons between the C-TACE and DCB TACE? This is a C-TACE is not a permanent embolic, but DCB are permanent embolic. And we use lipidol in conventional TACE, and DCB does no lipidol. And we actually use a rapid injection for the C-TACE and slow injection for the DCB TACE. Stasis actually we have to stop if there is stasis in C-TACE, and no stasis is achieved in DCB stage. So when should we stop the TACE? This is very important as a clinical perspective, where when should we actually stop the treatment? It can be stopped as soon as the complete response is obtained. In the absence of the response, after 2 to 3 TACE sessions, we have to stop the TACE. If there is no progression of the treated lesions, we have to stop the TACE. And when do you continue? When there is local tumoral recurrence and new tumoral growth is there, we can continue the TACE as per. Now coming to the transarterial radiotherapy, we actually use yttrium-90 in this, and it is minimally embolic microspheres loaded with radioactive beta emitters injected to deliver selective internal radiation to the tumor. So it actually causes irreversible DNA damage and cell death, and radioactive microspheres are around 30 to 70 microns, allowing them to penetrate the tumor vasculature. The overall survival rate is around 86% for all the patients, with 92.8% for the neoadjuvant patient with resection for transplanted liver. And when compared with C-TACE of BCLC A or B, TARE is actually significantly better results than that. The risk actually is hepatitis, radiation damage, and there is actually hepatopulmonary shunting has to be ruled out before the procedure using technetium-99m and MMA study. So this was the TARE image, where actually you can see the MMA study showing a good isotope uptake only at the liver with no shunting around in the other organs. So this patient was offered TARE, and this was a post image, and this is post 6 weeks showing good tumoral necrosis with no viable tumor. Now coming to the IR role in immuno-oncology, there are few studies saying that DEP-TACE with nivolumab and other systemic therapeutic drugs has a better results than systemic oncotherapy alone. So ablative therapies in this kind of patients has priming the antigen-specific T cells and natural killer cells with high levels of inflammatory cytokines like IR6 and tumor necrosis factors could lead to high effectiveness of ICI therapy. And in the future perspective, the direct injection of oncolytic virotherapy into the tumors has shown the promising results, turning the cold tumors into the warm or hot tumors. So in conclusion, the systemic therapies and liver directed approaches has allowed the immuno-oncology to be at center stage of rapidly evolving dynamic fields all across the HCC. Thank you.
Thank you, sir, for that compelling and forward-looking session. We truly appreciate your contribution. We now move to a transformative treatment approach in liver oncology, liver transplantation. It's an honor to welcome Dr. Sriman Narayana, Senior Consultant Surgical Gastroenterologist, Medicover Hospitals. Sir will be speaking on surgical management of hepatocellular carcinoma, advancements, challenges, and outcomes. Please join me in welcoming sir.
Good afternoon, everybody. Thanks to Medicover management to give the chance to me. The topic is surgical management of hepatocellular carcinoma. The treatment of hepatocellular carcinoma is based on few principles. One thing is HCC, hepatocellular carcinoma, the blood supply is depending on hepatic artery only. So if you target the hepatic artery, automatically the cancer will damage. Second thing is what is the surroundings liver, status of liver? Because in 80% of hepatocellular cases, the liver is the cirrhotic liver. Only in 20% cases, the liver is a normal. And one more thing is margin. How much margin we need for hepatocellular carcinoma? Microscopic margin is enough. So actually the problem with the hepatocellular carcinoma is the patient will not die with the hepatocellular carcinoma. He will die with the recurrence and the hepatic failure. So microscopic margin is enough. Second thing is the tumor blood supply is the hepatic artery. And the number of the lesions. Why I am concentrating on number of lesions is, if more number of lesions means the complete liver is a pre-malignant one, because the cirrhotic is the pre-malignant. So if the number of lesions are increasing, the remaining liver also is the pre-malignant one. So there is always a chances of recurrence. Coming to location of the tumor, because if I am going for surgery, there is a two options will be there. One thing is the lobectomy or segmentectomy, that is the anatomical one. Some people will do only the wide local excision with the microscopic margin. That is also fair enough. But the location is important. Suppose the tumor is very nearer to the bile ducts and hepatic veins and everything, we have to do the local anatomical resection, means complete lobe or complete segment. Otherwise, there is always a chances of more bleeding and more bile leak. If it is the peripheral locations, just microscopic margin is enough. That is not a standard one, but enough. And if you go for any ablative procedures like our site told, radiofrequency ablations, microwave ablations, cryotherapy, the tumor need at least 1 centimeter margin of liver. Otherwise, there is always a chances of bleeding and spillage. So location of the tumor also important. Coming to the underlying liver, because patient will not go with the HCC, he will go with the liver failure. The underlying liver, 80% of cases of liver are cirrhotic patients, 20% is non-cirrhotic ones. Coming to the two options will be there in the HCC. One thing is the curative options, that is complete recovery. Second one is the palliative options. Curative options, three types, that is the resection, normal standard resection. Second thing is the transplantation. Because why is, if the HCC patient comes to us, first thing is the resection, we suddenly tell that patient to transplant. People will think that why the cancer, for cancer, why you need a transplant? So I will explain that one. And ablative procedures. If the patient is non-resectable patient, non-transplantable patients, go for ablations procedure. Ablation is based on the energy source, damage the liver tissue. But there is a chances of recurrence. This is the standard staging system, already explained BCLC. So in this, main important is, as our professors always told to us, before going surgery, see the patient once. That amount of surgery, patient whether tolerate or not. This is more useful in the liver. That is the patient performance status. If the patient is very weak patient, don't go for liver resection. That's why before going for surgery, see the patient. That is very easily applicable for the liver. Under Child-Pugh criteria, that is the liver function status. If the liver function is good, we can do resection or transplantation based on the criteria. If the liver function is bad, don't go for the resection or transplant, go for the other procedures. So coming to if the patient is, lesion is a small one, 2 centimeter lesions, Child-Pugh's functional status is very good one. If the patient is a potential candidate for transplant, go for the transplant. If the patient is not a transplantable patient, go for resection based on the liver status. And remaining 3 taste, sorafenib already Sai explained. Coming to the resection, what are the indications or classical indications for resection is the solitary tumors, and single tumors, the size is not a criteria because the liver is almost like a big one. We can cut the end size of liver for the tumor. Just microscopic margin is enough. How much liver remnant required for the patient? Normally, if the liver is normal, 20% liver is enough. If the liver is like a fatty liver or some chemotherapy induced damage, 30% of the liver is enough. If the patient is a cirrhotic patient, 40% of the liver enough. That means we can cut the remaining liver with the microscopic margin. That's why preserved liver function. And no other evidence of portal hypertension like a normal bilirubin should be there. Portal venous gradient should be less than 10 platelet because patients should not have the portal hypertension. That is the candidate for resections. When compared to resection, the 5-year survival rate is almost a 70%. So if the patient is a resectable patient, go for directly resection. The survival rate is almost a 70%. The surveillance should be there. For any malignancy, surveillance should be there. It is every 3 to 6 months with a normal ultrasound because the recurrence rate will be more. And AFP. Why recurrence rate more is already the liver is a cirrhotic liver. The cirrhotic liver is a pre-malignant liver. If you cut one place, it will develop chances of development of other malignancy in other lobes. This is the latest advancement in the resection. Portal vein thrombosis, previously it is unresectable. But nowadays we are doing the resection. Because portal vein thrombosis in a cirrhotic patient is almost 62%. We should not delete the patient for his good recovery. Okay, but portal venous thrombosis, if it is involving only the first order branch of portal vein, we can do the resection. The survival rate is very good, almost like when compared to systemic therapy, it is 2 years survival benefit is there. So we should not contraindicate the one patient for the portal venous thrombosis. And this is the latest advancement, clinically significant portal hypertension. Previously, if any patient with the portal hypertension, portal venous thrombosis, we are asked the patient to don't go for resection, go for transplantation. But if it is a very small lesion, peripheral lesions, and portal hypertension is very minimal, we can do the laparoscopic procedures. Because transplantation nowadays very good transplant surgeons are there, so there is a very minimal complications. But small lesions, better to go for resection, even in minimally significant portal hypertensions. This is the transplantation criteria. If the patient has a very small lesions, 5 centimeter, less than 3 lesions, the size is less than 3 centimeters, there should not be any vascular invasion, there should not be any extrahepatic spread. The simple thing is, tumor should be within the liver. This is the palliative options in the transplant, in the HCC patients, already I explained, TACE and tear. This is the only thing is, the tumor blood supply is hepatic artery. If you give anything in the drainage branch of hepatic artery, the tumor will die off. But problem is, recurrence chances will be more. These palliative options we have to do in the patient with unresectable, untransplantable, based on the patient condition, not based on the tumor. So these are very simple investigations like a CECT abdomen with pelvis, like a hepatic protocols, and HRCT chest routinely we are doing. Bone scintigraphy few people are doing, we are not doing actually. Upper GI endoscopy to rule out any portal hypertension or not, because the surgery, resection or transplantation based on patient has portal hypertension or not. And elastography, very simple thing is, after resection, whether the remnant liver is good or not, we have to decide before going for surgery. On the table, the surgeon eyes is more powerful than the PET scan. If on the table, if the surgeon feels that the remnant liver is not enough for his life, stop the surgery. So before going for surgery, go for elastography, ultrasound. We can see the remnant liver is function or not. This is the AFP. AFP shows how much is the tumor burden and follow up whether any recurrence came or not. LFT, this is for the normal function test. So main thing is whether the liver function is good or not, whether portal hypertension is there or not, whether the remnant liver is good or not for his future. This is the classical lobectomies, right and left. And this is the different types of hepatectomies, like a right hepatectomy, right extended based on the lobes. This is the anatomical resections actually. But in a liver surgery, in liver resection, the microscopic margin is enough actually. So how you optimize the future liver remnant? Because the survival benefit will based on the future liver remnant. How can I, suppose one patient is there, I want to do the resectable patient, not a transplantable patient. I want to do the resection. So the remnant liver is not enough for his life. How can I optimize before going for surgery? The one thing is in the liver vasculature is the 80% of blood supply to the liver will go with the portal vein. If a portal vein has two branches, right and left. If I cut one branch of right side, the complete blood supply will go into the left side. So more blood supply, the more liver will grow off. This is the principle actually. And one more thing is, tumor will depending on hepatic artery supply, not on the portal vein supply. Okay, so based on these principles, the latest development is ALFs. Before that is portal vein embolization. What is a ALF? ALF is just a simple thing is ligate the portal vein, which is draining the disease under liver cancer part area. Suppose our right side liver has a cancer. I will ligate the right portal vein. The portal blood supply will directly goes to the left side, which is the remnant liver. But should be make sure that the left liver lobe doesn't have any malignancies. Otherwise, it will grow off. And one more thing is there is always a portal venous circulations, like right side blood supply will go into the left side via the parenchyma. So I should cut off the parenchyma. One more thing is in the surgery, I have to cut off the parenchyma and I have to ligate the portal vein. This is the surgery. So right side portal vein I have to ligate. Left side there is no lesion. Before this, sure, if you see in the first picture, there is a lesion. We have to remove that lesion. Otherwise, the left side lesion will increase enormously. And I have to cut the parenchyma to stop the no bypass from the right side to left side. So cut the parenchyma, cut the portal vein, automatically the left side liver lobe will increase its size. How much time we have to take? At least 2 weeks is enough. How much liver volume? At least 70% of left side liver lobe will be increased, which is the fair enough for the patient. In this surgery, the very important part is don't do the liver mobilization. Don't do the portal dissections. Because the future, next time surgery will become the problematic. So this ALF is used for the non-resectable patients. We can resect to increase the liver remnant. This is the very latest one is the ex vivo resection with auto transplantation. Okay, what is the ex vivo resection is? Suppose the tumor is there in around the vasculature, near the portal vein, near the IVC area. So inaccessible area. So we can remove the tumor liver along with the vasculature, along with the venous. Do the bench dissection of tumor. Do the vascular anastomosis of the liver. And do the auto transplantation. That is called as ex vivo. This is the only useful for the tumor which is not accessible to the resection on the table, on the patient when they is alive. And the tumor is very near to the vasculature. So remove the tumor along with the vasculature, that is IVC, whatever thing is. Do the bench dissection, remove the tumor, remove the veins, do the venous reconstruction, keep the auto transplantation. This is the very latest. This is a very simple principle in liver resection is, you can remove the end size of tumor with the microscopic margin, but the liver remnant, whatever is there, it should be enough for his life, that is at least 30%, with the drainable area, that is blood supply should be go, venous supply should come, bile has to be drained, because the most common cause of death for the HCC is not HCC, it is the liver remnant, whether it is functional or not. And there is always a chances of recurrence, so follow-up should be mandatory. Why recurrence is? We are dealing with the pre-malignant liver. Complete liver is a pre-malignant. So once you remove, one more tumor will come into the another area. Thank you so much.
Thank you, sir, for that enlightening session on current challenges and outcomes. It is my pleasure to welcome Dr. Ajay Shinde, Consultant Gastroenterologist and Hepatologist, Medicover Hospitals. Sir will be speaking on liver transplantation for hepatocellular carcinoma, expanding criteria, outcomes, and future directions. With his clinical acumen and deep involvement in liver transplant programs, Sir will offer valuable insights into how this treatment modalities is reshaping survival possibilities for advanced liver cancer patients. We welcome you, sir.
Good afternoon, everyone. I would like to thank the organizing committee for giving me an opportunity to participate in this session. Today, I'll be giving a brief talk on the role of liver transplantation in hepatocellular carcinoma. So, liver cancer, it is the fifth most common cancer and its second most frequent cause of cancer-related death globally. Around 850,000 new cases of HCC are diagnosed annually, and around 8 lakh deaths due to HCC have been reported per year. It accounts for 7% of all cancers. HCC accounts for approximately 90% of the primary liver cancers, and it constitutes a major economic problem worldwide. So now, HCC, it is traditionally a Barcelona Clinic liver cancer classification system has been used for staging hepatocellular carcinoma, and it has been updated regularly, and the recent update has come in 2022. So this BCLC staging already have been highlighted by Dr. Sai Teja and also by Dr. Sriman Narayana. I would just like to tell the changes which have happened in this staging system recently, that they have incorporated the systemic therapy also in stage B and stage C, and these systemic therapy, there have been a lot of changes, including immuno-oncology therapy also, and that part will be discussed in other session. And there has been Indian modification of this BCLC staging system, because BCLC is not comprehensive for including and giving prognosis and treatment criteria for all the patients. So in initial modification of BCLC staging system, it stages the HCC as very early stage, that is stage 0. Early stage is stage A, intermediate is stage B, advanced is stage C, and terminal is stage C. In very early stage, there is single lesion less than 2 centimeter in size, liver function is preserved, and ECOG performance status is 0. Ideal treatment for these patients is ablation, and in stage A, that is early stage, either there is single lesion which is more than 2 centimeter but less than 5 centimeter, and if the lesions are multiple, they are less than 3 and size should be less than 3. Performance status is ECOG 0, and liver function should be child score less than 6. So it has been categorized, staged as stage A1 and stage A2. So for stage A1, the optimal treatment would be resection, and for stage A2, if there is no contraindication for liver transplantation, these patients should be considered for transplantation. For intermediate stage, it is multilodular lesion, size more than 5 centimeter. The performance status is ECOG 0, and the liver function is still preserved. So these stage has been divided into 3 stages, that is stage B1, B2 and B3. Stage B1 patients, these are multinodular patients, they can be considered for liver transplantation by using extended criteria for liver transplantation, which will be highlighted in the coming slides. The next is advanced stage, that is stage C. Initial BCLC has modified this into stage C1 and C2, where in C1 there is only portal vein tumor thrombus but no extrahepatic spread. In stage C2 there is extrahepatic spread. So treatment changes for both of these stages, which were not highlighted in the BCLC staging system. And in stage D, which is a terminal stage as per the BCLC staging system, and BCLC recommends only best supportive care for this staging. However, most of these patients, they they have the performance status which is advanced, but their tumor still can be transplanted if it is within the criteria for transplantation. So initial BCLC has modified this stage into stage D1 and D2. So stage D1 patients, they can be considered for transplant if they fit into the criteria for the transplantation. So this is the comparison of both stages, which were just highlighted in the last slide. Now, for for HCC, definitive treatment is liver transplantation. It is curative treatment as well as it eliminates the cirrhotic liver, which contributes to the patient's risk for HCC recurrence. However, it cannot be performed in each and every patient due to strict eligibility criteria, which precludes some patients from undergoing transplantation, as well as there is limited availability of the donor organs. The conventional criteria which has been used for last 2 decades is Milan criteria, which is a single tumor less than 5 centimeter in diameter or up to 3 lesions, each less than 3 centimeter in diameter, with no extrahepatic spread and no evidence of any gross vascular invasion on the imaging studies. Milan criteria heralded a new era in liver transplantation for HCC over the last 20 years, and they have been the benchmark for other criteria also. However, over the last 2 decades, Milan criteria has come under intense scrutiny because they are too restrictive, thus limiting the access to liver transplantation for many patients of HCC who would have otherwise been benefited. Many cases exceeding the Milan criteria have showed a good prognosis when they have been transplanted. Attempts at expanding the criteria were made by increasing the morphological parameters of the tumor, that is tumor diameter and number of HCC lesions. So extended criteria based on tumor morphology for considering HCC patients for liver transplantation. The criteria is UCSF criteria, that is University of California San Francisco criteria. In this, this criteria was, they increased the tumor size, maximum size solitary tumor less than 6.5 centimeter, and if multiple lesions, they should be less than 3 nodules, and largest lesion should not be more than 4.5 centimeter, with maximum tumor diameter less than 8 centimeter in size. The 5-year survival in patients undergoing liver transplantation following UCSF criteria were around 75.2%, which were similar to Milan criteria, where 4-year survival rate was around 75%. The other criteria used include total tumor volume criteria, where they used the total tumor volume as the guiding principle to decide whether the patient should undergo liver transplant or not. In this, the total tumor volume they have taken is around less than 115 centimeter cube. Here the 5-year survival accounted for around 80%. Next is up to 7 criteria. This criteria was given by Medicover only, who initially gave the Milan criteria. In this, they summarized that, concluded that patients can be transplanted for HCC if the total sum of the maximum lesions and the diameter of the maximum tumor was within 7. In using this criteria, the 5-year survival rate accounted for approximately 70%. The other criteria used, they were in the setting of living donor liver transplantation, that is Tokyo criteria and ASAN criteria, both using tumor numbers as 5 or less, and in Tokyo criteria the number was 5 or less, and in ASAN criteria the number was 6 or less. So their 5-year survival rate was similar to the other criteria, around 75 to 76%. Using these criteria, UCSF criteria offered benefit for patients with HCC and who underwent liver transplantation, and additional 5 to 20% patients could be transplanted using UCSF criteria who would not have been transplanted if they were restricted to the Milan criteria. Similarly, using total tumor volume criteria less than 115 centimeter cube, more patients qualified for transplant with this criteria, around 30 to 50% more patients than Milan criteria, and around 15 to 25% more patients compared to UCSF criteria. And there was no marked deterioration in the post-transplant outcome in these patients. Now, all these criteria, they only use the morphologic characteristic such as the number of the lesions and the size of the lesions, which do not completely represent the biological behavior of the HCC. Other markers which represent the biological behavior of HCC have been under study. The most commonly used by pseudo marker is alpha fetoprotein level, and other is the PUCA2, that is prothrombin induced vitamin K, prothrombin induced by vitamin K absence 2. It is also called as DCP. The alpha fetoprotein level, they correlate with the microvascular invasion and degree of differentiation of the HCC, and PUCA2 level correlates with the microvascular invasion and the intrahepatic metastasis of the lesion. So now going beyond the tumor size and the number, the other surrogate markers which have been used along with the alpha fetoprotein and the PUCA2, they include the neutrophil lymphocyte ratio, utilization of the PET scan as the surrogate marker. Here they have given these criteria to consider before the liver transplantation. So optimal criteria which can be considered include AFP usually less than 20 nanogram per ml. If the patient undergoes any loco-regional therapy before considering for transplantation, if the AFP was more than 1000 nanogram per ml before, then the AFP at the time of liver transplantation should be less than 100. Change in the AFP after the therapy or during the waiting period should not be more, and the degree should be less than 0. The recommended value of PUCA2 or DCP to consider patient for liver transplantation is less than 100 milliangstrom unit per ml. The recommended neutrophil lymphocyte ratio is less than 5 to consider patients for liver transplantation. Now next is the radiologic response to loco-regional therapy. If there is complete response after LRT, then these patients can be considered for liver transplantation. Pertaining the waiting period for the transplantation should be more than at least 3 to 6 months. Now this Kaplan-Meier survival graph shows the value of AFP before considering the patients for liver transplantation. So in these two figures, the initial figure is for maximum AFP before the liver transplantation, and second is the final alpha fetoprotein level at the time of liver transplantation. So in both these curves, we can see that more the level of alpha fetoprotein level before the transplant, less is the chance of survival and more is the chance of recurrence after the transplantation for patients undergoing liver transplantation. This New York, California scoring system, they included both the morphologic criteria such as tumor size at the diagnosis and number of lesions at the diagnosis. Along with that, they also included the change in alpha fetoprotein level after the loco-regional therapy. So they devised the scoring system giving the points 0, 2, 4. So based on this scoring system, they have categorized it as score less than 2 or less than 2, score up to 3 to 6 and 7 or more. In score up to 2 or less than 2, the recurrence risk was low and the 5-year survival was excellent, accounting for 90%. In 3 to 6 score, the recurrence risk is acceptable, around 70%. If the score is 7 or more, recurrence risk is high, which is around 42%. So other extended criteria which have been included, they are more initial criteria was Hongzhu, who included the alpha fetoprotein level, and the Toronto criteria included the imaging criteria. Next is AFP model, which was highlighted in NYCA classification. Other is the total tumor volume plus alpha fetoprotein, in which they added the AFP levels to the total tumor volume less than 115 centimeter cube. Now coming to the downstaging, most of the patients waiting for the liver transplantation, either their size is not allowing them to undergo the liver transplant, or the waiting period is more. So these patients need to undergo loco-regional therapy. Downstaging and bridging, both these therapies have been highlighted already by Dr. Sai, so I would not go in detail for this. The important thing is there have been criteria laid down to consider the patient for downstaging. That is a single lesion which should be less than 8 centimeter. If 2 to 3 lesion should not be more than 5, and the sum of the maximal tumor diameter should be less than 8. If the lesions are 4 to 5 in number, each less than 3 centimeter with maximum diameter should be less than 8 centimeter. And there should not be any vascular invasion and any extrahepatic disease based on the cross-sectional imaging. So now considering timing for liver transplantation after downstaging, usually 3 to 6 months period should be there to observe the biological behavior of HCC. Now next is it is important to predict the risk of recurrence after transplantation, because no matter which criteria we apply, there is chance of recurrence after transplantation. So this retreat scoring, they have taken few markers to predict the recurrence after transplantation. They included alpha fetoprotein level, presence of macrovascular invasion, and the largest viable tumor diameter plus number of viable nodules. Based on this, they have given scoring system, which the score 0, 1, 2, 3, 4 and 5. You can see that if the score is 0 and 1, the recurrence rate is very less, that is less than 10%. And if the score is more, as it increases to 4 and 5, the recurrence rate is more, that is accounting for 40% at 1 year and more than 75% at 5 years. So there have been other scoring system to predict the risk of recurrence after HCC, which include the moral score and HALT HCC score. So based on other criteria, the recurrence rate which has been described is, using Milan criteria, the recurrence rate was less than 10%. In UCSF criteria, it was around 12% at 2 years. Up to 7 criteria, the recurrence rate at 5 years was less than 10. Using Kyoto criteria, the recurrence rate was 20% at 5 years, and total tumor volume less than 115 centimeter cube, the recurrence rate was 5.4% at 2.5 years. Now the post-transplant management in HCC patients is more or less similar to the patients who have undergone liver transplant for indication other than the HCC. However, the change needed in these patients is based on the immunosuppression, because HCC, it is a tumor, and any immunosuppressive condition, it will increase the risk of recurrence. So the little tweaking in the immunosuppression regimen should be done by subjecting these patients to the mTOR inhibitors rather than subjecting them for calcineurin inhibitors in their post-transplant immunosuppressive regimen. So this is the image showing the selection criteria. So within Milan criteria should directly go for transplantation if there is no contraindication. If they are beyond Milan criteria, they should be considered for downstaging and should have a sufficient waiting period before considering them for the liver transplantation. So initial was the Milan criteria, and after the Milan criteria, there have been multiple criteria used by multiple authorities. So this debate will go on continuously, which criteria to use routinely, as there has been no consensus yet to establish the correct criteria. So this has to be decided on the patient basis, the tumor characteristics, morphology of the tumor, and the biological behavior of the tumor. So the initially Milan criteria, they heralded a new era of liver transplantation as being recognized as reliable treatment for HCC. Subsequently, multiple criteria have been suggested by increasing the morphological characters and also including the surrogate markers which explain the biological behavior of the tumor. Thank you.
Thank you, sir, for that insightful and forward-looking session. We sincerely appreciate your contribution to the symposium. We now transition to a key therapeutic domain, systemic therapy in advanced HCC of role of immunotherapy. It's an honor to welcome Dr. Praveen Adusumelli, Senior Consultant, Medical Oncologist at Medicover Cancer Institute. Dr. Praveen will be presenting on systemic therapy in advanced HCC, role of immunotherapy. Please join me in welcoming Dr. Praveen sir onto the stage.
Very good morning to all of you. I was told by Aparna that my time is cut down by 5 minutes because we are running late. So I will try to finish this as early as possible. First of all, I want to thank Dr. Mahalakshmi ma'am, additional professor at Nizam, for accepting our invitation. to come and chair this session. So after the local therapy, I am going to talk on the systemic therapy options of HCC, especially the advanced HCC disease. So these are the subheadings which I will be going in my talk. So we all know that HCC is a very aggressive disease because it presents very lately, we will recognize very lately. As you can see on the right of the screen, almost 90 to 95% of the patients have a high mortality rate. So basically it is not a one-man thing, because we all need a multimodality team approach of the medical gastroenterologist, medical oncologist, surgical, interventional radiologist and radiologist. We all need to work together to give the optimal outcome in these patients. And also the tumor number, tumor size, child class, performance status of the patient, and most important is the preference of the patients. All these we need to take into account before planning the treatment for these patients. So we all seen that liver-directed therapy by Dr. Sai in the previous presentations about the role of the TACE and TARE. And in the advanced HCC patients, it's not only the single modality, like nowadays we are seeing the combination of the liver-directed therapy along with TKs like lenvatinib, and data is also evolving. We are also using in our clinical practice, and we'll look in the next few slides. So in the advanced HCC, we know that because of the aggressive nature and late presentation, the survival is less. Previously, it used to be around like 6 months to 1 year. Now, because of the advanced immunotherapy options, it is almost 1.5 to 2 years. So two important things that we got to remember. In one of the previous presentations also, we have to seen that it's not only the disease, we also need to take care of the underlying liver function while managing this disease. And also we need to optimize the function of the liver. And also we need to check for any presence of the extrahepatic disease, and presence of the portal vein thrombosis is one of the most important point that will help and guide us in managing these patients, and it is a very poor prognostic factor. And these are the few points that we tend to forget while managing these patients, and these are also very important, especially alcohol cessation and initiation of the antiviral therapies, because almost 80 to 85% of the patients in Indian scenario of HCC are either of hepatitis B or C, and the treatment of diabetes and weight loss as part of the management of NAFLD, and optimization of viruses and ascites. So this is one of the study, that is the launch study, that is shown benefit by the combination of the TACE plus lenvatinib and of HCC, especially advanced HCC. Initially, sorafenib has come based on the SHARP trial in 2007. So this is the SHARP trial based on which sorafenib was approved, and this is the first TK molecule that was approved. Most of us also have used this molecule, and it has shown the survival benefit of median OS of 10.7 months. Just remember that. And next is the lenvatinib, the molecule which has come. It has shown non-inferiority when compared to the sorafenib, and it is almost equally efficacious. And when two molecules are there, which ones to choose? We obviously look into the side effect profile of these agents. So as sorafenib, we all know that hand-foot syndrome, that is palmar plantar dysesthesia, is one of the most common side effect, along with the diarrhea and hypertension. And when compared to lenvatinib, it has hypertension, diarrhea, fatigue and weight loss. Almost the side effect profile, both of these are similar. Ultimately, it comes down to the experience of the clinician, how we manage the dose of these patients, because managing the dose, cutting down the dose and adjusting the dose according to the side effects, and managing the side effects is more important before labeling that patient is progressing, because we need to titrate the dose, that is more important. And for any patient, doctor who has treated a HCC patient with TK, we all know that hand-foot syndrome is one of the most common complaint troubling the patients. So we all tend to use the urate-based creams. There is a study showing that prophylactic use also has given benefit in these patients. So this is the schematic diagram. So roughly just remember that the entire immunity in oncology especially revolves around T cell. It's not the B cell, it is the T cell. So T cell goes and attacks the tumor cell. So the tumor cells are very intelligent, so that they developed a receptor named PD-L1, that's in the blue molecule, PD-L1, so that the binding of the PD-L1 with the PD-1, they prevent the killing of the tumor cell by the T cell. So it is just an immune escape mechanism. So the PD-L1 on the tumor cells binds with the PD-1 on the T cells, so that T cells doesn't attack the tumor cells. This is the immune escape mechanism by the tumor cells. So that what scientists have developed is they have developed molecules so that they can block the binding of this PDA1 and PDL1 that is in the first row, so that this immune escape mechanism is obliterated in the T cells and go and attack the tumor cells and they can kill it. So now the concept of dual IO, we are not only using a single immunotherapy molecule, we are using the two immunotherapy molecules. What is the main reason is, first reason is one immunotherapy molecule acts on the lymphoid compartment and increases the number of the T reactive cells. And the other immunotherapy molecule, they acts in the tumor microenvironment and prevent T cell inhibition. So one prevents the inhibition of the T cells and other increases the number. By this, we can have the dual IO benefit. So the first study is the IM-BRAVE study. So in this dual IO, idezolizumab is combined with bevacizumab, which is the anti-VEGF molecule. The benefit is it increases the vascularity so that the drug can better penetrate into the tumor microenvironment and helps in the attacking the tumor cells. So here you can see the combination has shown clear-cut benefit. Previously we have seen with sorafenib around like 10.5 months odd, the survival benefit is there. Here when we come to immunotherapy, you can see almost 19.2 months of overall survival benefit is there with idezolizumab and bevacizumab combination. So, and there is also improvement in the quality of the life when compared to the sorafenib. So this is the second trial. Initially one regimen I told is idezolizumab plus bevacizumab, that is based on IM-BRAVE study. This is a second trial which showed the benefit of a dual IO, that is durvalumab plus tremelimumab. Both are IO molecules, that is a stride regimen. You can see the benefit is almost 16.4 months when compared to 13.8 months with this regimen. The 3-year OS, how many of us have seen a metastatic stage 4 very advanced HCC patient surviving for 3 years? So almost 30% of the patients are alive at 3 years. That is a 3-year OS is almost 30%, 30.7% when compared with the 20.2%. So this is a single slide showing all the trials, IO trials in advanced HCC patients. We have seen the 2 trials which is important, and the top trial is basically from the China. Those drugs are not available in India. We don't use much. So which one to choose? Because we have both the drugs. Which one to choose? So basically each has its own side effect profile. When compared to the first Edizo and Bev regimen, it has very good efficacy. The main important point is it also included patients of main portal vein thrombosis in the clinical trial. So this data works well for patients who have main portal vein thrombosis also. So whereas in stride regimen in the second, the main portal vein thrombosis patients are excluded. And the second, the side effect profile, mainly for Edizo and Bev, it is hypertension and proteinuria, and stride regimen you see immune related side effects. And overall survival is almost similar, but it is HR is a little bit better. Like with the first regimen, there is a decrease in the death of by almost 34%. With the second regimen, it is 22%. So which one to choose? It's completely depends upon the patient comorbidities and his logistics and everything. But anything can be chosen based on the side effect profile. So at present, there is no data to use the combination of IO along with TKs like sorafenib or lenvatinib. It is either TKs or IO or one after the other. So this is a single slide showing the various real world scenario of various drugs. So this is the main diagram. It shows the main portal vein and branches of the portal vein. So we all know that portal vein thrombosis is one of the main problem that we face, and it also helps in decision making in the treatment options of advanced HCC. So as I told, in one of the IO study, main portal vein thrombosis patients are also included. And for main portal vein thrombosis, there is data for tear. For tear also, in few of the patients we have used, and the results are encouraging, and with a median OS of almost 8.6 months. So this is IM-BRAVE data. With main portal vein thrombosis, the OS is 7.6 months when compared to without thrombosis, it is 21 months. So initially we have treated with some molecule, either IO or TK. The second line options are limited. The survival is almost 5 to 9 months. We know these patients have very poor PS, and the options are also very less. So the points to remember in conclusion are the systemic therapeutic options have increased slowly but surely improved the OS. Previously, it used to be 10 months, 11 months, very advanced HCC. Now, because of the advent of the IO molecules, we could able to reach that 16, 18 months. We never know in future, in the coming few years, we can able to increase that further with better local regional therapies, liver-directed therapies, and combination of IO. And Etizo and Bev and stride regimen have increased the overall survival to 15 to 18 months, as I told. Patients in clinical practice often in variance with the, because the clinical trial data is separate and the clinical practice is definitely separate because, and the multiple second line options with some improvements in survival are available. Thank you very much. Got it.
Thank you, sir, for that insightful session. Your presentation has added a great depth to today's discussion.
It is now time for a very special moment of today's program. We are truly honored to have with us Dr. Sharath Reddy, sir, Senior Consultant, Interventional Cardiologist and Director of Medicover Hospital as our chief guest for the day. May I now invite Dr. Sharath Reddy, sir, to kindly join us on stage for the official launch of Excellence in Advanced Gastroenterology, Liver Transplant and Oncology. I kindly request Dr. Mihir Lakshmi ma'am, our chairperson of HCC, to hand over bouquet to our chief guest.
Kumar, Dr. Sriram, Dr. Sunil Kumar, Dr. Amit K. Jotwani, Dr. Kandra Prashant Reddy, Dr. Mannem Manoj Kumar, Dr. Sai Teja, Dr. Jogu Kiran Kumar, Dr. Sriman Narayana, Dr. Arun Arora, Dr. Santosh Narayanankar, Dr. Krishna Gopal, Dr. Raj Bharat, Dr. Ajay Shinde, Dr. K. Shrikant, and Dr. Sharath Reddy sir and our regional director Megha ma'am to join the stage.
Thank you, sir. This is our entire team of medical gastro and oncology.
It's a pleasure to launch the grand launch of our Center of Excellence in Advanced Gastroenterology, Hepatobiliary Diseases, Liver Transplants, Bariatrics, and Oncology. so much, Sharad sir, and the entire team of Medicover here for this grand launch and giving the best patient care and the outcomes. Thank you so much, sir.
Now I request Dr. Sharath Reddy sir to share his thoughts.
Thank you. Good afternoon, all the delegates and my dear team, oncology and gastroenterology team of Medicover, who are organizing this, a mini conference for our patrons who are using, our services for their patients. So Medicover as a group is now grown to 25 hospitals across 4 states. Telangana, Andhra Pradesh, Maharashtra and Karnataka. And we are shortly coming up with 2 more hospitals in this Hyderabad city, one in Secunderabad and another is in Nanakramguda, that is in Gachibowli. So the Secunderabad one is around 300-bedded facility which is going to be inaugurated in July of this year, and Gachibowli is another 450 bed facility which will be inaugurated somewhere in December 2025. So we are the fastest, expanding hospital group in this country, and we also realize the potential of, expanding healthcare in this country, which is going to become a $5 trillion economy by 2027 or 2030. So this expansion of economy is an opportunity to expand, healthcare institution and to reach areas which are unreached by current healthcare infrastructure. Having said that, the silver lining of, expanding healthcare, the blind spot in our country is still our dependency on, guidelines and guidelines from, Western countries. So we are still dependent on guidelines and consensus documents of Western countries, in treating our patients who are completely different in terms of ethnicity from the Western population. So this is clearly a blind spot because of our governments and government spending on research and development. In fact, it's also a blind spot for all of us as we were not working, with that idea of, research and development or, preparing our own guidelines for our own population. So we are in a typical juncture or a watershed moment from transitioning from using, Western healthcare guidelines to our Indian healthcare guidelines, as well as developing our own resources and network of, research and development to prepare documents for our own population. So keeping this in mind, Medicover is working quite actively in terms of data building. The first thing in data building is, having data together. So to achieve that, we have already completely digitalized our 25 hospitals. I'm proud to say this is one hospital which is completely digitalized. Each and every patient record is, digitalized in this country. So still people are struggling to do that. We have already done that. And our next goal is to convert this digitalized database into some sort of, research and, helping for developing our own guidelines in our country. So we are in the process of doing that, and I'm sure, we are going to do that shortly. So, and with that vision, we are also, doing these kind of programs. The quality in delivering, service to patient is not just inside my doorstep. It starts at your doorstep, where patient walks into your clinics. So That is the reason we expanded our vision beyond our infrastructure and human resources to all of you, so that together we can deliver a right service to our citizens, and together we can build trust on our profession, and together we can grow in this future healthcare scenario. Thank you once again for all our team who put together a program for all of you, and I thank you all the delegates for such an incredible, overwhelming response, which again keeps my people running to conduct these programs. Thank you.
I now request our entire team of gastroenterologists and oncologists and all the Sharath Reddy sir and all the center heads to join on the stage for the group photo. Thank you, everyone. We now move on to a crucial aspect of cancer care, multidisciplinary approach. It is my pleasure to welcome Dr. Amit Jotwani, Senior Consultant, Radiation Oncologist at Medicover Cancer Institute. Sir will be speaking on stereotactic body radiation therapy for hepatocellular carcinoma, a precise oncology approach. Please join me in welcoming Dr. Amit Jotwani onto the stage.
Very good afternoon, everyone. Radiation traditionally has not been used for hepatocellular carcinoma treatment, but a new technology, advanced technology called SBRT has gotten us as a wild card entrant into the armamentarium against liver cancer. So without much ado, SBRT is a very advanced technology. We'll talk about it in more detail. But just basics, it's 6th most common cancer globally. 3rd most common cause of cancer mortality. 82% of hepatocellular carcinoma incidence is seen in developing world. And most common etiology being hepatitis B and C viral infections, NASH, cirrhosis, alcoholic liver disease, morbid obesity, hereditary hemochromatosis, and other toxins like aflatoxin and few more other smaller etiological factors. Largely, HCC best treatment is done in a multidisciplinary. All of you must have realized with so many modalities being offered, it's always done in a personalized fashion by a multidisciplinary team experienced in dealing with HCC. Liver transplant, surgical resection, thermal ablation have traditionally been the curative intent treatments. When we have that kind of case where we can have that curative intent, these three modalities have been. Then catheter-based therapies like transarterial chemoembolization, TARE, hepatic artery chemotherapy are considered acceptable treatment options for loco-regional tumor control. Then SBRT, ablative therapy, has shown significant survival advantage in certain clinical settings. What are the challenges that we commonly face while dealing with HCC management? So it's an aggressive tumor that usually occurs with already an underlying condition like chronic liver disease or cirrhosis. Baseline liver function determines what modality is appropriate for a particular patient. Underlying hepatic parenchymal disease conflicts with the resection volume that you have. High propensity for regional and intrahepatic spread. Vascular invasion is common and main cause of intrahepatic recurrence post-resection. Because of that intrahepatic vascular spread propensity, we commonly see a lot of times recurrences. There is a high risk of bleeding in cirrhotic patients, so surgery becomes difficult. And liver is a dual blood supply organ. It has hepatic artery and portal vein. So it may lead to more chances of recurrence, especially after percutaneous procedures like TACE. And liver is very sensitive organ to radiation, and we have only one. Coming to radiation, radiotherapy involves primarily ionizing radiation like X-rays, gamma rays, high energy electrons or particles like protons nowadays to destroy tumor cells. Primarily, we have two goals of radiation treatment when we do. To deliver optimal tumoricidal maximum dose to the tumor without delivering a very high or a lethal dose to surrounding healthy tissues. Primarily, it works by causing double-strand breaks in DNA, leading to mitotic cell death. Now, historically, radiation was not considered because the treatment volumes would be so big, and the technology was not much evolved. So you can see such big volume, the liver volume remaining, functional liver volume is a very big factor that we consider while treating this thing. So earlier we could hardly deliver maximum 30 gray, which would lead us to local control of less than 30%. But as the technology has evolved, we have better precision in targeting those tumor cells, especially intensity modulated radiotherapy that offers highly conformal dose delivery to the tumor. Now that was not possible in earlier. So last 20 years have given us that foot in the door into management of hepatocellular carcinoma. And SBRT added to it is much more. It is much more precise. We can deliver much higher doses without delivering very high doses to surrounding healthy liver parenchyma. So just to understand these technologies, conventional radiotherapy that we had from 100 years back was like a square box or rectangle. But tumor is never like a square box or a rectangle. It's always irregular. So we got some early beam shaping to shape the tumor. And then came 3D conformal almost 40 years back, where we could shape the beam according to shape of the tumor. But still, we could not achieve because intervening tissues will be there, and whenever there is an entry, there has to be an exit. So the photon, the radiation always impacts the intervening tissue and the tissue after the tumor. After that came intensity modulated radiation. There are different names to it. VMAT is further advanced technology and all. So within that same volume, there could be areas where we want to deliver much higher doses. So concept of dose painting came with IMRT, where within that same volume, the whole volume was divided into beamlets, small square, like pixels we have a picture, pixels as we see. Similarly, so different pixels could be given different doses using very advanced algorithms. This is the very big change that has come in last 25 years that has helped us achieve better treatment deliveries. Then came 4D CT and better tumor tracking. Live tumor tracking and breathing directed, respiratory motion directed motion. Now you can see this is just an example of lung lesion where it's constantly moving, but we can track it, we can measure the volume, we can measure the area receiving how much dose it's going. And we can program the treatment delivery according to the phase of respiration. So image guidance, tumor tracking, gating, all these technical terms have come. So a proper image guided SBRT radiotherapy suite, that's what we have in our setup. Completely tumor tracking, everything is possible. That helps us achieve much better conformity, much better tumoricidal dose delivery that is needed for a liver cancer. Just for an example, just to help you understand how much impact the gating or better treatment imaging techniques have given us. Liver volume in this case is you can measure, see the color, match same volume. Gross tumor volume is 119 cc. With giving margins for the motion, and liver motion can be up to 4 centimeter up and down. So this can lead to a total tumor, overall target volume to be 684 cc for a tumor of 119. But with gating, we could reduce it to 286. So 58% reduction in treatment volume. That implies a lot of liver tissue is not exposed to so high doses of radiation. That's where the change has happened that has brought in SBRT as a major player in loco-regional treatment of hepatocellular carcinoma. Doses can be, typically radiation doses may be up to 30 fractions, 35 fractions, but SBRT we deliver in 3 fractions, 5 fractions, or depending on Child-Pugh CP score B7, we give lesser dose in 5 fractions. And further hypofractionation, suppose the tumor is very close to duodenum or any other organ, lumen organ, intestinal organ, which are sensitive to its radiation effects, we can further fractionate up to 15 fractions. With carefully selected patients, studies have reported up to 100% local control rate and overall survival increase, 3-year overall survival up to 87% for selected cases. We will talk about it now. This is one of our cases, a recurrent post-resection recurrence. Clearly, post-resection, as Dr. Sunil mentioned, the activity increases. So PET helps us, in fact, sometimes better. So resection margin recurrence was there. The patient was treated with SBRT 5 fractions standard dose. We could also track the movement of liver organ and all. This was the lesion, and 3 months post-treatment, there was complete resolution of that lesion, resection margin lesion. Again, another segment 1 lesion, you can see we treated that lesion with SBRT, complete resolution. Another segment 8 lesion, here we can combine also with catheter therapies like TACE with SBRT or RF ablation with SBRT, where initially first we do RF ablation or TACE. That helps us reduce the tumor volume for SBRT, also helps us mark the tumor area for further image guidance. As we all know, tracking the tumor on a CT scan is difficult, delineating is difficult. So when we do RF ablation, we can put fiducials, markers that would help us visualize the tumor while delivering SBRT. Or when we do TACE, the lipoidal contrast embolization, solution is given that helps us target because it gives us that contrast effect while delivering SBRT. So this gives us much more enhanced outcomes especially for larger tumor where TACE or RFA alone may not be very effective in one sitting. In this case, complete resolution of segment 8 lesion after combined SBRT plus TACE, and you can see the arterial venous phase and the MRI. So any treatment comes with its toxicity or side effect profile. Radiation-induced liver disease, fatigue, abdominal pain, aneurysm, but major toxicities are less than 3% in most of the cases. Indications for SBRT in general that have been recommended as per guidelines. Strongly recommended as first-line option for liver-confined HCC. Most effective in lesions less than 3 centimeters, but we do deliver, it is recommended up to 6 centimeter size lesions. We can deliver SBRT, especially in lesions which are not amenable to local liver-directed therapies like TACE or RF ablation techniques like subphrenic location, macrovascular invasion, close to large vessel lesions. Strong recommendation is also consolidation after incomplete response to ablative techniques or TACE. Salvage therapy for recurrence after prior liver-directed therapy. Conditional recommendations are there where you take a clinical call, multidisciplinary discussion, patient's condition and all, where multifocal unresectable disease, where you can deliver treatment alone or with TACE, as we discussed, symptomatic or metastatic HCC. Bridge to transplant. This is a new evolving indication, especially patients who are beyond Milan criteria. We bring them to downstage the lesion, reduce the size and other factors, and bring them within Milan criteria. And there is certain evidence to support the use of neoadjuvant external beam radiotherapy or SBRT. So tumor downstaging or bridging, and especially patients are waiting for transplant, there are other factors. So multiple practical settings, it can be used. And portal vein thrombus lesion before resection, that's another lesion indication where there is some conditional approval depending on other factors, as we mentioned, the patient's general condition, liver performance, functional status and all. At the end, I would say multidisciplinary personalized approach always gives best outcomes for patients with HCC, and HCC must always be treated in a setting where there is all the disciplines, right from surgical hepatology, the transplant, the interventional radiology, TACE, TARE, radiation oncology, surgical, medical oncology all are available. And any patient, we need to consider patient's condition, liver function, tumor characteristics, treatment perspective, where we combine local therapy, including resection, ablation, RT, loco-regional therapy, systemic therapy, and achieve overall a transplant or something. This is the diamond area where we need to get the patient. Thank you very much.
Thank you, sir, for that enriching session. Your insights truly highlighted the strength of integrated oncology practice. Request all our respected delegates to kindly proceed for lunch. Please join us back in half an hour as we resume the next session.
reason why we have a panel discussion is to integrate all these therapies and to see where all of these fit in so that you can have a comprehensive overview or a bird's eye view of all of this. Okay. Can you just check if the slides are working with this? Anyway, in the panel we have with us senior hepatologist Dr. Anand sir. Along with that, as part of a multidisciplinary team, we need a group of surgeons, including both surgical oncologists, gastroenterologists, and transplant surgeons. Along with that, radiation oncologists, and very important, interventional radiologists. More important than other aspects of cancer care. This is one region where their inputs are really valued. And definitely medical oncologists, because most of our patients in our country usually come in an advanced stage. Okay. So let me start with this slide. This is the slide that you just saw was BCLC 2022 modification. So during our MBBS and our PG times, usually we have seen different versions of BCLC, and even during the talks that we had previously, I have seen many of the speakers putting up older versions of BCLC, and this is the latest one. And what I want you to see in this basically is the fact that in BCLC B, the middle category has been subdivided into 3 different categories, and we'll go in more detail once we start the case discussions. Is the pointer working? Okay, can you go to the next slide, please? I think post-lunch it has had this thing, but anyway, let me start with this and also say that post this, there is an Indian modification called as the INACEL classification, where they have taken the latest modification of the BCLC and added a few more practical points. Some of this have some bit of evidence, but some of this usually is general practice that we are following. So having said that, let's go to the first case. You don't need slides for that. So basically we have a 60-year-old male who is an alcoholic, and he has had previous history of hematemesis and has had some variceal bleeding, and which was banded previously around 3 years back. Currently his liver status is Child-Pugh A. He's well preserved. His liver functions are normal except for the fact that his albumin is slightly elevated. So this patient, on an incidental imaging of the abdomen, he had a 2 centimeter lesion in the segment 8 of the liver. That is all the finding that we have. And post this, we have confirmed this with a triphasic CT, which showed the classic arterial enhancement and washout. And in the background of a probable cirrhosis, usually we would classify this as a HCC without a histological diagnosis as well. Now, I want to know, in this setting where, okay, so still slides are not working. In this setting where you have a Child-Pugh A, well preserved, PS score 0, 2 centimeter lesion segment 8. So when this person comes to the hepatologist, what do you look at this in this patient? What are you assessing for? What biochemical parameters you are assessing for? And who is the first next referral point for you?
Thank you. Thank you, Ajay. It's a great question. I think in current situation, most of our patients won't agree for surgery upfront. And the resection and ablation both have shown similar efficacy in results wise, overall survival wise. So I would ask my radiologist colleague whether they will be helping us with ablation in this situation.
Okay, as sir rightly said, resection versus ablation is the usually what we actually try and see. Sir, do you prefer resection or ablation in this, or both are equal, or do you go based on the patient's wish?
Patient's wish most often, but ablation is preferred.
Okay, so coming to the interventional radiologist, Dr. Jignesh, what is your opinion on ablating a 2 centimeter lesion, and how would this fare?
So I'd first see the images and location of the lesion. If the lesion is in a easier location, straightforward ablation would be much safer, because long-term studies also showed similar efficacy of resection and ablation. And for a 2 centimeter lesion, we usually get a curative ablation zone. So that should be fine. That it would be a straightforward ablation case.
Okay, so this was the first case. So this was the 2 centimeter lesion that we are talking about. And this was a small HCC with a cryptogenic cirrhosis. And as we have discussed, microwave ablation versus resection is usually the thought process. But based on the classification, some way or the other, even liver transplant sometimes fits into this. Or so let's ask our transplant surgeon, for a small lesion like this, if someone refers to you for a transplant, would you go for it or you don't want to go for it?
As this patient is very well preserved, I think he is not having any actively decompensatory. Once he had hematemesis and it was addressed very well, I do prefer to go with the local therapy first and transplant as a salvageable option.
Okay, what he said is right. Even though in guidelines somewhere or the other we fit this in, transplant is only reserved for those patients in the salvage setting, or if they are not candidates for resection or RF ablation, which usually they are in most of the cases when they are quite fit. So again, resection versus ablation, usually the data suggests that more or less they are equivalent for small lesions. For little bigger lesions, Dr. Jignesh, what is your opinion on ablation? So say for example, it was a 5 centimeter lesion. Would you still ablate this?
We will not give ablation as a standalone treatment. If in IR setting we would add a TACE or something to it by doing a chemoembolization plus ablation for a lesion which is 3 to 5 centimeters.
Okay, so that is a totally different class. So basically for a small lesion, ablation is okay. For a larger lesion, we wouldn't think of definitive ablation. Okay. So this data suggests the same thing. Usually for a less than 3 centimeter lesion, where you call it as a BCLC-A or BCLC stage 0, 1 year, 3 year and 5 year survivals are more or less equivalent for ablation and resection. Though some data suggests that 5 year survival is a little higher in resection, marginally they are all equivalent. So I'll ask Dr. Prithvi, who is a surgeon here. So having said that both of them are more or less equivalent, still if you want to consider resection for a 3 centimeter lesion, what parameters are you looking at? And this particular case where I said this history, is this patient a candidate for resection or no, based on your clinical judgment?
So based on the clinical judgment, he is actually a case for resection, but having said that, all the parameters in the studies have proven that resection versus ablation, the recurrence, complications are everything same. But before answering this question, I would like to ask the intervention radiologist, doesn't it come under a high risk zone, close to the subphrenic diaphragm and chances of lung injury?
We'll get the image once. So
it's in segment 8.
In the single axial section, you see it is closer to the capsule. But when we usually do this under ultrasound guidance. We do not go directly straight in the plane that you're seeing. We usually go from inferiorly. So we'll avoid the diaphragm, capsule and all. So on ultrasound, I think this kind of lesion can be ablated safely.
Okay, now the question again remains.
Yeah, I would.
So what are your particular concerns regarding resection, or it's okay to go for resection in this particular patient?
Yeah, ultimately it's patient choice, but if you see resection versus RFA, all the parameters are same except that ablation is more cost effective. So I would be happier to send the patient to ablation because patient should not be suffering from the financial toxicity. After all, it's a simple 2 centimeter lesion.
Okay. There's one thing probably that Dr. Prithvi has missed. If Dr. Kishore can tell me. So this patient doesn't want RF ablation. He wants resection. You know technically it is feasible, but how do you choose the patient?
See, if at all, we can ablate through local therapies. Always we prefer local therapies. But sometimes some patients, they want curative kind of thing at one step. Some patients may prefer surgery also. And whenever there are certain difficulties in doing local therapies, like I already said, the subcapsular kind of thing, where there is a chance of risk of rupture kind of thing, in those scenarios also we can go for surgical resection.
Okay.
Or
Yeah, Dr. Sujana wants to make a point which I wanted her to get to this.
HPPG, whenever you're discussing about resection, I believe as a surgeon you do a HPPG, right, before?
Yeah, that is another important point when you look at, you don't want the portal pressure of the patient to be very high, because major liver resections, it's okay to have a lateral segmentectomy or a wedge or something, but major liver resections usually when we go, having a high HPPG, in one of the talks also we heard, usually
maybe this kind of lesion is a
okay.
Peripheral small lesion, it's okay, I think. We don't bother.
As again I said, major liver resection.
The patient doesn't have any ascites there.
But
Okay.
he has varices.
Varices,
So,
yeah.
Dr. Anand, if you see someone with varices, can it be taken as a clinical surrogate of having a high HPPG, or do you again have to go actually measure how much HPPG the patient has?
HPPG of 10 mmHg is required to form varices and more than 16 for varices to bleed. So he definitely has clinically significant portal hypertension, but already his blood 3 years back has controlled portal hypertension. I don't think there is any relevance of doing HPPG in this current situation given the lesion is too small.
Okay. But remember, always before doing a resection, at least do an endoscopy. If you find varices, it means, as sir said, at least the HPPG is more than 10, and this slide actually emphasizes the same. So if you take patient for a major hepatectomy and the HPPG is more than 10 or the bilirubin is more than 1, you can see that the graphs are quite dismal as compared to someone who has a low portal pressure. So this case scenario, I would, even if the patient wishes so, I would think he's an ideal candidate for an RFA rather than a resection. Okay, so this is the basic summary of what we talk about. We talked about 2 stages, stage 0 and stage A, single lesion, where we have all the treatment options, ablation, resection versus transplant. Transplant, we usually don't get it so early, but ablation versus resection. And in resection, when you want to go, you select the patient based on these characteristics which I spoke about. Now the next one is quite interesting because this is the one that has had the maximum change in the latest BCLC and also the updated INASL classification, which is the intermediate stage. Stage B, always remember, usually it was considered as multinodular. Now what they have done is they have subcategorized this into 3 different subcategories, which was not there before. The first subcategory is the extended transplant criteria, where you go little more than 5 centimeters and little more than 3 nodules. In these patients, you can offer a liver transplant. The middle variant is the classic one, which was always there with BCLC-B, that is well-defined nodules with preserved portal flow. They all go for TACE. And the last category is something that we all knew that they did poorly, like diffuse infiltrative kind. But previously, even they got TACE, but now there is increasing thinking that they should be given systemic therapy beforehand. So having said that, let's go to the case. So this patient was referred from outside the country, hepatitis B related cirrhosis with HCC. He was directly referred for a liver transplantation. On evaluation, he had an 8 centimeter lesion with the AFP, which is considered quite high, 5500. So basically he had grade 2 esophageal varices as well. So this patient with the 8 centimeter lesion, good performance status, would you consider a transplant or would you go for downstaging? Dr. Kishore.
As this patient is having AFP is very high, more than 5,500 is very high. So in transplant, considering transplant, we should see the patient's performance status as well as tumor burden and tumor biology. As AFP is very high, I think tumor is very aggressive, so I don't want to go for upfront liver transplant. First, I will try to go with the locoregional therapies and I will assess the tumor response. How the size is it regressing or not, and what about the AFP levels. If AFP levels reduce more than 50%, even then we will wait. It's better to have below 500. If the tumor responds well, then we can consider for, if it comes into UCSF criteria, we will go for transplant. Otherwise, we'll go with the other systemic therapies.
So what Dr. Kishore is trying to say is, he is trying to give time so that the disease biology can be assessed. He knows upfront that the size is more, AFP is high. These patients tend to recur earlier. So he wants to try for a downstaging. Dr. Jignesh, what is your opinion on doing TACE for downstaging versus a TARE for this patient?
Yeah. So in this scenario, in our Indian setting, if financial constraints are there, I would go for TACE. But ideally, theoretically, TARE would be better because the time to progression, imagine if there's a scenario where the donor availability is an issue, even in LDLT, and there would be a time frame where we do not know. I would first give them a choice of tear.
Okay.
Because tear, the time to tumor progression is more, and the during resection, post tear, these cases you'll have complete necrosis chances are higher.
Okay, but what he said is again patient affordability, because I think tear is 10 lakhs plus.
Yeah, 10
in
plus,
most
12,
centers.
13.
13 lakhs, okay, as you said, and TACE usually is. Yeah.
So if affordability is really an issue, if we have an adequate liver volume, even SBRT can be considered.
Okay.
So that is one thing.
Definitely I would add lenvatinib, because tactics trial, spaces trial and all those things have shown that there is some benefit in these patients. In intermediate stage, the addition of TKIs to TACE would be beneficial for these patients.
Okay, so basically you determine if the biology is poor, try to downstage it. If possible, add some sort of TKI is what sir is saying. So basically this patient did not undergo a tear, he underwent a TACE. The AFP dropped to below 500. The lesion reduced to 3.5 centimeter, which comes in the transplant criteria. The patient successfully underwent a transplant and now is disease free, I think 2 years post-transplant. So basically, this patient is again one of those doubts which most of you will get. Patient is an 8 centimeter lesion, single lesion. BCLC mentions that a single lesion usually is stage A, but why are we offering downstaging? These are the kinds of gray areas that we usually deal with. BCLC does not mention for very large single lesions, do we just go for resection or transplant directly or downstaging? But now with the INASL classifications and more consensus guidelines that are coming in, single lesions more than 5 centimeters usually are bad lesions. They usually should be categorized something similar to multinodular lesions, and that's why downstaging is an option in these patients. So basically this patient was beyond the extended liver criteria as well. So we did a TACE, downstage him, and then went for a transplant. So the next thing what I would want to point out is stage C. BCLC stage C, when you think about it, the only thing that usually used to come to our mind was systemic therapy. And the classic description was portal vein invasion, extrahepatic split, and poor performance status. Even a performance status of 1 was categorized as BCLC-C in the original BCLC. Now we have tried to, in practice, tried to segregate these patients. So there are a group of patients who have only a portal vein invasion, that to the later part of after the bifurcation of the portal vein. These patients don't have extrahepatic disease and their liver functions and their performance status is good. These patients can be offered some sort of downstaging and, if possible, a transplant. But in the other end of the spectrum, you have gross extrahepatic disease or nodal disease, which again go for systemic therapy. So we'll go to the case directly. So 58-year-old male, resident of Myanmar, hepatitis B and C. He was again directly referred for a transplant. On evaluation, this was the picture. So Dr. Jignesh, with your radiology background, if you see this image on only the CT image, is there a chance that you can miss a HCC in this patient?
Probably it depends on the experience of the person, but if you see the left lobe compared to the right lobe, left lobe is smooth, homogeneous, right lobe, there is a infiltrative kind of tissue. I wouldn't just like that go and say HCC, but there's one more typical finding, the portal vein. If you see the portal vein over there, it has a thrombus that is bulging, and probably if you have all the phases, we can see the enhancement and washout. So in these settings, the enhancement and washout will be seen not in the lesion, but in the portal vein much. And so that's how you go towards HCC.
So this was a diffuse infiltrative HCC, which you know by default are very bad tumors. Along with that, to add to it, there was a portal vein tumor thrombus. To start off with, basically, this was the radiological summary of the patient, diffuse infiltrative HCC with the right portal vein thrombus. So these patients, you know they are biologically bad. Dr. Kishore, would you consider downstaging this, or would you just go for a systemic therapy?
See, with the transplant for HCC, now a lot of gray areas are there, and still, once it was a contraindication, later it became one of the most common indications. Portal vein invasion is also, once upon a time, it was like a contraindication, but now it depends on the location and extent of the portal vein thrombus. Like as you said, it's a secondary branches and beyond. It's not no more a contraindication. But like the extensive thrombosis, still with the advances in local regional therapies and systemic therapies, still we can give a trial of downstaging the tumor.
Okay. Dr. Sujana, would you want to add if there is role for radiation in these patients, EBRT or SBRT for downstaging?
So this lesion is quite infiltrative. So I would probably refrain from adding SBRT upfront because the entire right lobe is kind of occupied. So we'll only be left with the left lobe, and I am very pessimistic about the volume what we are going to spare with the normal liver.
Okay.
So at least if we can add a different form of local treatment, I would really happy to handhold this patient and hand it over to Jignesh if possible for tear or something. Or if not, give some systemic, downsize it, and then add some local treatment.
Dr. Jignesh, TACE I know doesn't work because portal vein is thrombosed. Does tear work in this lesion?
So tear, we would target the lesion proper, and for the portal vein, we will try to target the portal vein. If not, if the liver function is fine, we would do tear. Within the first month, we would go for, we would
Combined.
ask them for SBRT.
Both of us will work together and do a combined approach.
Okay. But have you forgotten the medical oncologist in this?
That's the first thing I told. We'll add some systemic, try to downsize it, if not local treatment, and then reassess for local treatment.
Okay. Dr. Bharat, so this is not a metastatic disease. It is still localized but quite aggressive. So what is your first choice for systemic therapy, considering the latest guidelines and the evidence that we have?
Before I tell my options what to treat, I'll say we as a clinicians should never give up. That is the first thing. Yes, guidelines says that this is a bad disease, but there is always two tail of the bell's curve. There is always somebody who is prolongs at the end of the tail. So there is 1 out of 100, maybe with a proper consent, proper explanation, we should keep fighting till the end. So in this particular case, if you ask me, if an immediate surgical intervention is not planned from either of the side, then atezolizumab will be the first option where immunotherapy combination with VEGF inhibitors. There is data that other immuno combinator like tremelimumab and ipilimumab is better, but cost increases, the toxicity increases in terms of the immune side effects. Those are the two things. So either of these two agents we can offer. Since the response rate with sorafenib, lenvatinib or any of the TKIs, the major response is stable disease. Wherever it is, it will remain more or less similar. I can't expect a tumor reduction. So until unless there is a financial crunch, somebody cannot afford atezolizumab, then probably I will offer take TKI. Otherwise, atezolizumab remains the option. And never to give up. This is the perfect example where these type of the cases actually produces result for future exploratory studies. Today's contraindication becomes tomorrow's indication, where we can, at least minority of cases, we keep on doing everything. Few of the cases can achieve a long-term control.
But unfortunately, that is not the truth, as you would see when we go ahead in this case.
There is always end of the tail. Somebody will survive longer.
Dr. Anand.
Recently, we have published on this. Immunotherapy atezolizumab followed by downstaging to transplant. 120 patients, 10% were able to achieve transplant, and only 10%. Out of them, only 5 to 6. So, yes, the hope is there, but it should not be over.
So even though the chance is minuscule, you can give that option to patient, but in a case like this, being over enthusiastic usually leads to failures, is what we.
Obviously, with this tumor volume, it's always, even though patient responding very well, it's always better to wait for a certain period of at least 3 to 6 months and assessing the trend of the tumor biomarkers and all these things before going for transplant.
Exactly. What he said is a very right thing to do. Actually, 6 months is best. 3 months is at least what you should wait once you downstage, at least to go for transplant, because you do a transplant immediately and patient eventually fails, then your whole exercise and the risk that you have put the patient through is usually a waste. Fortunately, this patient responded to the therapy that we gave, SBRT along with immuno. And then this patient went for a transplant after 3 months. But there was viable tumor in the portal vein along with the primary as well, and the patient recovered after 9 months. So as I said, in few cases you have success stories, but most often than not, the doctor knows what kind of patients usually fail and what kinds usually succeed. Now this is a fourth case where usually this is a what you call as a classic metastatic HCC, which is in BCLC-C again. So this patient had bilateral liver lobe. Yeah.
Previous case I forgot to tell, he's double positive HBV as well as HCV. To offer me for me to offer atezolizumab combination, I have to have the viral load below certain level. So that is
missing.
That is like I said atezolizumab, but if HBV levels, HCV levels are too high, probably then I will be little hesitant to offer.
Do you have an alternative?
Then the only alternative is TKIs.
Okay. So this fourth case is a 60-year-old from Bihar, alcoholic with liver cirrhosis, however preserved liver function and good general condition. Imaging showed a multinodular HCC with bone, lung and adrenal mets. Biopsy was HCC. So again, stage C, what we reviewed, this falls on the extreme where you would offer these patients systemic therapy. The previous case, what we discussed was a portal vein thrombus where we tried to do maximum that was possible. And in this case, usually it's systemic therapy. So Dr. Bharat, so can you just take us through this chart? This is from the BCLC latest guidelines.
Yes, atezolizumab has been standard of treatment options from almost 2021. While working with Dr. Anand and AIG, Dr. Sujna, initially we used to criticize, but now it's a standard of care. Dhruva Tremi is the second, which is numerically better compared to sorafenib. From atezolizumab, numerically better. This will be a cross-trial comparison when I'm comparing atezolizumab versus Dhruva. But yes, it is a fair option. The cost is almost double. The immunotoxicity is almost double. But toxicity of immunotherapy is somewhat different than tyrosine kinase inhibitors, where you patient develop hand-foot syndrome. Immunotherapy side effects are usually hypothyroidism, hormonal disturbances, autoimmune disorders. But still it remains the first line considering no financial crunch. As a second line, or in a first line, if atezolizumab immunotherapy not possible, then TKI is what we offer. As a second line, choice remains cabozantinib. Regorafenib is a difficult option to give at a full dose. So normal dose is 160 mg. Most people start developing symptoms of TKI treatment rather than the disease at say 160 mg dose. So cabozantinib. Ramucirumab remains a fair option considering the cost. It is yet not generic. Eli Lilly is the only people who is producing it. So these are the two lines. If we have not exhausted cabozantinib, then a third line we can have a cabozantinib. But if we have exhausted in second line, nothing more than clinical trials we can offer. Practically all medical oncologists do a little bit of juggling around. Somebody has received TKIs in the first line, immunotherapy in the second line, then again re-challenge with TKI. Response rate is single digit. Don't expect much of response rate.
So just a question to Dr. Anand. Yeah. So I want to know what should the performance and the liver status of this patient be, and would it make a change to what you offer? So one thing just to summarize, till recently what we had was only sorafenib. For all sorts of systemic therapy, it is only sorafenib in whatever you want to do, and along with lenvatinib. Now we have two first line options, atezolizumab along with Durva and Tremi. As he said, most centers have shifted to atezolizumab. Some are using Durva Tremi for some reasons, like bevacizumab contraindicated or so and so. But what I want to know is, what profile of patients tolerate this systemic therapy? Should their liver function be absolutely fine and their performance status be absolutely fine? Dr. Anand as well.
Child per gay is the actually preferred. All the clinical trials included performance status 0 and child per gay. But in clinical real world scenario, most of our patients fit into B7 or B6. That is then our maximum B8. Beyond that, we don't go.
But you want a preserved liver function.
Bilirubin more than 3, strictly no. That's what I.
Yes. So, see, HCC is not lymphoma. Lymphoma, even if patient is near death, you give the full-blown treatment and expect a response. Majority of cases, first of all, response rate is not as high as it ranges around 30-40%. Majority response is stable disease, and it takes time. Even if you see the chart, the response started after 6 weeks of time. So if you are expecting a very poor performance status in which patient might die at any point of time, giving any of the treatment options may satisfy clinically, but it may not help the patient because the therapy will not have adequate time to improve. So that is regarding the fitness. Above 3, we are kind of hesitant to offer the treatment, even though immunotherapy by default has been offered case-to-case basis at high bilirubin also.
Okay, just a last point. That was a good point. Why I asked this question at the end was, what you always look in the BCLC is tumor burden. You look at single nodes, multiple nodes and everything. But what you forget usually is BCLC 0, A, B and C. All of them require that the patient has a preserved
are medium and severe kind of things. So they are individualizing the and
just a last point, Dr. Anand, these patients usually come to you. Small tumor, decompensated liver disease, good performance status. Will you refer for transplant or no? Transplant? Okay, fine. Yeah, that was the last word. Thank you so much. Yeah. Sir.
I would like to extend my heartfelt thanks to all our panelists for making this session so engaging and interactive. May I now request our moderator, Dr. Ajay Varun sir, to kindly present the mementos to our esteemed panelists as a token of appreciation. I kindly request Dr. Anand Kulkarni, sir, Senior Consultant Hepatologist, AIG Hospitals, Hyderabad, to kindly accept the memento. Dr. Kishore Reddy sir, Senior Consultant, Liver Transplant and HPB Surgeon, Medicover Hospitals, Hyderabad. Dr. Prudhvi Raj sir, Consultant, Surgical Oncologist, Kim Sunshine Hospitals, Hyderabad. Dr. Jignesh Reddy sir, Dr. Sujna Priya ma'am, so 1 minute. I now request Shivankar sir, Center Head of Medicover Oncology Institute, to present memento to our moderator, Dr. Ajay Varun sir. I now request Dr. Dilip sir, Medical Head of Medicover Madhapur, to present mementos to our speakers. Dr. Raj Bharat sir, Dr. Sunil Kumar sir, Dr. Sai Teja sir, Sunil Kumar. Sai Teja. Dr. Sriman Narayana, Dr. Ajay Shinde sir, Dr. Praveen sir,
As we move into our focus segment on biliary tract cancer, it is my privilege to invite a highly respected leader in the field of surgical gastroenterology to chair this session. Please join me in welcoming Dr. E. Vimlakar Reddy, HOD and Senior Consultant, Surgical Gastroenterologist and Liver Transplant Surgeon at KIMS Sunshine. Dr. Vimlakar Reddy is renowned for his surgical expertise and leadership in liver and biliary sciences. Please join me in welcoming Dr. Vimlakar Reddy. I now request Dr. Dilip sir to hand over a bouquet to Dr. Vimlakar Reddy. I request Dr. Vimlakar Reddy sir to please be seated for the next further sessions. We now move on to the first expert talk in this session on biliary tract cancer. It is my pleasure to welcome Dr. Arun Arora, Consultant Medical Gastroenterologist at Medicover Hospital, who will be speaking on the topic role of EUS in biliary tract cancer. Over to you, sir.
Hello everyone. Today my topic is role of endoscopic ultrasound in biliary tract cancers. Mostly it is in diagnostic and therapeutic perspective. So my topic covers in following headings: introduction, EUS, its diagnostic role in staging and FNAC, therapeutic role of EUS like EUS guided biliary interventions, which includes EUS hepaticogastrostomy, EUS choledochoduodenostomy, EUS antegrade biliary stenting or biliary drainage, EUS rendezvous and EUS gastroenterostomy, and EUS gallbladder drainage. So introduction, biliary tract cancers comprise of malignancies of bile duct like cholangiocarcinoma, extrahepatic bile duct, perihilar cholangiocarcinoma and gallbladder cancers. Among this, gallbladder cancer is the most common. So coming to the basic of EUS, EUS uses an endoscope equipped with ultrasound transient trips. So it uses a frequency of 5 to 20 megahertz. Okay. So there are two types of EUS, the radial type in which ultrasound images are acquired perpendicular. You can see over here. And the convex type, linear type, in which ultrasound images are acquired parallel to the endoscope. The radial EUS depicts 360 degrees of the field of view, and the convex linear EUS has 180 degrees field of view, and it is used for tissue acquisition and interventional endoscopic ultrasound. So the role of EUS in cholangiocarcinoma staging, tumor detection and localization. The EUS is better for distal cholangiocarcinoma compared to hilar cholangio because it is operator dependent, and the hilar cholangio is sometimes difficult to access with EUS. Advantage of EUS is it can visualize bile duct wall thickening in early cancers, masses and adjacent organ involvement. EUS can help in T staging, can assess depth of invasion and local spread, helpful in determining resectability. And other role is lymph node involvement. In staging, EUS guided FNAC allows sampling of suspicious regional and periportal lymph nodes, more accurate than CT and MRI in detecting microscopic nodal metastasis. So CT and MRI may miss small nodes which can be picked by EUS FNA. So EUS can also assess portal vein invasion, hepatic artery, celiac axis and SMA, and can help in assessing surgical resectability. EUS can also help in FNB of primary lesions, suspicious lymph nodes or liver metastasis. Okay, and the FN of hilar tumors is usually avoided because if surgery is planned, it is usually avoided because of risk of tumor seeding. So how can we take sample? So EUS has different needles ranging from 19 to 25 gauge. More is the gauge, less is the diameter. So for EUS 19 gauge needle, for solid lesions we can use 19 gauge needle for sampling. For cystic lesions we can use 22 gauge needles for sampling of the fluid. So for solid lesions 19 gauge needle is used, and for cystic lesions 22 gauge needle is used. So here is the example of the EUS of the distal cholangiocarcinoma. FNE was done using 22 gauge needle of the distal CBD. You can clearly see there. So after EUS FNAC, rapid on-site evaluation is done and cholangiocarcinoma is detected. So EUS FNAC can help in rapid detection. We can include a pathologist in the same session, and they may give you the diagnosis within half an hour. So we get the diagnosis within half an hour with the help of EUS FNA. Here you can see the hilar mass. FNAC of the hilar mass is done from the D1. Okay, it requires expertise. So to take FNB from the hilar mass from D1. So here the sample showed adenocarcinoma. So we can get the results very quickly. So that is one of the advantages of EUS. It helps in staging and diagnosis. Okay. So what are the limitations of EUS FNAC? In the hilar masses and the intrahepatic tumors, it is very difficult to get the sampling, and it is operator dependent. So highly skilled for the hilar and easy to get from the distal cholangio actually. And there is a risk of middle tract seedling, especially in potentially resectable patients. So EUS FNAC, one of the role is diagnosing, and FNB from the distal cholangio and the hilar lymph nodes and the lymph nodes is easy, but FNAC from the hilar cholangio is difficult and usually avoided. Only sampling from the hilar lymph nodes can be done. What are the different types of EUS guided biliary drainage? So if the block is distal, that is in the distal biliary obstruction, the type of drainage is different. If the obstruction is in the hilum with both the right and left ducts communicating, the type of EUS BD is different. And if the hilar biliary obstruction is there with non-communicating right and left ducts, the type of biliary drainage is different. So in distal biliary obstruction, we usually do choledochoduodenostomy, that is drainage of the bile from the duodenum to in the CBD. So we place a stent from D1 into the CBD in the distal CBD in distal biliary obstructions. In hilar biliary obstruction, with both communicating stream, like both the right and left hepatic ducts are communicating, we usually do hepaticogastrostomy. So with hilar biliary obstruction with non-communicating systems, we usually do bridging procedures, that is hepaticogastrostomy with stent placement, draining to the right and left. I will show this in the next further slides. So according to ASG, what are the definitions, terms and definitions according to the guideline? So EUS guided biliary drainage includes EUS to puncture intra or extrahepatic ducts. The 4 techniques are described, which include EUS guided rendezvous procedure, EUS CDS, that is EUS choledochondrostomy, EUS hepaticogastrostomy, and EUS guided antegrade interventions. So I will come into this while showing the figures like EUS CDS, EUS HGS. I will show in the next slides. So what are the principles of biliary drainage in hilar obstruction? Draining more than 33% of the liver should suffice in patients with preserved liver function, while draining more than 50% was needed in patients with impaired liver function. So at least minimum of 50% of liver segment should be drained in biliary obstruction. So a multicenter study from France on assessment of biliary drainage by liver volumetry showed that draining more than 50% of liver was associated with improved survival than draining less than 50% in malignant hilar biliary obstruction. And 71% is the optimal volume of liver to be drained for adequate chemotherapy to be given in patients with malignant hilar biliary obstruction. So at least more than 50% of the liver segment should be drained. So what are the indications for EUS biliary drainage? One is the failed ERCP. If the EUS cannot pass the hilum, the hilar stricture, so the other option available is EUS guided biliary drainage. In surgically altered anatomy, as the ERCP scope is difficult to pass, in that through the EUS we can access the liver biliary ducts through the stomach. In patients who have failed reinterventions of occluded transpapillary stents, EUSBD is mainly used for inoperable patients, although EUS rendezvous can be done in the preoperative settings. So what are the contraindications for EUS biliary drainage? Gross ascites, intervening blood vessels for the EUS, and coagulopathy and patients unfit for endoscopy. These are the contraindications for EUS biliary drainage. One is the gross ascites and the intervening blood vessels. So what are the steps for EUS guided biliary drainage? See, this is a picture depicting EUS hepaticogastrostomy. These are the steps for all the EUS biliary drainage. First, we should puncture the biliary tract using EUS FNAC needles, and to confirm the needle in the biliary tract, we should aspirate the bile and check it. Afterwards, followed by contrast injection, followed by guide wire should be manipulated across the hila into the distal CBD into the duodenum. So here, first puncture the biliary radicals, aspirate the bile, inject the contrast, followed by guide wire manipulation into the D2, tract dilatation and stent deployment. Okay. So here in that image you can see the needle in the bile duct, intrahepatic biliary radicals. So this is a graphic depicting the steps of doing EUS hepaticogastrostomy. So the optimal parameter when choosing the duct, intrahepatic duct for puncture, it should be at least more than 2.5 from the liver capsule surface. And the angle between the FNA needle and the longitudinal axis of the bile duct should be more than 135 degrees. With these measures, most of the time we succeed in doing hepaticogastrostomy. Here in this slide it is showing segment 2 and segment 3 biliary radicals. So which one to choose? So while choosing drainage of gaining access into the EUS hepatic ducts, segment 2 and segment 3 are most commonly used. But when compared to segment 2, third segment biliary radicals are easy and safe because they avoid puncturing the pleura. You can clearly see that in the image B, in B2 segment. So there is a chance of the needle coming through the esophagus, puncturing the pleura into the BD. So it's always better to go down into the stomach, push the scope and use the big wheel up and puncture the B3 segment so that the guide wire can be passed easily across into the hilum. So always better to choose B3 segment for EUS guided hepaticogastrostomy. See, this is same showing the needle direction aims towards the hepatic column, allowing successful viral passage in the image A. So if the scope is curved upwards, the guide wire passes easily into the hepatic left hepatic duct. In the image B, the needle direction is perpendicular to the target bile duct, and making the wire manipulation towards the hilum is difficult. So, okay, an unstable scope position causing looping and displacement of the equipment. So, thing is, the scope should be in the upward direction, and the needle should be along parallel to the bile duct direction. So, wire can easily go across into the hilum. And followed by stent deployment, this partially covered SEMS, which has uncovered part intrahepatic and covered part between the liver and the stomach. So there are different types of stents for US hepaticogastrostomy. Most commonly used is a Geobar stent from Taiwan Medical and Hanaro stent. A and B are the most commonly used stents for US hepaticogastrostomy. So this is an example showing graphical representation of US gate hepaticogastrostomy in type 1, type 2 hilar block. So in type 1, type 2, and as the right and left hepatic ducts are communicating, a single stent would suffice. Okay. And this is figure 3 showing graphical representation of US gate hepatico-duodenostomy in type 3 and type 3 hilar blocks. So in complex hilar blocks, like in type 3 and type 4 hilar blocks, we should drain both the right and left ducts. For that, double stents are required. One stent, it is called bridging stent placement in hilar obstruction with involvement of primary biliary confluence. Uncovered SEMS was placed between the right and left systems. So you can see the hilum, uncovered stent was placed, and with this is second stent is partially covered stent. So partially covered stent is placed between the liver and the stomach, and fully uncovered stent is placed in the hilum. So for complex hilar strictures, double stenting is required. So coming to technical and clinical success, technical and clinical success is easier for type 1 hilar blocks, but for type 3, type 4 hilar blocks, the technical and clinical success is slightly less. It's a busy slide, I am just summarizing it. For type 1, type 2 hilar blocks, technical success is more. For type 3, type 4 hilar blocks, the technical success is very less. So what is the biliary drainage for malignant distal biliary obstruction? So USBD for distal obstruction can be performed by 3 different techniques, like cholecystogastrostomy between the gallbladder and the stomach, cholecystoduodenostomy between the gallbladder and the duodenum, and the choledochoduodenostomy. I would like to concentrate more on the choledochoduodenostomy, the placing stent between the gallbladder and the first part of duodenum in malignant distal biliary obstruction. So what are the indications of EVS biliary drainage for the malignant distal biliary obstruction, like distal cholangiocarcinoma, ampullary tumors, and pancreatic cancers causing distal biliary obstruction and upstream dilatation? So in that cases, what we can do is we can place a stent between the D1 and bile duct, as the proximal bile is very much dilated, like more than 2 centimeters. Sometimes we can place the stent from the antrum into the CBD. So this is US CDS for distal biliary obstruction. And other indication for US BD is failed ERCP, because as the tumor blocks the D1, there is it is difficulty for the scope to pass into D1, D2, and for ERCP, when the ERCP fails, we can't place a stent. And duodenal obstruction. So in all these cases, we can place a stent that is called EUS choledochoduodenostomy between D1 and CBD. So this is a image depicting EUS choledochoduodenostomy. See, that is a hugely dilated common bile duct appearing like a gallbladder. So we have to carefully see and puncture using 22 gauge FNAC needle, and the contrast is injected to confirm the position of the CBD, followed by tract dilatation and stent deployment. So US choledochoduodenostomy is mostly done in patients with biliary duct obstruction, distal biliary duct obstruction. So sometimes lamps, instead of long stents, lamps can also be placed between the D1 and common bile duct. So these are different types of cholecystogastrostomy, cholecystoduodenostomy, and choledochoduodenostomy. So in this, after locating the target organ, the distance between the tip of US scope and the CBD should be less than 1 centimeter, and a Doppler should be done to evaluate any intervening vessels. So actually for choledochoduodenostomy, the lamps, this is the lamps, the inner diameter is between 6 to 8 millimeters. It is placed between the first part of duodenum and CBD. And the CBD diameter should be at least more than 50 millimeters, 15 millimeters, for the lamps to be placed. Okay. So what are the advancements that we can expect? Peri-procedural, there is bleeding, perforation or pneumoperitoneum, sometimes bile leak, cholangitis, stent obstruction can occur. It is seen very early as we puncture the bile duct from D1. So what are the late complications? That is stent migration proximally into the CBD, buried stent obstruction with the foot, and some syndrome, that is when you place the stent between the D1 and CBD, the part distal to the stent becomes dilated and bile gets collected in the distal part of CBD. So it gets infected, that is called sump syndrome. So these are all the complications that can occur with EUS CDS. So these EUS biliary drainage are highly skilled procedures. They should be done by a trained endoscopist. So what are the comparison outcomes? The technical success rate, clinical success rate are similar between hepatico-jejunostomy surgical and the EUS hepatico-gastrostomy. So adverse events are more with percutaneous transhepatic biliary drainage that favors EUS biliary drainage. Okay? When compared with EUS hepatico-gastrostomy, EUS CDS is more favorable for malignant biliary obstruction. Okay? Stent patency, there is no difference. When compared to percutaneous hepatico-gastrostomy, when compared to percutaneous transhepatic drainage, EUS CDS is better. Okay? When compared with EUS hepatico-gastrostomy, EUS CDS is far better than PTBD also. So another is the final one, EUS gastrojejunostomy. What are the indications for EUS gastrojejunostomy? One is malignant gastric outlet obstruction due to biliary tract cancer like gallbladder cancer, distal CBD cancers, failure unfit for surgical gastrojejunostomy, recurrent gastric outlet obstruction after enteral stenting. These are the most common indications for EUS gastrojejunostomy. So what are the types of EUS gastrojejunostomy? There are two types, direct freehand technique and balloon assisted. This is the image showing the direct freehand technique. Once you can see the duodenal stricture due to the pancreatic head mass, or sometimes the gallbladder cancer also can cause, or distal duodenal malignancy can also cause obstruction. So we pass the guide wire across the narrowing into the D3, D4, and over that a nasobiliary drain catheter is passed over the guide wire, and water is filled between the D3, D4 and proximal jejunum, and EUS probe is passed so that the fluid is seen, and the lamps, electrocautery guided lamps can be placed across the stomach into the jejunum. So that is called EUS GJ. So here you can see the guide wire is passed across into the D3, D4, and nasobiliary catheter is passed over the wire into D3, D4. You can see in the B, the fluid filled jejunum or D4, and in the figure C you can see the lamps getting deployed into the proximal jejunum from the stomach. Okay. So to summarize, in malignant gastric obstruction, if the life expectancy is more than 3 months, there are two options, surgery or EUS gastrojejunostomy. If the life expectancy is less than 3 months, if there is biliary obstruction, ESC plus biliary stenting is okay. If there is no biliary obstruction, diet duodenal stenting is okay. So in a nutshell, if the life expectancy is less than 3 months, only plain ERCP and stenting is okay. If the life expectancy is more than 3 months, surgery or EUS gastrojejunostomy can be done. Okay. So I'll stop it here. Okay.
Very good, Arun. So my small clarification. Yes. Because biliary drainages are done for the purpose of palliative care, yes, as well as preoperative biliary drainage. Before going for the surgery, if somebody is having really cholangitis or malnutrition. But whatever you said, this hepatico-gastrostomy, hepatico-duodenostomies, as a part of biliary drainage, usually being a surgeon, we won't advise, because as you all know, the stents are enemies for surgeons.
Yes, yes, sir.
And if you see the concept of the stenting, part of stent will be lying freely in the peritoneal cavity, which attracts a lot of adhesions and causes problems.
Yes, yes.
And we have seen few cases where they tried for the hepatico-duodenostomy, and you're doing anastomosis between a solid organ and a luminal lumen. So both the structures are different. In that, So the stent staying percentage is less, and that wrong tracking is very high. We have seen cases with the perforations and landing in emergency for the emergency people, emergency surgeries. And with that, not only having complications definitely will come down with the experience and all those things. But if it is for the purpose of preoperative biliary drainage, if the patient is not having cholangitis, if you're not contemplating any hepatectomy, if there is no malnutrition, whatever may be the bilirubin, we can go ahead with the Whipples. But if you're contemplating hepatectomy, definitely you need to have a less than 3, or few people will consider up to 5, but less than 5 bilirubin. So this small clarification for the house. So if it is for the purpose of palliative care, definitely when you compare external drainage versus internal drainage, obviously internal drainage is very physiological and it will give very good comfort as a part of palliative care. But for the purpose of preoperative biliary drainage, usually not to go ahead with such big procedures, because definitely complication rate is, to be frank, I am telling, we have seen a number of cases and landing in emergency. And definitely it will cause problem while doing surgery.
I completely agree, sir. Thing is EVS hepatico-gastrostomy is mostly done in inoperable patients in our setup.
That's what. In that, in indications, malignancy is there. So I want to make it clear,
okay.
As a part of palliative care, definitely accepted.
Sir, as you said, as a preoperative period, preoperatively, so I think EVS antegrade stenting is better, sir. It actually, antegrade stenting is we place the stent into the CBDA.
So that definitely can be done.
Preoperative procedures, we place the stent within the CBD, so that will be helpful.
That is definitely. Always internal drainage is 100%. That can be done EVS guided, or else you can go for P2BD, go down, put your stent down and replace within 48 to 72 hours with the SEMS.
Okay, thank you.
Thank you, sir, for that comprehensive and insightful talk. We now move on to our next speaker, Dr. Santosh Narayankar, consultant gastroenterologist at Medicover Hospitals, who will be speaking on the topic endoscopic retrograde cholangiopancreatography in BTC. We welcome you, sir.
Good afternoon, everyone. So today's topic is about the biliary tract cancers and role of ERCP in these patients. So, slides please. Slides please. So we have here for discussion role of ERCP in these biliary tract cancer patients. So already Dr. Arun has discussed about the US. Now US has become a go-to test for diagnosing and evaluating the staging of the biliary tract cancers. ERCP has left with mainly the palliation role. So we know ERCP is mainly for the stenting of the biliary tract in patients who are having malignant biliary obstruction, and both in as well as biliary as well as pancreatic cancers causing obstruction. It has a role of diagnosis, palliation as well as treatment in some cases, and the stenting depends on the number, location of the tumor as well as and how many stents to be placed is based on the MRCP. At least 50% of the liver should be drained for the management. So choice of the stents, metal stents or plastic stents, both have similar efficacy and depends on the personal choice and availability and stage of the disease. So we all know biliary tract cancers, either it may be intrahepatic cancer or it may be a perihilar cancer, gallbladder cancer as well as distal biliary cancers. So intrahepatic, they usually present with the liver mass and underlying existing cirrhosis or hepatitis B or any pre-malignant conditions, and they can be addressed by hepatectomy and other things. For perihilar cancer, ERCP plays a major role. Here, it plays both as well as palliation as well as the diagnosis of these cancers. And whenever gallbladder cancer is there and it has involved cystic duct or common hepatic duct, then also palliation is required in these patients. And distal biliary obstruction, again, it is mainly for the drainage of the biliary system, ERCP is advocated, as well as for the diagnosis by brushings. So whenever patient presents with a painless jaundice, we have cross-sectional imaging study showing a bile duct dilatation with or without associated mass lesion. So in that cases, we do ERCP and take brushings, or some cases we may take direct biopsies in these patients when distal growth is present. Along with that, we also have CA19-9 and IgG levels to be checked to rule out the IgG4 disease. So whenever we have a dominant stricture in the CBD or CA19-9 elevated, and UAS can be done for staging in these patients and get the lymph node biopsies for the staging. And if negative cytology, biopsies and CA19-9 is less, then repeat studies every 3 to 4 months, considering as a indeterminate biliary stricture. So whenever the biliary tract malignancy is diagnosed, and if it is operable, always consider surgery before, if it is operable and bilirubin levels are less than 3 to 5. And inoperable and meets transplant criteria, when perihilar cases, consider liver transplant in these patients and consider downstaging whenever possible and advocate for transplant. And if it is not a candidate for transplant as well as the surgical candidate, then consider systemic therapy as well as metal stent placement for these patients. So ERCP plays main role in diagnosis, tissue acquisition, palliation, and therapeutic treatment also in these patients. In diagnosis, whenever we have a biliary tract cancer, it may be periampullary cancer, it may be distal biliary or perihilar. So in periampullary cancer, we usually do direct biopsies under endoscopic vision, and if there is a distal biliary cancer, we do biliary brushings. Then if at all it is in perihilar region or in the distal biliary, not brushings are negative, then consider EUS guided FNA in these patients. Sometimes, so brushings as well as FNA may be negative. In that cases, direct cholangioscopic guided biopsies can be done in these patients. So we also can do MRCP and CT and serological markers for diagnosis. So which one to consider for diagnosis, EUS FNA or ERCP? Nowadays, whenever patient presents with biliary tract obstruction, we first consider EUS FNA as a primary test because it gives both staging as well as the diagnosis at the same setup. If FNA is not possible in these patients, then consider ERCP and brushings. But in patients where intrahepatic and proximal hilar, they are difficult to get a FNA from the US, then we consider ERCP as the primary choice and take brushings from the stricture site. So even though brushings are routinely being done, it carries only 40% accuracy in diagnosis of these patients. And to increase the sensitivity of diagnosing brushings, we can do dilate the stricture before taking brushings, and which increases the yield up to 70% times. So direct biopsies can be taken for periampullar lesions and distal biliary strictures sometimes after the fluoroscopic, under fluoroscopic guidance after sphincterotomy, we can consider doing direct biopsy from the under fluoroscopic vision. So this is one of the pictures showing periampullary lesion where we can take direct biopsies from the endoscopic vision. And in one of the picture here, we can use a SPY scope, that is which can be passed through the ERCP scope, and directly under cholangioscopic vision, we can take biopsies from the tumor so that diagnosis can be yield. At least 6 to 7 SPY bites should be taken to consider it to increase the diagnostic sensitivity. So main role left for ERCP is now is palliation, mainly to reduce the bilirubin levels preoperatively or for advocating neoadjuvant chemotherapies. In patients who are having mainly biliary tract, distal biliary tract cancers or resectable pancreatic cancers, we have to patients are being planned for chemotherapy, in that case, we usually, medical oncologist asks for stenting, preoperative stenting for, even for surgeons, they ask for preoperative stenting if there is even though there is no cholangitis, to decrease the bilirubin levels to less than 2.5, because it increases the overall post-surgical outcome. So that palliation improves, and jaundice levels once reach bilirubin less than 2.5, there is increased outcome. If at all some patients who can undergo surgery within 1 week of diagnosis, when head-to-head studies have shown that if to bilirubin up to 14.6 with no cholangitis in present, the ERCP patients who had preoperative ERCP had more complications compared to the surgical patients. So in palliation, we can preoperatively or neoadjuvant treatment, we can consider putting a plastic stent in these patients. Preferentially 10 French plastic stent is placed, which improves overall good biliary drainage. So until we achieve surgery or unresectable stage, we have to continue exchanging these plastic biliary stents every 3 months. What if ERCP fails? Then, as already Dr. Arun has discussed about the different modalities of drainage of biliary system, if at all ERCP fails, then we have EUS guided randomized procedures. But endoscopic palliation is highly successful. It has low morbidity and mortality compared to all US guided as well as surgical bypass procedures, and cost effective compared to the other approaches. So biliary stenting for hilar strictures, here always confusion arises whether to go for ERCP or PTBD at the beginning of the setup itself, because ERCP sometimes wire may not be passed beyond the biliary strictures. In that case, PTBD is the option of choice. So whenever we have confusion, we have whether to go for unilateral stenting or bilateral stenting of the both the ducts. So at least aim should be there at least to drain 50% of the liver biliary system, so that there will be a good outcome after the surgery if at all planned. So whenever we have bismuth grading 1 to 4, in that usually bismuth 1 patients can be having a single stent is sufficient for draining the biliary system, but in bismuth 4 multiple stents are required, and it should be guided by the MRCP. So whenever we are considering ERCP in these patients, we usually avoid cholangiogram because it can cause sepsis and lead to cholangitis in these patients. So we call successful ERCP and stenting in patients when there is a significant decrease, that is 30 to 50% of reduction in bilirubin levels. We consider it as a successful stenting. Which stents to choose? In these patients, plastic versus metal stents. Plastic stents, usually the 10 French stents can be placed side by side in hilar strictures. They are equally efficacious compared to metal stents, but in bismuth 4 type of complex hilar strictures, metal stents are superior to plastic stents. But in metal stents, whenever they have metal stents, there is a difficult to re-intervene when there is a tumor ingrowth into the metal stent. In that case, again, we have to go for a plastic stent placement in stent place. So these are the few pictures where we are seeing hilar strictures. Metal stent has been placed into the left system, and also in other case we can see bilateral plastic biliary stent placements. So other endoscopic ERCP can also help in palliation in the form of photodynamic therapy and RFA, even though these are all not being routinely used, but they can loco-regionally can manage these biliary tract cancers and increase the overall outcome. Though prolonged survival improvement has been shown in these patients, but the downsides of photodynamic therapy or RFA is there is a high cost repeated ERCP procedure and technical difficulties in these patients. So other than that, also we have endoscopic procedure, which is ampulectomy, which can be used, potentially can cure the periampullary carcinoma in these patients. So whenever we have a option diagnosis of a periampullary carcinoma, we have to evaluate with endoscopic ultrasound, and biopsy has shown that papillary or well differentiated tumor, and usually there is no invasion of the duodenal wall or no PD invasion, and PD size is normal, CBD is not dilated. We can consider endoscopic ampulectomy in these patients, and which can potentially give the curative option, but it should be considered in patients who are unfit or not willing for the surgery for major surgical procedures. So ERCP again after the surgery, if some patients undergoing biliary tract cancers underwent surgery, then what is the role of ERCP? Sometimes post-operatively patient may develop bile leaks, there may be anastomotic site strictures, and sometimes during the surgery some stents are placed to remove the stents, and in these cases also ERCP is indicated, and ERCP can be done safely after 1 or 2 weeks, but we should remember that we have to discuss with the surgeon prior to proceeding for the ERCP procedure, because it requires a lot of scope manipulation during these post-operative patients. To conclude, usually management of these biliary tract cancer through ERCP requires multidisciplinary approach, because whenever ERCP is failed, we may have to require interventional radiologist help, we may have to approach surgical oncologist for drainage, as well as we may have to discuss with the neoadjuvant therapies for medical oncologist. It is always a medical multidisciplinary approach. ERCP plays important role in diagnostic and therapeutic approach, and often it should be combined with US FNA for diagnosis, and whenever ERCP fails, we can consider US as the other option for the biliary drainage. Thank you.
Thank you, sir. It was an excellent talk, but I want to thank you for accepting and showing the evidence that up to 14.5 without cholangitis, without malnutrition, better not to stent.
Yes.
Because the stent versus no stent, the mortality is very high.
Yes.
So that is one thing. Second thing, if you have a hilar cholangiocarcinoma, usually at the confluence are one-sided. We have seen a number of cases, they try to stent that side. Usually if it is a retrievable, as a part of preoperative biliary drainage, if you are putting a retrievable SEMS, so what you are going to do, you are going to put a covered SEMS.
Yes.
If it is a covered retrievable SEMS, if you are putting that side, wherever the obstruction is, which side is the obstruction is there, invariably at the confluence level, you are occluding the opposite side duct. That's why always better to put Y.
Yes.
Always, whether it is a single side obstruction or double side obstruction or at the hilum or below, better to drain both the systems. That is one more important thing. And next, better to put a short SEMS than a long SEMS.
Yes.
If you put short SEMS, the chances of periductal inflammation and fibrosis will be very less. And after putting, and one more thing, most of the times we see in CA of pancreas or periambulary growth or cholangiocarcinomas, they look at most of the medical gastroenterologists. I'm not blaming anyone, but they look at the bilirubin. And if it is more than 3, they will stent, and the patient will be going for CT scan, PET scan, all those things. After 1 month, he will come. But we surgeons, we never look at the bilirubin. It's not the criteria. For us, albumin is the most important thing. Whether we are going for the hepatectomy or not is the important. And next, whether the patient is having cholangitis or not. So don't wait for the bilirubin to come down unless you are contemplating hepatectomy. The job is to look at the albumin. If it is sufficient more than 3.5, so that is the time we have to go in for the surgery. And waiting for 6 weeks, most of the medical gastroenterologists will have this notion after stenting, you have to wait for 1.5 months. It is not so. Again, I am telling you, if the patient is for some reason if you stent, if the patient is having good albumin, if cholangitis got settled within few days, so better to do early surgery. So usually after stenting within 1 week, we'll try to go for the Whipple's procedure or any radical cholecystectomy or whatever the cancer based on the cancer. So no need to wait till the bilirubin come down if you are not contemplating hepatectomy. Look at the albumin. Try to put a short SEMS. Try to put bilateral stenting if it is a hilar cholangio. These are the things. Thank you, sir.
Thank you, sir, for that detailed and practical overview on the topic. We now invite our next speaker, Dr. Krishna Gopal, consultant gastroenterologist, hepatologist, and interventional endoscopist at Medicover Hospital. Sir will be speaking on the topic endoscopic guided ablative therapies for HPB tumors. Over to you, sir.
afternoon. Good afternoon, everyone. Thanks for joining us on the HPB symposium. I will be presenting today on the endoscopic ablative therapies. What are the new modalities which we have for? So coming to the ablative therapies, most of our understanding that comes from the field of the cardiology and vascular surgeons. So as we can see in this pictogram, we have the chemical ablation, cryoablation, radio frequency ablation, then microwave ablation, electroporation, and photoablation. So this is the history of how ablative therapies has grown over a time. Very first attempt was the laser therapy in 1990s. Then in late 1990s we had argon plasma coagulation, followed by a photodynamic therapy around somewhere around 2000. 2000 and 2005 we developed a radio frequency ablation which has been long used by our intervention radiology colleagues, and in 2010 we had a cryotherapy to our basket. So coming to the use of any ablative therapy in the field of GI or GI oncology, it starts with esophagus. We do use it for the Barrett esophagus, early esophageal tumor. In case of the liver, it is for HCC or the meds to the liver. Then in biliary tumors, intraductal cholangiocarcinoma and the ampullary adenomas, pancreas, pancreatic neuroendocrine tumors, pancreatic adenocarcinomas, and cystic neoplasm of the pancreas. Ablative therapy which we commonly use are photodynamic therapy, ethanol injection, radio frequency ablation, and cryotherapy. So the basis of any endoscopic therapy is why do I do it, when do I do it, and how do I do it. These three are the important questions which we should be answering while doing any of our ablative endoscopic therapy. So the very first is the photodynamic therapy, in which there is a formation of the, can I have pointer working? So as we can see in the diagram there, we generally put a photosynthesizer on the tumor first, followed by that after a 48 hours duration, we expose it to the laser of 450 to 500 micronanogram. That leads into the ablation of the tumor. The figure down there shows the image. In image A, we can see the actual MRCP of the patient. In image B, how the tumor was there when we applied a photosynthesizer to it. Image C, it shows the picture of the 7 days ablation, and the image D shows it almost after a month of the ablation. The second pictogram, it shows a ERCP procedure, how it has been done. The red arrow shows the position of the laser catheter. So coming to the evidence, what we have with photodynamic therapy, so it has shown to improve the stent patency over a time of up to the 24-month to the 60-month duration. Also the recurrence rates has been less, and the stent patency was found to be more. But the major limitation with any of the photodynamic therapy is photosensitivity, and it is a two-step procedure. Obviously the cost involved with the photodynamic therapy is a lot, so that put us forward to find the other therapy which can make it more cost effective. So the other thing is ethanol injection in hepatic and pancreatic lesion. So 5 to 80% of the concentrated ethanol is injected during the therapies. It can be done with the help of EUS. We have a different EUS needles which help us for the direct delivery of the ethanol to the lesion. It can be used in the lymph node, metastatic lymph node ablation. it has a viable efficacy varying somewhere between 60 to 72% over a time. It is easily available and a very cost-effective approach. Ethanol ablation has shown to be a very excellent result in the cases of insulinoma, in which the effect starts coming up in a next after 24 hours of therapy, and there are the studies in which it has been shown up to the 5 years of therapy. So coming to the RFA, in RFA the tumor size is something which we should look at. Normally the tumor size should be less than 3 centimeter. It is preferable it is somewhere around 2 centimeter. So in the mechanism is with the RFA catheter, we slowly start rising the temperature of the tumor tissue, leading into the tumor necrosis and breakdown of the tumor cells. Following that, there is an interesting study which has been published which showed that there is an increase in the immune response at the tumor site with the help of the RFA. It has shown that there was an increase into the immune-related T cells, which has been based for the theory of why post-RFA there was found to be improved survival. So for now coming to the RFA of hepatic, pancreatic and biliary lesions, for biliary RFA we have two catheters. The first one is the Habib catheter and the second one is the ELRA. In Habib catheter, we have two ablation port which are almost 8 mm away from each other, and the length of each is around 8 mm. While coming to the ELRA, it is available in a different size which can vary from 11 mm, 22 mm and 30 mm, which help us in giving in ablating a tumor which are larger into the size. The other diagram which shows the position of the RFA catheter into this, if we see the pictogram B, which shows two dots in which the RFA catheter can be placed. Following that, the RFA in the picture E, there is a pictogram which shows two plastic stents were placed, and the pictogram F, two biliary stems were placed. So a similar study showing the response of the RFA in terms of the stent patency and improved survival in the patient post RFA and stenting. So this is a device or how our setup is there for the RFA. We need a probe, we need a generator, and we need something in US therapy what we call as our RFA needle. So if we see at the needle, it has an insulated tip and a non-insulated part. Basically that non-insulated part is to do the ablation, and the insulated tip is to prevent the damage to the surrounding tissue. The picture lower down, it shows a coolant machine and a generator for the RFA. So for coming to role of EUS with HCC and liver lesion, we can use ethanol injection in metastatic lymph node or the liver lesion. In the patient in which US RFA can be considered, obviously most of that are done by most of the RFA for the HCCs are done by our intervention radiologist colleague, but somewhere we can make the cases when the patient is very obese. It is difficult for the intervention radiologist to reach to the lesion because of the anatomy of the lesion somewhere into the caudate lobe or the left lobe, or there are the interposing vessels. So this there is a small video which shows so this is a lesion into the caudate lobe. Can you mute it? That is a RFA needle which has been inserted. Now you can see there is some blooming effect which has started coming up. That is how it looks like when you start doing the RFA for the lesion. The added advantage while doing it with endosono is if we have a contrast enhanced endoscopic ultrasound with us, that time we can see the complete ablation of the lesion at the same time. Slides. So coming to the ablative therapies in the pancreas, we have ethanol injection plus combining with a direct drug delivery to the lesion or the use of RFA. So this is a study which, or a table with multiple studies which has been done for the ethanol injection of the pancreatic cystic neoplasm. It has been tried in all kind of the lesions, IPMN, MCN, and it has shown a good response rate which has been varying between 60% to 70% with the use of ethanol ablation alone. Obviously all these things were used in a substrate of the patient who were the poor surgical candidate. So this table shows how effective the EUS plus the local injection of the drug. As we all know, the pancreas is a very desmoplastic tumor. So any chemotherapy which is directly delivered to the pancreas is more effective. So coming to the meta-analysis of EUS RFA for the pancreas, there is a good number of data which shows there is a high technical success rate. The clinical success varies around 85 to 95% in these lesions. Obviously, everything comes with some adverse event to it. The adverse event varies between 6 to 20% depending on the size of the lesions we are ablating, the area where we do ablate it. There are the reports of having a mild pancreatitis, some strictures, even pain abdomen which was not due to the pancreatitis and infection. To overcome this, most of the time we tend to put a prophylactic pancreatic duct stenting before doing the RFAs. There was an interesting article which was recently published in August 2024 which shows that US RFA for the pancreatic cystic lesion had shown to be having a low morbidity compared to the surgery over a period of time. This is another video of the case of pancreatic neuroendocrine tumor in which we had, it was around 1 centimeter lesion, but the patient was symptomatic with that. So this was in the body of the pancreas. Obviously that would have needed a major surgery. Patient was unwilling for the surgery. So we did This patient has been on follow-up. Her serum chromogranin level has come down to normal. So coming to the future therapeutics, what we have, we can go for a direct delivery of the immune therapy agent. We can have a genetically modified viruses for inducing the anti-tumor activity, which can be delivered directly to the tumor with the help of EUS. To summarize, ablative procedures are minimally invasive option and can be repeated if we require it. If there is a residual tumor, US guided therapies are feasible and safe. they have shown to have an effective role in the functional pancreatic neuroendocrine tumor and the cystic neoplasm of the pancreas. Obviously, we need more randomized trial and a larger database before we can call it as a standard of care and to replace it with a surgery. Thank you.
Thank you, sir. So definitely, when the surgery is not feasible in that particular patient or very early lesions, we can go for this. As of now, RFA is in practice. It is proven in liver cancers, especially HCCs. It is proven for the size of around 3 to 5 centimeters. But in pancreatic cancers and in other cancers, RFA role is not much as of now. As a part of palliative care or very early. These are the only two indications.
Yes.
I think, as you said in the last slide, it needs to be validated with the larger numbers.
Yes, sir. As of now, what data we have is a very limited data and with few cases, but the patient who are not a candidate for the surgery, I think this is one of the option which is very well worth considering for any of them.
Thank you.
Thank you.
Thank you, sir, for that enlightening talk. We now move on to our next speaker, Dr. J. Kiran Kumar, consultant gastroenterologist and therapeutic endoscopist at Medicover Hospital. Sir will be speaking on the topic self-expandable metal stents in BTC and its placement techniques. Over to you, sir.
Good evening, everyone. My topic was self-expandable metallic SEMs in biliary tract cancers. So as previous speakers already elicited, so most of the cholangiocarcinomas are around 60% cholangiocarcinomas are perihilar. Distal cholangiocarcinomas constitute around 20 to 30%, whereas intrahepatic cholangiocarcinomas are around 10% only. So basically hilar cholangiocarcinomas, Bismuth classification we can see. So type 1 involving the proximal CBD, so type 2 involving the primary confluence, whereas 3A involving the primary confluence and right side of the secondary confluence, type 3B involving the primary and left side of the secondary confluence, type 4 involving both right and left secondary confluence. So as previous speakers told, so I am again reiterating, there is so these biliary tract tumors will cause obstruction of bile tract and they will cause jaundice. So routine preoperative biliary drainage has no role. So preoperative biliary drainage only when there is a cholangitis or when there is a severe symptomatic jaundice or intense pruritus or when the surgery is delayed in because of decreased albumin or lack of nutrition, or when there is when a surgeon is planning for neoadjuvant chemotherapy. So we need to drain those biliary tract with preoperative biliary drainage. So in these scenarios we will use covered stents or plastic stents. Whereas in case of palliative biliary drainage, so when there is an inoperability or distant metastasis, so ERCP and SEMS placement, that is uncovered SEMS placement, is the ideal choice. So next slide. Okay. So coming to the biliary drainage, before drainage, so basically this is in the liver, so right anterior system and right posterior system and left hepatic left system will constitute around 30%, approximately 30% of constitute biliary drainage, caudate lobe around 10%. So we need to drain at least 50%. So whenever we are planning to drainage in left side, we can see there is a tumor in the left lobe. So we should try to avoid those segments with atrophied or tumor segments. So in the below we can see the tumor is located in the right posterior segment. So we are going to drain that right anterior and left segment. So to conclude, we need to drain at least 50% of liver volume should be drained. And if there is any cholangitis, we need to avoid infecting the undrained segments. So that we need to inject the contrast only to drainable segments. So we can avoid the cholangitis in those scenarios. So coming to the primary diametric, this is a SEMS. So SEMS are these are various SEMS models. This uncovered SEMS, first one is made up of nitinol. So main advantage of uncovered SEMS, it can drain from the opposite side also. Just now sir reiterated. So when we place the uncovered SEMS, so it will drain, it won't block the opposite side. So whereas for covered, in middle one we can see that is from Valvex, Boston company SEMS. So partially covered SEMS, so it can block the drainage from the opposite side. So last one is the fully covered SEMS. Each has one advantage and disadvantage. In case of uncovered stent, there is a ingrowth of tumor is more. So whereas in partially covered stent, so ingrowth of tumor is less. So but there is a risk of around 5 to 10% possibility of migration. So usually in case of palliative purpose, we'll use uncovered SEMS only. So in case of preoperative biliary drainage, we use fully covered SEMS, so that we can remove the SEMS and patient go for surgery if it is replaced for temporarily. So coming to the SEMS, these SEMS are made up of nitinol. Nitinol is basically made up of a superalloy of nickel and titanium. So it is an elastic, super elastic material. It can retain the shape. After it's manufactured, it will be stay in the same shape. So if we put in the biliary stricture, so it can adjust to that shape. So more compatibility is there. So we can deliver through the scope. And MRI also we can do, it is non-ferromagnetic, so it won't interfere with MRI. So and CT scan also we can do, so little because of radio dense material, mild beam hardening effect will be seen. Minimal artifacts will be seen post SEMS. So infiltrating the vascular invasion, and also there is a D3 infiltration here. So there is patient is having both gastric obstruction with the D3 and also distal biliary stricture. So can you play the video? So here is a D3 infiltration. Initially, so we tried for ERCP. So we are not able to cannulate. So we did EUS guided rando. So with the help of EUS, we place the wire into CBD. Here cholangiogram you can see there is a distal CBD stricture. So over the wire we did ERCP. So after placing the cannula, contrast was injected. You can see the distal CBD stricture. So over the wire, SEMS was loaded. So long uncovered SEMS was loaded. So SEMS was deployed. So this is the uncovered biliary SEMS placed into the biliary. So if the same patient is having D3 obstruction, so as a part of gastric outflow symptoms, so with the same scope with the cannula, we place the wire into D3 and we negotiated the wire into jejunum and uncovered SEMS was placed. So coming to the hilar strictures, so in the case of this is a case of type 2 stricture. So in case of uncovered SEMS, bilateral, just now sir has told, so bilateral SEMS, there are two methods of placing bilateral SEMS. This is side by side stent. In this, we'll place the wire into both sides simultaneously with 6 French delivery catheter system. So we'll deliver simultaneously. So this is a Y SEMS. So but both were delivered simultaneously with separate wires. So advantage with this is, even after patient comes after 2 to 3 months in their block, we can access individual ducts simultaneously. So we can access individual ducts when there is a block. So we can place plastic stent or we can re-stent also. So but there is a mild increased pressure in the CBD because both stents are lying side by side. So this is another method, SEMS placement using a stent within stent technique. Here First, we'll place the stent on one side with the help of cannula through the SEMS mesh. We will place the wire into opposite side. The second image you can see. So we place the wire into opposite side. Then we dilate it with balloon, hurricane balloon. We dilate it. Then we place the another SEMS into the previously placed SEMS. Here the problem is after 3 to 4 months, if the patient comes with obstruction, so we may not cannulate another side. So this is the problem, but there is a less possibility of duodenobbiliary reflex because there is a less pressure on the portal system and also CBD with this stent within stent technique. So both are equally efficacious and clinical success also equal. So to overall, so there is a good technical success and also clinical success around 98%. The median stent patency was up to 7 months. So, but there is a complication on follow-up, possibility of complication. Around 15 to 20% patient may develop reobstruction. This is mainly because of stent ingrowth. As we are placing in the palliative setup, so there is a possibility of tumor ingrowth into the stent. So there is possibility of reobstruction. In those scenarios, we'll place the plastic stent, or if the patient comes in emergency, we'll place the plastic stent. Later on, we may place another SEMS in the SEMS in SEMS. So if we use in a covered SEMS in case of preoperative setting, there is a possibility of 5 to 8% possibility of stent migration. So, and another complication is cholangitis. So cholangitis on follow-up, there is a possibility of cholangitis because of stent obstruction. So we need to treat with cholangitis with antibiotics and also with stent exchange and placing plastic stent in the covered SEMS, uncovered SEMS, or placing another SEMS in the previous SEMS. So most of the biliary tract cancers will also cause malignant gastric outlet obstruction. So I like to touch upon enteral SEMS here in few aspects. So enteral SEMS usually placed for malignant gastric outlet obstruction where there is a inoperable palliative purpose. So you can see most common cause of malignant gastric outlet obstruction, that is pancreatic cancer, gastric cancer, and bile duct cancer are the most common cause of malignant gastric outlet obstructions. So in these cases, around 50% patient will have simultaneous obstruction at the CBD. So biliary obstruction also around 50% will have, along with gastric outlet obstruction, 50% patient will have biliary obstruction. So we need to treat obstructive jaundice also in those patients. So these are the various enteral SEMS. So first one is, this is same material. So nitinol made up of single wire, made up of monofilament but covered with polyurethane. Second one is the Hanero stent, silicon membrane. Third one is the dual stent, that is inside is a bare netted stent and surrounding by nylon mesh. So at the edge there is uncovered, so that prevent the migration. There is a tissue ingrowth, so it will prevent the migration. So as it is a monofilament, in case of covered SEMS, if you full single filament, entire SEMS we can remove entire SEMS. So if it is covered. So uncovered we can't remove, it will because of tissue ingrowth, it will stay for lifetime. So so this is a case of pancreatic biliary cancer causing complete D1 obstruction. Just play the video. So it is a tumor obstructing the completely D1. So D1 infiltration. So initially we place the duodenoscope just in front of the pylorus. So we place the wire. Then we dilated it up to 18 mm. So this is a CRE dilatation. So with CRE dilatation we dilated the D1. After dilatation we entered into the D2. Then this is a CBD cannulation. So we place the wire. This is a cholangiogram showing distal CBD stricture. So uncovered SEMS was placed. So as the patient is having D1 obstruction, with the same cannula we place the wire deep into D3, D4. So SEMS was loaded and we adjusted the SEMS and we cross-checked the SEMS on the fluoro and placed in front of the pylorus. So this is the enteral SEMS placement. So this is the biliary SEMS and the enteral SEMS placement. So coming to the enteral SEMS, technical success were 97%. Clinical success also, most of the patient will respond, symptoms of gastric outlet will respond. We'll add prokinetics also. So 85%. So median stent patency was up to 10 months. So median survival is 2 to 6 months based on chemotherapy. So complications for late complication, there is no complication at the time. Usually we'll before anesthesia only we'll completely empty the stomach and we'll take the patient. So complications of stent dysfunction, that is in case we are placing uncovered SEMS, so there is a possibility of 10 to 12% reobstruction following the uncovered SEMS placement. So if there is a clogging of stent, we'll remove, and so we can place another stent also, stent in stent. So stent migration around 5%. So stent migration more in case of partially covered SEMS when covered to uncovered SEMS. So perforation, bleeding, and these are very less complications, very rare. So to conclude, so biliary and entrance SEMS placement has good technical and clinical success. We can do with the daycare anesthesia, mild to moderate anesthesia, short hospital stay. So we can discharge on the same patient on the same day. So when compared to surgery and PTBD, so endoscopic enteral and biliary SEMS placement, so technically and easy and better clinical success. Thank you.
Thank you, sir. It was crisp and beautiful. So my question is, we know the experience of putting side-by-side stents in benign biliary strictures over SEMS. But is there any experience putting side-by-side multiple plastic stents for the purpose of preoperative biliary drainage, or if you expect less than 3 months of survival, putting multiple side-by-side stents over SEMS?
Sir, in case of a palliative purpose, if we are keeping multiple plastic stent, so sir, if you are speaking in type 4 or type 2, it is okay. We can place, if you are able to drain all segments, okay. But if it is after injection of contrast, if type 3B or 4, so if you injected a contrast, if you are not able to drain all segments with plastic stent, then there is a possibility of infection. So in case if it is a type 4 after injecting the contrast, so there is a chance of conversion of type 3B to type 4. So we'll drain maximum, we can place maximum 3 stents or 4 stents. So but after plastic stents, after 4 stents also we may not drain some distal segment. So then we have to go for some PTBD kind of thing. So in case of type 4, sir. Type 2 there is no issue, sir. We can drain all segments.
At least for distal cholangios or carcinoma gallbladders.
Distal cholangio we can place 2 or 3 stents. So
is it in a single sitting or?
So same, in the same setting we can do 2 to 3 stents. Like so chronic pancreatitis is distal CBD stricture. So there are multiple trials, we will place multiple stents. Like in this scenario also, so with the distal we can place multiple plastic stents. So but there is a possibility of obstruction. Means what is cost?
That's what we are cutting lot of cost.
Cutting lot of cost.
And many of the times, if the patient is not affordable, yes, usually most of the medical gastroenterologists opt for the SEMS. But I want to know from you. So, is there any data on it?
If the cost is a purpose, then we can go for plastic stents. That too survival if it is less than 3 months. If you are expecting they don't want to go for any chemotherapy, it means it is a bad prognosis, then better to go for plastic stent also. So.
Yeah.
But if they admitted with plastic stent 1 episode of cholangitis, so then cost will again, so
yeah,
single admission will drain their budget.
Yes,
one cholangitis.
And one general knowledge question. So I've seen a number of times NITI stent. So I know NITI is nickel titanium alloy, but what is it a shape or
shape only, sir.
Shape only, no? NITI stent.
Stent.
Thank you.
Okay, thank you, sir.
Yes, sir. That's what.
Advisable to go with a 10 French plastic stent there rather than going with a single stent. That will decrease the chances of having cholangitis, and also it will cut down onto the cost of the overall compared to the biliary SEMS.
Thank you, sir.
Thank you, sir.
I would like to extend my heartfelt gratitude to Dr. E. Vimlakar Reddy sir for chairing this session today and sharing his valuable insights. I now request Megha ma'am, Regional Director of Telangana and Karnataka Medicover Hospitals, to hand over a token of appreciation to our chairperson. Thank you, ma'am. Thank you, sir, for joining us today. It is my pleasure to invite Dr. Manim Manoj Kumar, Consultant Gastroenterologist, Surgical Gastroenterologist at Medicover Hospitals, who will be speaking on the topic Surgery for Gallbladder Cancer, Latest Guidelines, Role of Laparoscopic and Robotic Surgery, and Surgery Beyond Radical Cholecystectomy. We welcome you, sir.
Good afternoon, everyone. I would be talking on surgical management of gallbladder carcinoma today. So my topic will be divided into introduction, radical cholecystectomy, lymphadenectomy in gallbladder carcinoma, surgery beyond radical cholecystectomy, and role of laparoscopic and robotic surgery, and finally the guidelines in the surgical management of GB carcinoma. So coming to the introduction part, management of gallbladder carcinoma, as you know, it's an astronomical oncological challenge as of now. Surgery is the only potentially curative treatment and it's a mainstay of management. And role of multimodality management is evolving. And multidisciplinary management includes surgeons, oncologists, gastroenterologists, and radiologists. So less than 10% of cases which were diagnosed preoperatively are suitable for surgical resection. And even there is confusion regarding terminology used for surgical procedures in gallbladder carcinoma, and there is no consensus on the terms used. People use radical cholecystectomy, extended cholecystectomy, and also there is confusion related to the use of term hepatopancreatoduodenectomy. And for some unknown reasons, mortality for the same procedures when they are performed for gallbladder carcinoma is higher than when performed for other cancers. For example, mortality of major hepatectomy is 16% for gallbladder carcinoma, whereas it is only 4% for cholangiocarcinoma. And mortality for hepatopancreatic duodenectomy was 20% when it is performed for gallbladder carcinoma, whereas it was 2.4% only when in case of cholangiocarcinoma. So coming to the philosophy of management of gallbladder cancer, Japanese surgeons traditionally approached gallbladder cancer aggressively and they have performed supraradical major surgical resections such as extended right hepatectomy, hepatopancreatoduodenectomy, hepatoligamento-pancreatoduodenectomy, and even there are reports of right upper quadrantectomy which involved major hepatectomy, pancreatoduodenectomy, right hemicolectomy, right nephrectomy as well as right frenectomy in the advanced stages. And West has pessimistic and nihilistic attitude towards the gallbladder cancer because of the low frequency of the disease there. And we in India follow Buddhist middle path where we approach it aggressively in the early gallbladder cancer, whereas non-surgical palliative approach is used in advanced gallbladder carcinoma. And major resections are usually performed in specialized centers in highly selected good risk patients. So in gallbladder carcinoma, every attempt must be made to find out a reason not to operate. If such reason is present and if it is missed, neglected or ignored, the outcome is very poor and operation is futile. And coming to radical cholecystectomy, it is defined as removal of gallbladder in non-anatomical wedge of 2 centimeters of liver in segment 4B and 5, or it also includes removal of segment 4B and 5 and regional lymphadenectomy. It is called primary radical cholecystectomy when it is performed for preoperative or intraoperative suspicion of gallbladder carcinoma. It is called completion radical cholecystectomy when it is performed for incidental gallbladder carcinoma. See, radical cholecystectomy is curative for early gallbladder carcinoma confined to GB wall, that is T1 and T2 lesions, and lymph nodes confined to hepatoduodenal ligament. And tissue diagnosis is not mandatory for performing primary radical cholecystectomy. However, there is a flip side to this, and there is risk of performing radical surgery for benign disease, and we have reports for that. Among 16 out of 27 cases in one study turned out to be xanthogranulomatous cholecystitis, 20 out of 30 in another study, and one more study in 2019 showed out of 164, 100 were benign diagnosis. So contraindications to radical cholecystectomy is a GB neck tumor with any amount of rival infiltration. Because right portal pedicle is so close to the GB neck, and adequate oncological margin cannot be achieved without sacrificing the right portal pedicle, and it needs extended right hepatectomy. And involvement of CBD, you have to resect CBD, and when there is involvement of duodenum or pancreas, it requires pancreatoduodenectomy. So coming to another burning topic, whether wedge resection is enough or segment 4B and 5 resection is needed. See, the rationale for segment 4B and 5 resection or hepatic bisegmentectomy was micrometastasis may spread via cholecystohepatic veins to segment 4B and 5. However, studies says otherwise. Only one study from Japan in 1990 favored bisegmentectomy. All other studies, including our own study from Tata Memorial in 2019, showed no difference between wedge resection and hepatic bisegmentectomy. So logical would be do a wedge resection for T1B, T2 and T3 tumors with minimal liver infiltration, and segment 4B and 5 resection is reserved for T3 GB fundus and body tumors with greater than 1 centimeter liver infiltration. So coming to lymphadenectomy in gallbladder carcinoma, it is characterized by early lymphatic threat. Involvement of lymph nodes is less than 5% in T1A tumors, up to 10% in T1B, 40 to 60% in T2, and 80% in T3, T4 tumors. Japanese surgeons have classified regional lymph nodes into first echelon nodes, which includes cystic node and pericholedochal nodes, and second echelon nodes that are hepatic artery, periportal, hilar, and posterior superior pancreatoduodenal nodes. Distant nodes such as includes iodocaval, celiac, and superior mesenteric nodes. And cystic node is not sentinel lymph node for GBC because cancer can spread to other nodes before involving cystic node also. There are three prominent lymphatic pathways for gallbladder. Cholecystoretropancreatic pathway, this is major pathway. It follows cystic node, pericholedochal nodes, perihepatic nodes, periportal, retroportal nodes, and finally iodocaval nodes. And cholecystoceliac pathway, cystic lymph node drains into common hepatic artery nodes, then it goes to celiac lymph nodes. And cholecystomesenteric pathway, periportal lymph nodes and lymph nodes drain directly into the root of the superior mesenteric artery. So this is the diagram showing lymphatic drainage, cholecystomesenteric pathway, cholecystoretropancreatic pathway, cholecystoceliac pathway as described. And lymph node involvement is most important predictors of prognosis in gallbladder carcinoma, and removal of at least 6 lymph nodes are needed for accurate staging. However, only 12% patients had greater than 6 lymph nodes resected. This is data from National Cancer Database. And removal of greater than 6 lymph nodes associated with better recurrence-free survival and median overall survival. And coming to another topic, controversial topic, whether to remove or not to remove 13A, that is highest superior retropancreatic lymph node. This is considered as a transition node between N1 and N2 lymph nodes, and its involvement predicts recurrence as well as survival. And Japanese and Indian surgeons consider it as a regional node, whereas Western surgeons consider it as a distant node. And para-aortic lymph node metastasis is as bad as distant mets and contraindicates resection. And routine sampling and Trojan section of 16B1 avoided unnecessary non-curative radical surgery in 18.6% of patients. This is a study from G.V. Pant Hospital by Anir Agarwal sir. And coming to the benefits of lymphadenectomy, it results in better staging, guides selection of cases for adjuvant therapy, and predicts prognosis. Prognosis worse in node-positive patients, and improves survival when it is performed for T1B and T2 tumors. And this is a study of systematic review and meta-analysis showing the effect of lymphadenectomy in curative gallbladder cancer. This is published in 2020. As you can see, they compared no lymphadenectomy versus lymphadenectomy. In T1A, T1B, there is no difference in overall survival or disease-specific survival. However, there is significant difference in survival in T2 and above tumors. And few studies compared stage-wise survival as well. Again, in cases with lymphadenectomy, overall survival and disease-specific survival are significantly better, and even more better if more than 4 lymph nodes were harvested during surgery. And this is another diagram showing as the number of lymph nodes harvested increases, the survival increases. The current standard for lymphadenectomy for GB cancer includes removal of 12C, 12B, 12A, 12P and 12H lymph nodes, 13A, that is posterior superior pancreatic duodenal lymph node, and CHA, common hepatic artery lymph nodes, and lymph nodes to the right of celiac axis. And preoperative diagnosis of enlarged celiac, SMA and interaortic caval nodes, contraindication for surgery. And minimal number of nodes needs to be resected are 6. This is a diagram showing lymphadenectomy in gallbladder carcinoma, and the area in green, the nodes, entire nodes marked with green should be removed for a proper lymphadenectomy in GB cancer. And next clinical question is whether routine CBD excision to be done or not to do. So Japanese surgeons believed that routine CBD excision resulted in adequate and complete lymphadenectomy, and they might clear occult mets in CBD and hepatoduodenal ligament. However, if we see the evidence, including Memorial Sloan Kettering Cancer Group, Nagoya Group from Japan, and one more study in 2017 which included 12 to 51 patients of gallbladder carcinoma, unanimously reported that routine CBD excision is associated with higher mortality and morbidity, and there is no survival benefit. CBD excision is indicated only in cystic duct margin positive cases, GB neck tumors with macroscopic CBD invasion, gross bulky lymph nodal involvement in hepatoduodenal ligament making lymphadenectomy difficult, lymph nodes adherent to the CBD, associated choledochal cyst, papillary tumors with high propensity for intraductal emboli spread. And coming to resections beyond radical cholecystectomy, this is done for advanced GB cancer. Nagoya group has reported high mortality of 18% as well as morbidity of 50%. It is performed only in specialized HPB centers in select few good risk patients. And what is major liver resection? It is defined as resection of greater than 2 segments of liver. It is done in GB cancer with fundus and body involvement with extensive liver infiltration, or GB cancer neck with infiltration because right portal pedicle is invariably involved, and GB neck cancer with a hilar block and involvement of right portal vein and right hepatic artery. Hepatectomy in gallbladder carcinoma is never right hepatectomy alone. It is always combined with resection of segment 4. That's why extended right hepatectomy is necessary. It can be modified to removal of only segment 4B, where it is called modified ERH. And Taj Mahal resection is done rarely in GBC, where segment 4B, 5 and caudate lobe are resected. This is done in cases with biliary duct confluence involvement without right hepatic artery and right portal vein involvement. And these patients may require ENBD and PTBD for cholangitis or portal vein embolization ARBs in case of inadequate FLR. And there are very few reports of major hepatectomy for gallbladder carcinoma from the West. Most reports are from Japan. They reported a mortality of 12.5 to 28% and 5-year survival to the tune of 12.5%. And there are very few reports from India, 9 patients from Potokat et al. Group, and 3 from Anila Agarwal sir's group, and 5 from Mishra sir's group. Major hepatectomy for liver metastasis is a big no-no. Results are as same as unresectable disease. Hepatopancreatoduodenectomy, it is indicated for extensively bulky disease adherent to retroduodenal retropancreatic lymph nodes, involvement of duodenum and pancreas, biliary involvement in intrapancreatic part, synchronous gallbladder cancer and pancreatic periampullary cancer. So Indian experience, modified HPD was done in 4 patients by Pottekat group. Agarwal et al. Reported 6 HPDs and among 154 resections, only 5 were hepatopancreatidoidectomy in Mr. Sir's group. And Zhou et al. Group performed systematic review of 18 studies where 397 hepatopancreatidoidectomy were performed. Out of them, 152 were performed for gallbladder carcinoma. It resulted in a morbidity of 79%, mortality of 10%, with the median survival of only, 5-year survival is seen only in 10%. So they have concluded that HPB can be done in cholangiocarcinoma, but it remains controversial in gallbladder carcinoma. Alternatives includes duodenal sleeve resection only in duodenum involvement, pancreatic wedge excision in pancreatic involvement only, and sometimes distal gastrectomy with proximal duodenectomy and doing a GJ. So combined resection of adjacent organs involves resection of stomach, duodenum, colon and abdominal wall. It also includes HPD. Need for CRAO is a predictor of poor survival even after R0 resection. Vascular resection, resection and reconstruction and PHA, that is a proper hepatic artery and a main portal vein, are technically possible. They are indicated in cholangiocarcinoma, but they are contraindicated in gallbladder carcinoma as of now. So I'm quickly running through. And Nagoya University, Japan group recommends portal vein resection, but says that hepatic artery resection is not justified for GBC. I'm running through shortage of time here. So minimally invasive surgery in gallbladder carcinoma. Traditionally, even a suspicion of gallbladder carcinoma used to be a contraindication in laparoscopic radical cholecystectomy because of the concern of gallbladder perforation, tumor spillage and peritoneal dissemination. I will run through because of shortage of time. I will quickly show a video where we have done a radical cholecystectomy for T2 tumor. Can you play the video, please? It's a video showing radical cholecystectomy, robotic radical cholecystectomy for a T2 GB cancer. You can see complete skeletonization of common hepatic artery, proper hepatic artery, CBD and portal vein with 2 centimeters of wedge has been resected. And this is our specimen pictures with the wedge of liver, and you can see the large stone as well as lymph nodes that were harvested. Final report came as xanthogallinomatous cholecystitis. However, we are satisfied with our lymph node harvest. Around 11 lymph nodes were harvested altogether. This finishes my presentation. Thank you very much.
Interventions were both timely and informative. We now move on to a vital topic in hepatobiliary oncology, cholangiocarcinoma. It is my pleasure to welcome Dr. Ajay Varun Reddy, Senior Consultant, Robotic Surgical Oncologist at Medicover Cancer Institute, who will be speaking on the topic Surgical Management of Cholangiocarcinoma. We welcome you, sir.
Okay, Yeah, so what I would like to do in the next 15 minutes is give a brief overview of a surgeon's perspective on cholangiocarcinoma. I don't want to make this very elaborate because I realize that the more details we get into, the less is remembered. So having said that, the previous speaker spoke very elaborately on gallbladder cancer, and what I want to emphasize is that even though the origin of gallbladder cancer and cholangiocarcinoma are all from the same primary kind of cells, that is biliary cells, when you talk about staging and how you manage them, we usually try to separate out gallbladder cancers from cholangiocancers, and that is what this slide usually says. So cholangiocarcinoma usually means anything that arises anywhere along the point of the biliary tract from the bile duct cells. Traditionally, what it was classified broadly into extrahepatic type, then you have a primary liver type, and you had a gallbladder cancer, and at the end you had ampulla fater. But now modern classification totally separates out gallbladder cancer, and when you focus on cholangio, there are three different subcategories. One is the intrahepatic cholangiocarcinoma, then you have the perihilar, and the last one you have the distal cholangiocarcinoma. So all through, I expect that you keep this slide in your mind, where we here show that whatever is in the biliary radicals that are inside the liver, the secondary biliary radicals, usually comprises the intrahepatic cholangiocarcinoma. And the extrahepatic component is divided into two parts. One is the distal segments, where it is distal to the cystic duct insertion, and you have the perihilar segment, where it is in and around the primary bifurcation of the biliary tree. So this was the anatomical classification, and you see the imaging for this. There's another way in which people usually tend to subclassify these. One is the mass forming type, which is most common in the intrahepatic type, and the other two are the periductal infiltrative and the intraductal type. And this particular slide you must all be very familiar with. This is the Bismuth classification of perihilar tumors, and I wanted to highlight that this is very specific only for perihilar form of cholangiocarcinomas. This does not give you a prognostic kind of staging like how the TNM gives, but it is a useful parameter for you to keep in mind so that you can plan your surgical treatments. So clinical presentation essentially is patient presenting with jaundice, which is usually painless and progressive. Apart from that, you have other symptoms like pruritus, clay-colored stools, abdominal pain, or weight loss, which are contributory factors. And in intrahepatic forms, usually you don't even have jaundice. Usually the only sign is usually some vague dull aching pain, weight loss, or an increase in ALP. So in the laboratory findings, you definitely want to evaluate them for the extent of jaundice, where you have the increase in direct bilirubin. Apart from that, you have an elevated liver enzymes like ALP and GGT. And initial stages, usually AST ALTs are normal. Only when liver failure sets in, usually AST ALT are elevated. And in the radiological findings, classically when the patient usually goes for an ultrasound, you find a dilated biliary system without any obvious stone disease or other forms that can be attributed to this. And that is what prompts you to suspect a cholangiocarcinoma, a jaundice in the background, and an ultrasound that shows a dilated biliary system without any stones or history of a mass. So in the diagnostic workup, after your initial labs, your definitive imaging usually rotates around MRCP and a multi-detector CT scan. The highlight about an MRCP is that it gives you excellent delineation of the hepatic biliary ductal anatomy, where you know the distal extent and the proximal extent. But the MRCP fails when it comes to actually trying to delineate between subtle vascular involvement, where a multi-detector CT usually scores higher. And once you have crossed your imaging phase of your evaluation, the next step is to decide whether you actually need a biopsy or not. So these tumors which are classic radiologically, and you know that they are operable, they usually do not require a biopsy from a surgeon's perspective. But in case you want to go for a drainage procedure, so an ERCP at the same time can give a breast cytology in these patients, especially in distal and hilar. And in intrahepatic cholangiocarcinoma, usually the entire thought process is to differentiate this between HCC versus intrahepatic cholangio, and you have to go for a CT-guided biopsy. So the same point where I said biopsy is not mandatory, but you tend to get it where there are indeterminate lesions, or when the family is very insistent or the surgeon is insistent on it, or when you want to go for a non-operative form of treatment. And at the end, you do a distant metastatic workup, though we tend to get PET CTs
very commonly the evidence is lacking for that. However, due to convenience and availability, we usually go for a PET CT, but a CT scan of the chest, abdomen and the pelvis is as good. So this is the broad surgical strategy that I want you to remember. And always remember, an R0 resection is probably the only curative option that patients with cholangiocarcinomas have. And once they cross this, all that we tend to do is try to probably downstage them or bridge them or palliate them. So the surgical strategy, before you go into the decision for surgeries, usually you tend to evaluate these patients wholesomely with respect to what their resectability is. That is the anatomy per se. Also, the pre-op liver function is quite essential to determine if this patient will be fit for a liver resection or not. And the next two preoperative questions are, does this patient require a biliary drainage or not? And does this patient have an adequate future liver remnant if you go for a resection? And the point I wanted to make is, there has been a lot of talk about biliary drainage and that surgeons don't want biliary drainage as an essential thing before going for surgery. Yes, that holds true usually for distal lesions, but the more proximal these lesions go, that is perihilar or type 3 types, usually these patients require hepatic resection. And a cholestatic liver usually is little difficult when you think about the FLR. So usually we tend to do a biliary drainage in this patient. And also the advantage of biliary drainage is it increases the future liver remnants. So when you drain the remnant, so it increases the FLR. So this is the distal cholangiocarcinoma. I start with this because this is the easiest one to decide on surgical management. So when you have a tumor that is distal to the CBD cystic duct junction, which are called the distal cholangiocarcinomas, usually they go for a Whipple's procedure, and there is a no-brainer about this, and it's a standardized procedure. And the other end of the spectrum, when you look at intrahepatic cholangiocarcinomas, what we have to determine is which segments it is affecting and what sort of major liver resections would benefit this patient. Again, this could be a right hepatectomy or a left hepatectomy or a trisectionectomy. And just like any other resection, the usual preoperative evaluation of a CT volumetry and if there is adequate FLR and all has to be done. What I want to spend most of my time is actually on perihilar cholangiocarcinomas, where the management is a little tricky or not very straightforward. And again, the Bismuth classification helps us to some extent in trying to determine what management these patients eventually get. So at the lower end of the spectrum, a small perihilar cholangiocarcinoma with a type 1 bismuth usually can get away with the extrahepatic biliary duct excision along with the reanastomosis or hepatojejunostomy. Beyond that, when you go, usually they require one-sided hepatectomy also to get an adequate margin along with the caudate lobe resection. So this is the Bismuth classification, where type 1 does not involve the hilum, but it is below that. Nevertheless, it is perihilar because this classification is for perihilar. Type 2 is involving actually the bifurcation that you see over there. Type 3, it has involved the bifurcation and gone on to the right primary duct. Type 3B is to the left primary duct, and type 4 is usually where there is extensive involvement. So as I said, perihilar cholangiocarcinoma require a different sort of approach. Their anatomy is more complex, especially because the portal vein and the right hepatic artery are right behind the confluence. Also, whatever you do, usually when the patients are referred to you, their resectability is usually around 20 to 25% itself. So take a note on this slide. What I have highlighted there in the diagram is actually the bile duct confluence. And when you see just posterior to that, the confluence of the portal vein is right behind the biliary system's confluence. However, what is actually involved with respect to the artery is only the right hepatic artery. So remember, perihilar, if they invade vascular structures, it's usually the confluence of the portal vein and the right hepatic artery. And this is the biliary anatomy, which is actually quite complex once you get into the secondary and tertiary radicals. But what you need to remember is, largely when you think about this biliary anatomy, you have to think of them as 3 different sections of the liver: the right posterior, right anterior, and the left section, which actually helps in getting a surgical plan across. So always do your staging before any intervention that involves, if you want to do a biliary drainage or a PTBD or endoscopic drainage, don't jump into it. First do your staging investigations, because a lot of it actually gets obscured once you put a stent or you put a PTBD. So your MRCP is to know the longitudinal extent and the radial extent to a bit. However, an MDCT can exactly tell you if there's portal vein invasion or hepatic artery invasion. Also, it also goes to point out these few pointers that actually the position of the patient when they get an MRCP also is important, because as you see in a supine position, the 8C and 4B ducts actually look very close by here or here. However, when the patient is in a lateral position, they are separated out. So these essential things have to be kept in mind by a surgeon and also a radiologist, because if there is something involving those segments and you are not able to determine if it is a right-sided or left-sided, positional changing and imaging also helps. So this is again another caveat. When you do an MRCP and you think a block is here, you think in the initial image it's a type 1 type of block. But actually when you do an ERCP, this turned out to a type 3A type of block. So there's a wide variety of what you offer for a type 1 versus a type 3A. And the reason why this has happened is again because of the position and because of how the ducts, the biliary anatomy is positioned in the body. So again, vascular involvement and portal vein involvement, you need to get, probably it's always best to get both an MRI, MRCP and an MDCT to get the maximum value out of evaluating these patients for hepatic and portal vein invasion. So how do you evaluate these patients for resection? So if there is, especially I am talking about only perihilar cholangiocarcinomas here because we have already finished distal and intrahepatic. So in a perihilar cholangiocarcinoma, if there is only involvement of the first order ducts or a second order duct without any vascular invasion, that is a right duct or a left duct, these are resectable tumors. Or in the other extreme, if it involves a vascular structure that is on the same side of the majority of involvement, say for example there is a 3A or a confluence lesion involving on the right portal vein, that again is resectable along with the portal vein resection and reanastomosis. However, resectability is not only about the anatomy of the tumor, it also involves you assessing the functional status of the liver, which we have spoken since morning. So the liver state is assessed by the presence of cirrhosis, if the patient is in failure, and how his parameters are. So resectability involves patient factors, local factors where the anatomy of the tumor is important, and the distance spread, where spread to the retroperitoneal lymph nodes or distant lymph nodes is usually frowned upon for surgical resections. So regarding the preoperative drainage, which is very important for surgeons, most surgeons today tend to actually go for a drainage if there is a major hepatectomy involved. And usually the preference is to do it with a PTBD rather than an endoscopic drainage, usually because of the way the anatomy is. So for example, if you see over here, if you do an endoscopic biliary drainage in a very proximal lesion, usually the direct path of entry is into segment 8 duct. This runs the risk of not draining the left-sided or the right posterior segments. So all these small aspects have to be kept in mind before surgical planning. So what are the options? Once you have decided this patient is resectable, be it be simple resection with a hepatectomy or a vascular resection, the options are actually 4 major options. One is a right and a left hepatectomy, or a right trisectionectomy and the left trisectionectomy. But these were the base surgical procedures that we all tend to do. But beyond this, many surgeons in Japan and also in the East are going one step ahead than general curative resection surgeries, and that is doing a portal vein resection at the same point of time, or doing a hepatic artery resection and doing an anastomosis. But always remember, the prognosis of a portal vein resection is better tolerated than a hepatic artery resection. And the supramajor of all of this is, if the patient has an extensive disease, he might require a hepatectomy along with the resection of the portal vein, along with a Whipple procedure. Not very often done, but there are many case series on this. So you see a patient that you feel is not upfront resectable. do you have any downstaging options? Yes, there are some downstaging options, especially with neoadjuvant therapies, with chemotherapy and radiation therapy, which the further speakers will talk. But most of these fall short in the kind of responses that we expect, even though there are some small case series where patients have been converted to resectable forms. But if not resection, what else? So the next obvious question that comes is transplant, because we've been talking about transplant in HCC scenario. But always remember, the data is not as robust as it is with HCC. Whatever data we have usually for transplant is mostly for perihilar cholangiocarcinomas, where there's a Mayo protocol, where these patients are put on chemotherapy, external beam radiation and brachytherapy, following which if there's no progression, they go for transplant. This is an established criteria by the Mayo Clinic, and not many centers following it in India, but there is data for this. If you look at the other end of the spectrum, where there's intrahepatic cholangiocarcinoma, say for example a small cholangiocarcinoma, patient has cirrhosis, however fit, but not resectable because FLR is low. These patients can go for transplant, but always remember they should have a very low volume disease. The higher volume disease, usually they tend to fail later on. And the data for this is not very robust. So as I said, the role for transplant currently is only acceptable in perihilar, just coming into the picture for intrahepatic. However, after all these supramajor resections as well, even though our techniques have improved and mortalities have dropped, morbidities have dropped, the mortality rates still remain high for all these, up to 40% for supramajor resections. And the textbook sort of resection where there's clear margins, no role for adjuvant, all that is usually possible only in 25% of these cholangiocarcinomas when you look at all comers. And the patterns and the reasons for this is because the patterns of spread, usually they have intrahepatic metastasis along with nodal, liver and peritoneal metastasis. Thank you.
Thank you, sir, for that insightful talk. It is my pleasure to invite Dr. Sarita Ma'am, Consultant Medical and Hemato-Oncologist at Medicover Cancer Institute. Ma'am will be presenting on personalized approach in systemic therapy for biliary tract cancer from chemotherapy to targeted and immunotherapies. Over to you, ma'am.
Good afternoon, everybody. Thank you, Medicover, for the opportunity. So I'm going to speak about systemic therapy in biliary tract cancers, from chemotherapy to the latest targeted and immunotherapies. So as reiterated by the previous speakers, most of the patients of biliary tract cancers present in advanced stage, and even in patients undergoing curative intent surgery, the relapse rates are very high, more than 50%. The 5-year survival of patients of cholangiocarcinoma is very dismal. So for stage 1, it's almost 50%. Stage 2, it is 30. Stage 3, it is 10. And stage 4 is unfortunately 0%. So this has already been discussed by the previous speaker. So coming directly to the role of systemic treatment. So usually any form of systemic treatment depends on the stage of the disease in which the patient presents. And we divide systemic treatments into neoadjuvant, which is given prior to definitive management, that is surgery. Then it is adjuvant, which is offered to the patients post-surgery. Then palliative in case of unresectable and advanced stages. And then now we are into the era of precision medicine, where we also offer patients immunotherapy and targeted therapy. So coming to neoadjuvant therapy, there is not much strong data. So there is no evidence-based regimen for neoadjuvant systemic therapy. So the most valid or the most strongest data is from a randomized multicentric phase 2 trial, in which they had tried a triplet regimen of gemcitabine, nab-paclitaxel and cisplatin, which showed that it is safe and feasible without impacting much of the postoperative outcomes. Coming to adjuvant chemotherapy, as endorsed by majority of the guidelines, we offer adjuvant capecitabine for all patients of resectable cholangiocarcinoma starting from stage 1B. So the evidence came from the BILCAP study. So this was a randomized phase 3 trial in which patients post-surgery were randomized to capecitabine at a dose of 1250 mg per meter square BD for 8 cycles versus observation. And in this, the intent to treat analysis didn't show a statistical significance. However, the per protocol results showed that yes, capecitabine really had an improvement in overall survival. So the median overall survival was 51 versus 36.4 months for patients in observation. Next, apart from capecitabine, we also have a phase 3 data from a Japanese study. So in this adjuvant S1 is a combination of Tegafur, Jimidacil and Otoracil. So this has also shown an improvement in overall survival. And also a meta-analysis of almost 15 retrospective studies have shown that yes, adjuvant capecitabine really helps the patients in improving the overall survival. So because of these data, yes, capecitabine has been advocated as an adjuvant chemotherapy for 6 months post-surgery. Next, coming to systemic therapy for unresectable and metastatic biliary cancer. Broadly, we divide the regimens or the agents what we offer in form of cytotoxic chemotherapy versus targeted therapy versus immunotherapy. So now we are in an era of precision medicine. So, and however, the evolution of data or the evolution of evidence had been quite slow compared to what we had in the previous decade. So starting from 2009 to 2019, there were almost no approvals for biliary cancer in particular. So in 2009, we got the evidence of GemCis as palliative chemotherapy in case of unresectable biliary cancers. So from then onwards till to 2019, we almost didn't have any approval. So in 2019, we got an approval in the second line for FOLFOX regimen. And after that, there has been a plethora of evolution of medicine, precision medicine. Especially we have got approval in 2020 for FGFR2 and IDH1 inhibitors. Then in 2022, there was a major breakthrough wherein we got an approval for immunotherapy along with chemo in the first line treatment of metastatic disease. So there were 2 immunotherapy drugs which were approved subsequently in 2002 followed by 2022 and 2023. And then in 2024, we got another agent, trastuzumab deruxtecan, which has shown really great response rates in all the tumors which express HER2. So coming to the historical data, the thing in 2009, so this was the evidence from the ABC2 trial in which they compared gemcitabine versus gemcitabine cisplatin. So in this, there was a significant improvement in overall survival, so 11.7 versus 8.1 months in patients receiving gemcis versus gemcitabine alone. And also there was an improvement in the progression-free survival of 8 versus 5 months. Then these were the other trials. So apart from gemcitabine cisplatin, gemcitabine S1. Now this regimen was compared to the standard of care, that is gemcitabine cisplatin. So this also showed that this regimen was not inferior to GemCis. So any patients who have any condition hindering the use of cisplatin, yes, we can offer gemcitabine S1 to such patients. However, the addition of a third agent, that is when we have a stage 4 patient, we offer 2 chemotherapy drugs. Addition of a third drug, either S1 or nab-paclitaxel, hasn't shown a significant improvement in the response rates or overall survival of such patients. So the standard of care remains 2 chemotherapy drugs to be offered upfront to all metastatic cholangiocarcinoma patients. Now coming to, as I told, from 2022 we got approval for 2 immunotherapy drugs. So now we usually club chemotherapy and immunotherapy for patients. So this is the trial which got the FDA approval. So Topaz 1 was a phase 3 trial comparing durvalumab, gemcitabine and cisplatin versus gemcitabine and cisplatin for upfront stage 4 metastatic or unresectable patients. So here, this is the 3-year update So there has been a significant improvement in the overall survival, 12.9 versus 11.3 months. An interesting observation in patients receiving immunotherapy is that at the end, there tends to be a flat line, meaning that some patients who manage to gain response continue to enjoy a sustained response. So this was another trial, pembrolizumab, gemcitabine, cisplatin. So this was the second immunotherapy approval which we got in stage 4 cholangiocarcinoma. So this was a phase 3 trial wherein they compared pembrolizumab and gemcitabine cisplatin versus gemcitabine cisplatin alone in stage 4 or unresectable patients. Here also there was a significant improvement in the overall survival. So 12.7 versus 10.9 months, the results being statistically significant. Now, there is always a debate, always a confusion. So if the patient can really afford immunotherapy, what to offer the patient? Is it durvalumab versus pembrolizumab? Most of the clinicians favor durvalumab because post gemcitabine cisplatin 8 cycles, we can just continue durvalumab alone. Whereas when we offer pembrolizumab and gemcitabine cisplatin, we have to continue gemcitabine along with pembrolizumab. So lesser the cost of treatment, lesser the toxicities. So mostly durvalumab is preferred versus pembrolizumab in patients with stage 4, patients receiving immunotherapy. So this is a summary of what we offer in the first line treatment for advanced biliary tract tumors. So primary treatment being immunotherapy combination with chemotherapy. So durvalumab, gemcitabine, cisplatin, or pembrolizumab, gemcitabine, cisplatin. See, for any reason, if the patient is unable to take immunotherapy either for the toxicities versus or the financial issues, then we offer a dual agent chemotherapy with gemcitabine and cisplatin. Other patients who have toxicity constraints, for them there are alternate regimens like capecitabine, oxaliplatin, Folfox, that is 5-FU-leucovorin and oxaliplatin, gemcitabine, nab-paclitaxel, and patients who are more on the frailer side, we offer single agent chemotherapy like 5-fluorouracil, capecitabine and gemcitabine. Coming to treatment of refractory disease, that is patients who have not responded or progressed following reception of the first line treatment. So here this was based on the ABC6 study which was published in 2019. We offer Folfox regimen to patients as a second line treatment. If for any reason patient is unable to take Folfox, then we have other regimens like Folfiri, liposomal irinotecan, 5-FU and leucovorin, and for few cases regorafenib, and for few cases without doing any biomarker testing, it has been seen that immunotherapy in the form of nivolumab has also shown decent response rates. So what makes interesting the discussion of biliary tract cancers, especially advanced stage, is the plethora of targeted therapies which have come in the last few years. So basically, when we do a molecular testing on a tumor sample of any biliary tract tumor, we see that if it is intrahepatic cholangiocarcinoma, almost 40 to 50% of the patients will have some or the other targetable mutations. The incidence is slightly less for extrahepatic cholangiocarcinomas and somewhere in the middle for gallbladder cancers. So the most common discussed or talked about targetable alterations are the HER2. So HER2 is more commonly found in gallbladder cancers and distal cholangiocarcinomas. Then we have FGFR, that is fibroblastic growth factor receptor, and the IDH, isocitrate dehydrogenase mutations. And then for any patient in second line, we advise MSI testing, microsatellite instability testing for eligibility for immunotherapy. So this is the summary of all the targeted therapies available for biliary tract tumors. So once the patient exhausts his or her first line of treatment, it becomes mandatory to look at the molecular alterations of the tumor so that patient can really benefit with any of the targeted therapies for which the patient turns to be mutation positive. So MSI, sometimes in 1 to 2% of the patients, MSI may come positive, for whom we offer immunotherapy with a very nice response rates of 40%. The agents offered are pembrolizumab or dostarlimab. Then TMB high, meaning more than at least 10 mutations per megabase pair of the genome. So in this case, we offer pembrolizumab and nivolumab with the overall response rates of between 25 to 30%. Then we have NTRK, ROS1. Then most common discussed and talked about are the FGFR2 and IDH, which I'll be subsequently talking. Then the HER2 amplification has gained special interest in the last 2 years. And the other mutations are RET fusions and KRAS, which are also coming up. So coming to the FGFR signaling. So FGFR signaling is more common in the fluke-infested cancers or cancers affecting the intrahepatic cholangiocarcinomas. So basically FGFR is a basically receptor. So 1, 2, 3 and 4 FGFR receptors have been identified. And when the fibroblastic growth factor ligand binds to any of these receptors, there is a downstream signaling pathway activation in the form of JAK-STAT pathway or the MAPK pathway or the PIK3CA-mTOR pathway. So these send the cell signals for increased proliferation, survival, angiogenesis and metastasis. So this is essentially what is blocked in cholangiocarcinomas tested positive for FGFR2 mutations. So 2 drugs were approved in 2020. One is the FGFR1/3 inhibitor, that is pemigatinib, and the FGFR1/4 inhibitor, futibatinib. Slightly better results with futibatinib. However, these drugs are not available in India, but we can import them on a request basis. So next is the IDH signaling pathway. So basically IDH mutations are involved in the mitochondrial respiratory pathway, the Krebs cycle pathway, wherein the metabolite alpha ketoglutarate takes part in mitochondrial respiration. However, whenever there is an IDH mutation, an oncometabolite known as 2-ketoglutarate is formed, so which causes methylation of the DNA and the histone proteins, leading to oncogenic activation of oncogenic signals. So this is the phase 3 study, Clarity study, in which ivosidenib versus placebo was tested was tried for patients with IDH mutation. So there was a decent improvement in overall survival, 2.7 versus 1.4 months, which was statistically significant, leading to its approval by the FDA. So then HER1/4 signaling. So basically, this is the most talked about molecule or the signaling pathway in almost all the malignancies, because they have got agnostic approvals for almost nearly a majority of the cancers. So basically, human epidermal growth factor receptor basically comprises of 4 receptors. So they basically either homodimerize or heterodimerize, again causing proliferation signals leading to tumor survival, proliferation, angiogenesis and metastasis. So especially for biliary tract cancer, there was this My Pathway study, which was a phase 2 study testing 2 monoclonal antibodies, trastuzumab and pertuzumab, for biliary tract cancers who had exhausted previous lines of treatment. So in this, there was a decent improvement in the progression-free survival of 4 months and overall survival of 10.5 months. So next is the trastuzumab deruxtecan. I think this is the most talked about molecule nowadays in any medical oncology forums. So this is an antibody drug conjugate. Basically, it's an antibody targeting the HER2. It has a cleavable linker, which is linked to a cytotoxic molecule. So whenever we offer this drug to the patient, it is absorbed is taken up by the cells which express HER2. It is metabolized inside the cell. The cytotoxic payload is released, and this payload starts causing the DNA damage. So there were 2 studies for biliary tract cancers. One is the HERB and the Destiny, which have shown nearly overall response rates of 40 to 50% and significant improvement in overall survivals. Then there is another molecule, tucatinib, which we often combine with trastuzumab. This has also shown decent response rates. So this was a recent approval in December, zanidatamab. So this basically targets 2 different locations of the HER2, enhancing the signal, causing a more complete blockade of the HER2 signaling. So this was a trial which led to the approval of zanidatamab in December 2024. So summarizing the discussion, so whenever we have a patient of metastatic unresectable cholangiocarcinoma, first point is to look at the performance status of the patient. If the patient's performance status is very poor, we just offer best supportive care. But if patient with a good performance status, we start with immunotherapy and combination chemotherapy. Following progression, the molecular information, the molecular genomics of the patient becomes very important. So if the patient is MSI positive, we offer immunotherapy. If the patient is FGFR2 positive, we offer either pemigatinib or futibatinib. If the patient is NTRK positive, we offer entrectinib, larotrectinib or repotrectinib. If the patient is IDH mutation positive, we offer ivosidenib. And there is emerging data for BRAF mutations. Then for HER2 mutations, almost 4 different combination of drugs have been approved, and KRAS mutations for which new drug approvals are in pipeline. Thank you.
Thank you, ma'am, for that insightful presentation. Let us take a quick tea break for 10 minutes and refresh ourselves. We shall continue with panel discussion after the break. Thank you.
the complexity of the anatomy in handling these tumors and their biology. And also there is a lack of robust evidence. Though these tumors, a lot of standard procedures are there, but they don't have, none of them are standard, finalized or established kind of thing. It's still a lot of institutions, they practice their own protocols kind of thing or individual experience kind of protocols. So obviously these tumors will require a multidisciplinary approach for better outcomes. Coming to case 1, it's a 65-year-old male, diabetic and hypertensive, presented with painless progressive jaundice and pruritus of 4 weeks duration. The bilirubin was 12.2, ALP 450 and CA 19-9 is 440. Ultrasound, there is a bilobar biliary dilatation with normal distal CBD. How to proceed further?
Sir, we will first consider doing a baseline investigations like MRCP to localize the lesion, whether it is distal or hilar stricture causing the bilobar IHBRD. Based on that, we'll proceed with the ERCP and diagnostic biliary brushings, and then proceed with the biliary stenting because there is a high bilirubin levels. The preoperatively to decrease the bilirubin levels.
Okay. So what about, next imaging, which is a preferred imaging for you? Is it a CV, CT abdomen, triphasic or MRI, MRCP?
CCT abdomen, we will consider if it is like a metastatic. Otherwise, for procedure, pre-procedure, we want to see the MRCP for, we are planning ERCP.
Sir, surgeon perspective.
Yeah. I think in this patient, elderly male with high jaundice and CA 19-9 is significantly high. I think first attempt should be made for a cross-sectional imaging to rule out distant metastasis rather than localization of the lesion. So I think a good triphasic CT scan liver would be in the first in order to rule out metastasis.
Okay. The imaging wise, it's a 2.8 centimeter enhancing mass at hepatic hilum, type 3A, involving the right duct also, with no evidence of vascular invasion or distant metastasis, enlarged periportal lymph node, with the liver volumes right lobe 65% and left lobe 35%. The performance status is good. How to proceed further?
So,
okay. Surgeon's question. Would you like to keep this case in MDT or directly would like to take upfront surgery?
When we have a imaging which is very clear that there is no vascular involvement and with lack of a very good scientific data to tell us about the benefits of a neoadjuvant setting in the intent of cure, the only reason for me to think of a neoadjuvant therapy here after doing discussing with the radiologist would be because of the size of the lesion. A 2.8 centimeter lesion onto the right side of the duct. So the right artery and portal vein could be a blur. If this CT scan is correct after having discussed, then if patient is a good surgical candidate, as you have said, the performance status is also good. So then upfront surgery would be the initial choice after getting down the bilirubin and improving his nutrition if required.
How do you prepare this patient for surgery, sir?
So we will plan ERCP and Y stent to be placed at hilar region, sir.
Okay.
And consider decreasing bilirubin over a period of 2 to 3 weeks, bilirubin to drop less than 3 milligram per deciliter.
Do you consider any portal vein embolization in this patient?
Not necessarily, sir, because of the size of the tumor.
This is, I think this is a straightforward procedure, so there won't be any need for portal vein embolization. Volumes are also adequate. Most probably, upfront surgery will be justified for this patient. What would be the extent of surgery in these patients? Surgeons. Yeah. Sir.
I only have to tell. So this will be a standard extended right hepatectomy with caudate, including the caudate should be the stand of choice with level 2 lymphadenectomy.
This patient underwent surgery. It is the final pathology report is T2 N0 M0 resection, and resection was R0 resection. Would you like to give adjuvant therapy in this patient? If you want, what kind of regimen?
Yeah, so definitely when considering the patients of BTC post-resection, so in this setup, definitely I would like to go ahead with adjuvant capecitabine monotherapy. So that's what I think we have robust evidence for capecitabine monotherapy.
Okay, coming to case 2, okay, that is a case, a straightforward case of upfront surgery followed by adjuvant therapy. Okay, this case 2, it's a 56-year-old male with no comorbidities, presented with pruritus for 3 months duration. The LFT bilirubin was 4.2, ALP 604, and the CA 19-9524. Imaging wise, there is a 4 into 4.5 centimeters mass in segment 8 and 4 with right lobe atrophy, which is involving the right duct, suspicious infiltration of portal venous confluence mainly on the right side, with enlarged periportal and retrocrural node. The volumes of liver was right side 44 and left side 56%. No distant mets. It's a locally advanced tumor. How do we proceed next? Will you go for a neoadjuvant for surgery, the CT or CRT, or upfront surgery?
The primary, what exactly? The primary being? Primary
location right lobe, I mean segment 4 and both lobes, segment 4 and 8. Involving right side portal, I mean suspicious infiltration of portal venous confluence.
So when we talk about the role of neoadjuvant chemotherapy in any of the BTC entities, we don't prefer neoadjuvant chemotherapy at all. We don't have robust evidence, that's what I feel.
There is no role of any neoadjuvant radiotherapy in any of the biliary tract cancers.
Okay.
The only setting where radiation oncologist comes into place in gallbladder cancer, particularly in a post-op setting, particularly in node positive and R1 resections. In intrahepatic and extrahepatic cholangiocarcinoma.
Any role of in gallbladder cancer, neoadjuvant radiotherapy,
no,
along with chemo?
No, no benefit.
No at all, as clinical trials are there?
In neoadjuvant setting, no.
Okay, yeah, thanks. Okay. What about biliary drainage preoperatively?
What is biliary?
Surgical surgeon.
We have to train the right system.
4.2 bilirubin.
Yeah, but it is not that high bilirubin. There is no evidence of cholangitis.
No evidence of cholangitis.
Yeah, and still biliary drainage is required because to prevent cholangitis if surgery is planned.
Okay. Sir, what do you prefer? Do you want to go with any
So
new
here,
plan?
if you look at the numerical value of the bilirubin, preoperative bilirubin may not be required. But there are many other things in this. One is the portal vein confluence is almost involved. So you are looking at a possibility of a portal vein dissection and reconstruction. In such cases, there is good evidence to show that a preoperative biliary drainage, that to a PTPD, both segments, will help in a long way in giving a good post-operative outcome if at all you end up doing a portal vein reconstruction. So here the bilirubin alone should not be there. One thing, when the portal vein reconstruction is required, the OTPT is very high and his initial presentation is only pruritus. So all these things make sense to have a biliary drainage in this patient.
If you go for upfront surgery, what is Dr. Kaushik? This kind of locally advanced diseases where suspicious involvement of the portal vein and bile duct, centrally located tumors.
Yeah, I would not prefer an upfront surgery in this patient, especially with the confluence involved. I'm not very comfortable with going with an upfront resection for this patient.
Okay, then what is your plan then?
I would consider an neoadjuvant chemotherapy.
And how long do you consider? And when will you go for reassessment? And
After 3 to 4 cycles.
3 to 4 cycles. Sir, your opinion about
So,
neoadjuvant?
neoadjuvant, yes, it has to be done only on an experimental basis because we do not have a decent pathological response in biliary tumors. Even if you think that we do a neoadjuvant therapy, at least you should do 6 to 8 cycles. And even if you feel that the margins are free from the portal vein reconstruction will not be escapable. So this patient will end up. So the resectable criteria would be definitely upfront surgery if he is a surgically good candidate with preoperative biliary drainage will be on the cards. The resectable criteria would be, one is, once we do an assessment, I always use the intraoperative ultrasound to reconfirm the extent of the portal vein involvement at the confluence, how much of the length of the reconstruction we have got. Arterial involvement, we make sure it is not there. Otherwise, if arterial involvement is there, it becomes a predicament for inoperability in these conditions. So those will be the resectable criteria.
Sure. Yes. So, if you are speaking about this particular case, when we encounter such type of cases, definitely we would put in MDT and discuss with surgeon. Really, if he feels that it can be made resectable by the upfront neoadjuvant chemo use, then on an experimental basis, yes, we don't have robust data to support any neoadjuvant chemotherapy regimens as per any recommendations, but definitely yes, we have some agents in our hands like gemcitabine plus oxaliplatin based regimens or few other regimens as well, which will give us good response rates. But if you think on recommendation based wise, yeah, that's what is the dilemma.
Just one addition, neoadjuvant chemo for this biliary tract is not very robust, but some evidence from gallbladder,
yes.
you can assume that. And second thing, for specifically intrahepatic cholangio, there is now evidence coming up for hepatic arterial infusion chemotherapy, especially for unresectable and with liver limited metastasis also. Maybe we can consider that as an option, because especially all these intrahepatic cholangio are predominantly artery supplied tumors. So HAIC is one option which we can consider.
So gallbladder, definitely yes.
Yeah. Here after, discussing with the multidisciplinary team and after counseling the patient, finally patient accepted for upfront surgery. So we did right extended hepatectomy with portal vein resection and reconstruction. We sent intraoperatively frozen biopsy, margins were free, but later the final biopsy turned out to be portal vein. There is no assets in intraluminal extension of the tumor, but perivenous infiltration of the tumor. So all notes were negative. What about adjuvant therapy? Margins were negative, no portal vein invasion, but perivenular infiltration were.
Again, definitely for this case, as the patient went ahead for upfront resection and we know that they are going to do bad and end up with recurrence, so I may consider adjuvant therapy.
St. James's.
No,
What about
the data is more in favor of capecitabine.
Capecitabine, okay. Sure.
We have other agents like S1, as well as some trials were done with gemcitabine plus mitomycin, all that, but we don't have concrete evidence. That's what is the problem.
What about molecular studies and other therapies in this patient?
So the typically molecular studies will we end up in doing the metastatic setting. So as it is,
But this is a
so we don't recommend.
Just one thing in molecular studies, I know, see, to generate evidence is very difficult, but sometimes, if these patients turn out to be HER2 positive, they actually respond reasonably well to, something like a trastuzumab. Maybe upfront also you can, even before surgery.
Actually, this patient on follow-up later, after 2 months, we identified a lung lesion.
Yeah,
Initially.
so the reason to give neoadjuvant chemo is not just to downstage, but to avoid a futile surgery. In patients who progress on chemo, then you at least avoided a futile surgery. So, although there is no evidence, you can, select, selecting the biology, chemotherapy might help.
Yeah, sure. This is, sorry. Yeah. This is case 3. Sorry, 56-year-old male, diabetic, hypertensive. Patient presented with right upper quadrant pain, jaundice of 1 week duration. One episode of chills 2 days ago. He presented to ER with bilirubin level of 4.2, ALP 239, OTPT is 58 and 112, CEA was 6 and CA 19-9 was 32. Later workup, imaging wise, there was a stricture in the hilum around 1 centimeter, no mass kind of mass formation lesion, no IHBRD, no lymph node enlargement or distant lesions. And PET CT wise, it's non-avid, bile cytology was negative. What it could be, either benign or malignant. Patient is very well preserved, no complaints before, no loss of appetite and no loss of weight.
We have to rule out IgG4 disease in this patient, and it's probably benign biliary stricture, but needs further evaluation in the form of cholangioscopy and cholangioscopy guided biopsy in this patient.
Okay, maybe cholangioscopy or biomarkers. But I mean, are there any other biomarkers in this kind of CA9, CA and CA19- were normal. Our cytology was negative. No other FDG wise, PET wise also negative. Patient is very well preserved.
Yeah, I think we should rule out strictly primary sclerosing cholangitis. That's what someone was telling.
Okay. Yeah. Okay. So cholangioscopy would add some benefit in this one.
We have to rule out primary sclerosing cholangitis.
He doesn't have any bowel symptoms or any other sclerosing cholangitis features kind of thing.
So,
and in liver intrabiliary tree also no other abnormality identified, only the stricture.
So cholangioscopy will help us in diagnosing this stricture.
Yeah. One possibility is cholangioscopy may help us.
So on a practical note, what we will be doing as medical oncologists whenever we encounter this case, so MRI with MRCP, all those things.
All that imaging, finally this was the picture.
Yeah,
stricture and hilum, and an MRC, this is a hilar stricture, no mass, no IHBRD, no lymph node enlargement.
Yeah, see here, important thing is this patient reasonably middle-aged, with that bilirubin having chills,
with
well preserved, non-PET avid lesions, we should be putting more efforts to rule out benign disease, even if it amounts to over-investigation in terms of biliary brushings or cholangioscopy. Any attempt is worthwhile avoiding a major surgery in this patient.
Yeah, keeping his EAs in view and isolated hilar stricture kind of thing with elevated ALP and bilirubin, all these things, we counsel the patient, and we took him for surgery with the explanation of if it is intraoperative analysis, frozen biopsy, all these things. If it is a benign stricture, we'll do stricture removal. If it is malignant, then we'll extend the surgery. So intraoperatively, there is a stricturing kind of segment involving, it's a type 4 hilar finally. And imaging, it was only hilar, type 1 kind of thing. But during surgical exploration, it turned out to be type 4 hilar, right hepatic duct up to 1.5 centimeters, left 5 mm from confluence. And frozen biopsy turned out to be, the frozen is cholangiocarcinoma. And the margins, they said negative on frozen. So, but on final biopsy, it is R1 on the left side, left duct. We did extended right hepatectomy with left hepatococcygeostomy, and frozen margins were negative, and we have to go up to almost confluence of 2-3 segment ducts. So, but final biopsy turned out to be R1.
Yeah. So whenever we see R1 resections, definitely we would like to indulge our radiation oncologists. So to have their opinion on chemoradiation, then we go for systemic therapy alone.
Yeah, particularly in cholangiocarcinomas, particularly intrahilar, extrahilar, the evidence is very limited. So we prefer doing it in a sequential approach, but not concurrent. First, let us complete the chemotherapy and then see the patient's performance status. If he is fine and there is no disease elsewhere, then we would do a adjuvant radiation of around 50 grain.
If it is R0 resection,
no role.
Node positive.
Node positive, yes.
Obviously.
But again, the benefit is again in node positive only in gallbladder cancer. In cholangiocarcinoma, only locoregional control benefit.
If it is R0, N0 disease, no radiation.
No radiation.
If it is R1, N0 also radiation. If R1, N0, radiation.
Yes, yes.
N1, N plus also radiation.
Yes. Only
Chemo
node
followed
positive
by
and
radiation.
Yeah, in essence, any node positive will be receiving chemotherapy as well as radiation. R1 will go for both again. I think that's
Okay, thank you. This is another case of a 47 years old female presented with right upper quadrant pain and jaundice of 2 weeks duration. Bilirubin was 2.2, ALP is near normal, I mean slightly elevated, and CA19-9 was 132. And imaging, there is a mass replacing the gallbladder with the liver infiltration, infiltrating segment 4 and 5, abutting hepatic flexure and duodenum. With enlarged periportal lymph nodes and retroduodenal lymph nodes, no distant metastasis. Looks like seems to be locally advanced disease. What is your call?
Yeah, very lucky to have him still in the operative radar, but he would be requiring a multivisceral resection, but only after paraiotic sampling frozen, because gallbladder cancer involving colon, unlikely that it will not be a metastatic disease.
Yeah. So here definitely we would like to go ahead with neoadjuvant as we have got some evidence for gallbladder neoadjuvant. So typically what we will be doing is at least 2 to 3 cycles of gemcitabine based regimens here. So gem-cis is the ideal combination what we go. Wherever cisplatin if not eligible for, we will be replacing with carboplatin or the oxaliplatin as well. So typically give 2 to 3 cycles of neoadjuvant followed by response assessment, then take up for upfront surgery, because in this setting we have got little evidence.
Also would prefer neoadjuvant chemo in this patient, and just wanted to ask, what is your opinion for GemCis? And now I've seen a few people adding nab-paclitaxel with GemCis, nab-paclitaxel.
Yeah, so the robust data is in any of these cancers we have got the most data is from GemCis. So gemcitabine plus cisplatin. By whatever reason, if they are not eligible for cisplatin, we will be substituting with other platinum compounds. And regarding the addition, so we see in this way, do we really have any added extra advantage of triplet or like that? We don't have the evidence.
If I'm not wrong, still the current evidence suggests that nab-paclitaxel is used as an alternative when someone is not very fit for this first line gemcitabine-based therapy.
So we prefer any day GemCis.
What is response, I mean, for neoadjuvant in these kind of cases for GemCis?
The overall response rates are in the range of 30 to 35%. So that's what we look in terms of downstaging the tumor.
What would be the extent of surgery, sir, if it is downstaging or if it is progressive kind? What about biliary drainage? Is it endoscopic or here in this patient or percutaneous?
First we'll try and do ERCP plus metal stenting. Endoscopic approach first, followed by, if not feasible, then only we can consider PTBD. But considering palliative care here, we will consider placing a SEMS in this patient.
Regarding pain?
I think these patients, we know they'll be short-lived, and I would be very hesitant to do a PTBD in such patients because it will add up to their poor quality of life. So whenever we're doing the ERCP stenting for these patients, all the medical guys nowadays use the EUS, so it's worthwhile doing a celiac block while in the same sitting for whatever benefit it has.
What about role of, PTBD and how do you
Yeah,
manage these
if the
patients?
ERCP fails, then we can take him for the PTBD, sir.
How do you manage these patients with this external drainage system? Would you like to?
If there is a collection in the GB which to be drained with the persisting cholangitis, we can drain it off.
Even with PTBD, quite a few times you end up internalizing it and being able to put an antegrade stent most of the times. Very rarely you have to keep them permanently on PTBD, and in that scenario, even ERCP would not have helped.
What about, systemic therapy in this setting? Metastatic gallbladder.
So to begin with, only all of these patients, we would like to have a comprehensive genomic profiling. If finances are not an issue at all, then we would be going ahead for the systemic therapy initiation if there are no targetable genomic alterations. So ideally, we would be we would go ahead with the data from Topaz 1, and durvalumab in combination with Gemcis is one what we hope to give if there are no financial constraints, as well as Pembro plus Gemcis as well, because that is the standard of care as of now as we speak. And for those patients who are not affordable for IVO also, then we'll be going ahead with Gemcis.
Have you noticed any change with these additional, in CAGB patients, survival or prognosis after addition of these therapies?
Yeah,
recently?
definitely. So if you speak about the plain chemotherapy only in the form of Gemcis, the median overall survival is 11 months, roughly as per the data available in our hands. And when we add IVO through chemotherapy, that is combination of IVO plus chemo, definitely median overall survival has improved by 2 months. So that's what definitely it counts.
Any future developments in the diagnosis of biliary tract carcinomas, particularly where the benign versus malignancy, how can we solve them now? Like any of these liquid biopsies or something. Does it helpful?
Yeah.
Particularly such kind of benign versus malignant suspicious strictures kind of thing.
You are talking about benign versus malignant, sir?
Now, previous case what we have earlier,
Correct,
such
correct.
kind of cases before planning for surgery, is there any modality to diagnose those kind of things?
No liquid biopsy investigations available to differentiate between benign versus malignant. But at the same time, BTC is a very potential area where we would like to have all the genomic alterations in our hand, because we have many good molecules. For example, I just want to take this opportunity on this platform. So we are running a trial, phase 3 trial, global trial. So HER2 positive, that is over-amplified or HER2 overexpression BTC. So we are running a trial with Gemcis plus Durva plus anti-HER2, that is zanidatamab. So definitely, so HER2 expression, over-amplification, all that, not just that, we have many more like NTRK fusions, all that can be found by NGS testing.
Okay, this is a question, okay. Definitely the multidisciplinary approach will give encouraging results. So we should encourage because of lack of robust evidence, we should always encourage the patients to participate in clinical trials. I thank our panelists for their inputs. Thank you.
I would like to extend my heartfelt thanks to all the panelists for making this session engaging and interactive. May I request our moderator to kindly present mementos to our panelists as a token of appreciation. to Dr. Vijay Kumar sir. Dr. Santosh Narayankar sir. Dr. Venugopal sir. Dr. Kaushik sir. Dr. Rohit sir. Dr. Sai Teja sir. Thank you, sir. I would like to invite Dr. Harish Babu, Medical Head of MOI, to present mementos to our speakers. To Dr. Krishna Gopal, sir. Dr. Kiran Kumar, sir. Dr. Manoj Kumar, sir. Dr. Sarita, ma'am. Dr. Amit Jotwani, sir. Dr. Raj Bharat, sir. Dr. Praveen, sir. Thank you.
As we begin the next crucial segment on pancreatic cancers, it is my privilege to welcome the chairperson for this session, a highly respected figure in HPB and GI surgery. Please join me in welcoming Dr. Vijay Kumar sir, Clinical Director, Senior Consultant Surgical Gastroenterologist, HPB surgeon and robotic GI surgeon at Yashoda Hospitals. Dr. Vijay Kumar sir is known for his surgical precision, deep academic involvement, and extensive contributions to hepatopancreatobiliary care. I now request Dr. Venkatramana, Medical Head of Medicover Women and Child Unit, to hand over the bouquet to Dr. Vijay Kumar sir. Thank you, sir. We now begin our session on pancreatic cancers with a topic of great diagnostic relevance. It is my pleasure to invite Dr. Santosh Narayankar, consultant gastroenterologist at Medicover Hospitals, who will be speaking on the topic role of endoscopic ultrasound in the evaluation of pancreatic space-occupying lesions. We welcome you, sir.
Good evening, one and all. Now, as we are starting with pancreatic cancers, to begin with, we are discussing about the role of endoscopic ultrasound in evaluating these pancreatic lesions. Already, solid lesions has been discussed in morning session, so now we will be dealing with the role of US in pancreatic cystic lesions mainly. As we know, there is an increasing use of cross-sectional imaging for multiple reasons. There is an increasing incidental detection of pancreatic cystic lesions has been seen. So approximately around 13 to 49% of patients undergoing for cross-sectional imaging for reasons for other conditions have been incidentally detected with pancreatic cystic lesions. So as whenever these patients come to our OPDs with incidental detection of pancreatic lesions, so we have to, as a clinicians, we should need to diagnose and determine its malignant potential, because it will determine the course of the further management and treatment, because these patients may require reassurance, may require surveillance, or may require a surgical resection. So based on cross-sectional imaging alone, accurate risk stratification is difficult in these patients. And based on cross-sectional stratification, it falls short, because patients who underwent surgical procedures for pancreatic cystic neoplasms showed that 25 to 40% of patients had no malignant lesions on post-surgery, and 50 to 75% of patients had only mucin-producing lesions, but they did not show any high-grade dysplasia or carcinoma. So cross-sectional imaging has limited sensitivity and specificity for diagnosing these pancreatic cystic lesions. Hence, US with or without tissue fluid acquisition often helps in comprehensive management of these lesions. So what are the common indications for evaluating these pancreatic cystic lesions? There are different authorities have advocated different guidelines. So among these, most common is pancreatic cystic lesion which is more than 3 centimeter size. Then we have dilated main pancreatic duct, presence of solid component in the cystic lesion, associated dilatation of the pancreatic duct more than 10 mm or even 5 to 9 mm, and elevation of CA19-9. There may be associated lymphadenopathy. There may be on surveillance rapid growth which is present, and sometimes there may be abrupt cutoff of the pancreatic duct and distal atrophy of the pancreas. So any of these which are present these patients require an endoscopic ultrasound for further evaluation. So how US helps in differentiating these pancreatic cystic lesions? So it helps in determining the cyst size, whether the cyst is microcystic or macrocystic, then cyst wall, whether it is thick or thin. There may be septations may be present, there may be calcification in the center of the cyst or in the periphery of the cyst. There may be mural nodules present in the wall of the cyst wall. And also we can evaluate relation to the surrounding structures. There may be vascular involvement we can see, and we can also check for the main pancreatic duct, whether it is communicating with the cystic lesion or any of the side branches. So among these cystic lesions, we have malignant potential, then we have malignant cystic degenerations of the solid lesions, then we have non-malignant type of cystic lesions. So those which are having no risk or no malignant potential are pseudocysts, then we have congenital cysts, lymphoepithelial cysts, retention cysts, and also some of them are malignant potential carry. These include MCNs and IPMNs. And other than that, we have solid pseudopapillary tumor, which is a malignant cystic lesion. So among these, we'll discuss few of them. We have serous cystadenomas, which are very commonly seen on imaging. So usually these are the middle-aged women seen in middle-aged men with undergoing CT or MRI, and they may show a microcystic or macrocystic appearance. Even though they carry low malignant potential, but they needs to be evaluated. They typically have honeycomb appearance on US imaging, and they multiple cysts with coalescent multiple septations will be present. These cystic lesions may range from millimeters to the up to 1 centimeter or macrocystic. Sometimes SCN may be a unilocular lesion, or sometimes it may be oligocystic and with have appearance which can overlap with the MCN. And it is very difficult to differentiate them from other forms of cystic lesions. So this is a US image showing here my multiple cystic lesions of different varying sizes with separated by cyst walls, and it carries typical honeycomb appearance on endoscopic ultrasound. And it is pathognomic for the serous cystadenoma. So this is one of the histopathological image showing microcystic, multiple microcystic cysts which are seen separated by septae. It is typically seen in patients with serous cystadenomas. So next we have intraductal papillary mucinous neoplasm. These can be divided into 3 types mainly: main pancreatic duct, side branched and mixed type. So main pancreatic duct, here there will be abrupt dilatation of the main pancreatic duct associated with sometimes fish eye ampulla extruding mucin can be seen on endoscopic examination, and it is pathognomonic of main pancreatic duct IPMN. And branched duct IPMN is a result of dilatation of side branches, typically resulting in a grape-like cystic lesions on US. There may be intermediate malignant, they have potential of 15 to 70% carrying a malignant potential. And mixed type of IPMN has features of both side branch and main branch type of IPMN. So this is a US image showing IPMN, and this is a histopathological cytology showing low-grade dysplasia and high-grade dysplasia, and also the ampulla showing a typical fish eye ampulla where mucin is extruding from the papilla. Then we have mucinous cystic neoplasms, mostly in the body and tail region. They can be seen both in male and females, predominantly in male, and they are mostly unilocular and septated sometimes, and the endosonographic appearance is usually a thin-walled cystic lesion, and they carry malignant potential up to 10% of the cysts. So then we have pancreatic pseudocyst, which is very common. Usually these patients will have some history of pain abdomen or pancreatitis which is present, and usually it occurs in the setup of background pancreatitis, that is acute or chronic pancreatitis, and US evaluation shows a thin-walled collection which may have debris in the and there are no mural nodules or septations. On US also we can see features of chronic pancreatitis, and side branch ectasia and calcification may be present in the background of a cystic lesion. So whenever we have these cystic lesions, there are some concerning findings, that is cyst size more than 3 centimeters, there is a thick wall septations, there may be cysts causing bile duct obstruction, dilated main pancreatic duct more than 10 mm, and presence of mural nodule more than 3 mm are the features concerning for the malignant potential. So how can we proceed with these patients? We have US guided fluid acquisition, and which can be evaluated for the workup to differentiate between the different pancreatic cystic lesions. Even though the acquisition has a 50% sensitivity for diagnosing these pancreatic cystic lesions. So whenever we aspirate the cyst fluid, we usually evaluate these cysts for the CEA levels, then we have cyst fluid glucose levels, then most commonly these two, and also sometimes amylase levels. CEA levels are the mainly used to differentiate between the mucin producing and non-mucin producing cystic lesions, but there are no arbitrary cutoff levels, but 192 is the mark where we can consider below that are non-mucinous and above that are mucinous. But CEA levels less than 5 nanograms rules out the mucinous, and CEA levels more than 800 confirms the diagnosis of mucinous type of cystic lesions. Cyst fluid glucose usually less than 50 confirms the mucinous type of cyst. Sometimes if there are septated cystic collections are there, the fluid aspirated may not be adequate for testing for CA levels or cyst glucose and cytology. In that cases, genetic markers are important, and genetic markers like KRAS and GNAS mutations, they confirm the diagnosis for IPMN and mucinous cystic lesions. So VHL genes also confirmed for SCN. So when we aspirate the fluid, we also send them for cytopathology. In that cytopathology may show histiocytes, macrophages or neutrophils. In that it confirms the pseudocyst. If it is a glycogen-rich cuboidal cells, then it is a serous cystadenoma. Then we have mucinous epithelial cells, which can show extracellular mucin also, that confirms the mucinous cystic lesions. So when to aspirate the fluid in these cystic lesions? Cyst size more than 3. Then we have MPD dilatation. So other than that, we also have endoscopic ultrasound guided fine needle biopsy. When the mural nodules are more than 3 mm or 5 mm, we can send smaller biopsies through the 19 gauge needle under endoscopic ultrasound guidance and take biopsies from the mural nodules, which increases the diagnostic yield and detects the carcinoma in situ or high grade dysplasia in a suspected malignant cystic lesion. So whenever we encounter a cystic lesion on routine cross-sectional imaging, we have to ask history of pancreatitis. If there is a history of pancreatitis, we have to consider pseudocyst. If there is no history suggestive of pancreatitis, but concern is there that the cystic lesion has caused pancreatitis, then we have to consider USFNA again. But if there are no other main duct diameter is more than 5 mm, cyst more than 3 centimeters, change in main duct caliber or upstream atrophy of the pancreas are present, then we have to go for USFNA. So again, USFNA confirms the cytology if there is a high grade dysplasia or pancreatic cancer or suggestive of any mucin producing or IPMN type of cyst, then refer to multidisciplinary group for the surgical management or ablation. If there is no signs suggestive of malignant potential, then consider MRI in 6 months and follow up. If the cyst size is less than 3 centimeters, then we can consider them for surveillance. Less than 1 centimeter MRI in every 2 years, 1 to 2 centimeters in every 1 year MRI, or MRI can also be done, or US can also be considered in these patients, and 2 to 3 centimeters we consider whether it is a typical IPMN or MCN, then routine
surgical techniques and multidisciplinary approaches in pancreatic carcinoma. We welcome you, sir.
Very good evening to everyone. I think I see many weary faces, so I don't think I'll be taking too much of your time. And there's too much of information packed in a single day. So I know it is very difficult to grasp everything. So I'll keep my presentation simple. I'll not be going into the different types of cancers, how to manage different things. I'm restricting my talk to pancreatic adenocarcinomas. That would be my talk. And as you know, pancreatic adenocarcinoma is a aggressive malignancy. And what we are showing here, the SEER data is the latest data, which is showing a slightly better 5-year survival rate of 44% in the localized tumors. But traditionally, that was not the case. The 5-year survivals of 20% is considered the standard in pancreatic adenocarcinoma, which is localized and operated. So, radical resection that offers the best possibility of cure, and what has improved the survivals is the advent of neoadjuvant chemotherapy. So, though we know chemotherapy, it's a very aggressive chemotherapy, that is what works in these cases, that is a FOLFIRINOX or gemcitabine based, that has improved the 5-year survivals from roughly 20% to around 40%. So, but what are the prognostic factors predicting the survival after pancreatectomy? So, you do a very good surgery and you see the patient coming back within 6 months with the recurrence in the liver or some other place. So, what are the factors which decide that one? Number one, preoperative CA99 levels, a positive resection margin, lymph node metastasis, and severe post-op complications, and not administering adjuvant therapy. So, the first and last are not in the surgeon's hands, but the rest of the things I think are in the surgeon's hands. So what is the kind of surgery we do for a pancreas? If it is in the tumors in the head of pancreas, it's a pancreatiduodenectomy or the Whipple's. For body and tail, the distal pancreatectomy, and total pancreatectomy rarely in cases which are locally advanced, multifocal or multicentric, and IPNMs with invasive disease which is diffused through the ducts. So these are the kind of tumors or extensive neuroendocrine tumors. These are the times when we do a total pancreatectomy. So why all the fuss about pancreatectomy or Whipple's resection? Because of the unique anatomy. As you know, the pancreas lying in the C lobe of the duodenum. So if you have to resect the head of the pancreas, you should always be removing the duodenum, the pylorus of stomach. The CBD will be draining into the ampulla, passing through the head of the pancreas. So you have to divide the CBD, and the jejunum. So once you have resected such a thing, and you have to rejoin everything, so that makes the surgery more complex. And over and above that is the presence of vascular structures coursing through the pancreas. So standard steps, just to give a gist of why this surgery is so complex. So it is like we have described 6 steps here. So the first step is the exposure of intrapancreatic SVC. For that we have to mobilize the entire colon, that is what we call as the hepatic flexure should be mobilized, the Kettle-Brash maneuver, and then you identify the middle colic and follow it to identify the superior mesenteric vein. Okay. So there you can see it pointed with an arrow, and then the extended Cocker maneuver,